आशीष जी, यहाँ पे हमने लैपटॉप वगैरह बैकड्रॉप वगैरह लगा दिए हैं और पूरा सिस्टम चालू कर लिया है हमारा, और स्क्रीन भी चालू हो गई है। और हमारे महेंद्र जी पूरा काम देख रहे हैं ऑडिटोरियम का। यहाँ पे ऑडिटोरियम इनके हाथ में है और ये सैनिटाइजर कर लिया इन्होंने, अपने हैंड वॉश कर लिए सैनिटाइजर से। चेक चेक चेक। हेलो। चेक वन, चेक चेक। हेलो 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 हेलो। इस पे रिकॉर्डिंग चालू है क्या? हेलो हेलो। चेक। हेलो हेलो। हम्म। वही कल वाली आ रही होगी। हेलो 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 हेलो। अब देख। मुझे भेज चल। हम्म, मुझे भेज दे। हम्म। सो जा। हेलो 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 हेलो। माइक Check 1 2.
Hello?
Hello.
Hey, it's Tim Pollock.
Hello.
Hey, can you hear me? Hello? Hello?
Hello. Good morning, Dr. Palik.
Hey, it's Tim Pollock. Can you hear me?
You wouldn't be able to see me, but yeah, good morning. We'll just start in a few minutes.
All right. Do you want me to try to share my screen to make sure you can see it?
Yes, we can see. So we will play your video to begin with because that quality of sound is better. And then we'll request.
I don't have a video. I do not have a video. It's just live.
It's not a pre-recorded video.
Nope. It's live.
So you will be presenting live.
That is right.
Okay, that's fine.
But it looks like the host has disabled screen sharing. Will someone let me share my screen?
Can you just test share your screen for a minute?
It says that the host has disabled screen sharing.
Done. It's done. You've been enabled to.
Okay, there we go.
Right now.
Can you see my slides?
Yes, we can, please.
Okay. All right, great.
Yeah. So I think another 2 minutes and then probably we'll.
Okay, great. Thank you so much. Just I'll turn my camera off, but I'll be here. Let me know.
powering on. Good morning, everyone. Today is the day of Biliary Day of conference third day. For the first topic, for the first talk is on the US Extrahepatic Biliary Malignancy Consortium. I would like to invite as chairperson Dr. S.K. Mathur. He is a eminent and well-known entity in the field of surgical gastroenterology and liver transplant. He don't need any interview or any introduction. And I would like to invite Dr. Mathur sir to chair a session and invite our speaker for this session. Dr. Mathur sir. Dr. Mathur sir is the teacher of all teachers. I can say, welcome sir.
Good morning, everybody. It's a pleasure to introduce the speaker of the day, Pauli, Doctor and Chair of Department of Surgery at Harvard University. By saying his introduction is quite long. the most important part is a part of the consortium for extrahepatic biliary malignancy of the United States, which consists of 10 leading universities with the academic background, and published on this topic itself more than almost 20 articles in the leading journals. Welcome, Dr. Paulik, and nice seeing you again after the IHPBA New York conference. So please start here.
Thank you so much. Thank you so much. Can you hear me okay?
Yeah.
Okay, great. Can you see my slides?
Yes. Yeah, we can.
Okay, great. Fantastic. Well, thank you so very much for inviting me to talk. I wish I was with you in person, and I wish you the best in your conference. So as you mentioned, I'm going to actually talk about our intrahepatic cholangiocarcinoma consensus consortium, which is made up of more than 17 different institutions from around the world, representing every continent in the world except for Antarctica. This consortium has been built over the last 10 to 15 years and now has over 1,300 patients in the database on intrahepatic cholangiocarcinoma. And we've actually probably published easily over 100 papers, maybe 200 or 300 papers on intrahepatic cholangiocarcinoma. And I'm really proud of the work that has been done with these collaborators in these institutions to help us better understand this disease. And that's what I want to share with you this morning is how this consortium has contributed to our understanding of intrahepatic cholangiocarcinoma. So as you all know, most patients with intrahepatic cholangiocarcinoma present with an asymptomatic mass that is frequently found on cross-sectional imaging when they have non-specific symptoms or they are being evaluated for another reason. Frequently, a mass will be found in the liver, and then someone will put a needle into that mass, and it will be read out as adenocarcinoma. And then the question becomes, is this a primary or a secondary malignancy? And good hepatopathologists will look for biliary dysplasia, and then they will also perform immunohistochemical staining to rule out other primary adenocarcinomas such as lung, colon, or pancreas, and then look for a specific IHC staining pattern that may strongly suggest biliary epithelium. So frequently, based on the pathology, you will have a good idea that you are dealing with an adenocarcinoma from a biliary primary. But really, it is important to understand the different radiologic imaging characteristics of intrahepatic cholangiocarcinoma. And in particular, there are 3 different morphologic subtypes. The most common is the mass-forming lesion, which represents about 80% of all patients with intrahepatic cholangiocarcinoma. These lesions tend to be hypodense, and they have capsular retraction when the lesion is close to the edge of the liver. And then also they have peripheral rim enhancement. The other type of tumors are periductal infiltrating. And you can see here that there's a dilated duct with some enhancement of the ductal wall. And then also there's an intraductal growth pattern where you can see ductal ectasia and also sometimes an actual papillary mass within the bile duct itself. This would be a classic example of what a cholangiocarcinoma looks like on CT. On the early images, it tends to be hypo-intense, and then on the later images, it will begin to enhance. You can also look for peritumoral ductal dilatation. At our institution, we use mostly MRI. And this is a classic image of an intrahepatic cholangiocarcinoma on an MRI. On early images, it's hypointense. There's capsular retraction. You can see on later images, it's enhancing peripherally with central necrosis. And then you can see in panel C that around the tumor, there's peritumoral ductal dilatation. I tend to use a fair amount of PET with intrahepatic cholangiocarcinoma because these lesions are FDG avid. In about 20 to 30% of cases, it will alter your therapeutic approach. You will either find occult metastatic disease, or even if I find FDG avid lymph nodes, then I'm more likely to treat the patient with preoperative chemotherapy rather than taking them directly to the operating room. This is an example of a case that I recently operated on. This is a patient with a large tumor in the central aspect of their liver involving segment 4B and 5. You can see it's abutting the right posterior sectoral branch and completely obliterating the right anterior sectoral branch. This patient needed an extended right hemihepatectomy, and you can see the round ligament in the base of the umbilical fissure with the exposed bile ducts of segment 2 and 3 here. These are large operations, and frequently it is difficult to get a wide negative margin, as you can see here on this explant picture. This is another patient that I operated on recently, a very large tumor in the left hemiliver that is abutting the vena cava in the middle and left hepatic veins. This patient was treated with preoperative chemotherapy, and actually I gave them Y90. And then subsequently, I took this patient to the operating room and did an extended left hemihepatectomy, and they are alive about a year later, disease-free. This is a different patient that I operated on who had a large mass in their right liver with some atrophy of the right liver, who presented with biliary obstruction, and you can see a bile duct stent in the liver here, who also had ascites. Their CA19-9 was over 100,000. This patient was treated extensively with preoperative chemotherapy and had a good response of their CA19-9 and resolution of their ascites. I took this patient to the operating room and performed a right hemihepatectomy, but unfortunately, this patient recurred within 6 months and subsequently died. So these cases highlight a number of points. They highlight the technical challenges of taking out these large tumors and also reflect the difficult clinical decision-making around the potential benefit of operating on these patients. One issue from a surgical perspective is whether we should be performing an anatomic or non-anatomic resection. And this paper published from the consortium shows that there is no beneficial effect to performing an anatomic versus a non-anatomic resection. What really matters in this other paper that was published based on the consortium was that attaining a wide negative margin, ideally of at least 10 millimeters, was associated with a prolonged long-term survival. So as surgeons, it's important to get a negative surgical margin and ideally at least a 10 millimeter margin. And these, up until the 6th edition of the AJCC staging manual, there was no staging for intrahepatic cholangiocarcinoma in the postoperative setting. After resection was done, one would have no idea really how to stage these patients, and we staged them really according to how we stage hepatocellular patients, but that doesn't make any sense because these are two separate diseases. So our group, using data from the consortium again, moved forward with proposing a new staging system for intrahepatic cholangiocarcinoma that was actually adopted in the 7th edition manual and now has been updated in the 8th edition staging manual. And everyone should be familiar with the staging system for intrahepatic cholangiocarcinoma, in which T1 disease is based on tumor size, with T1A being 5 centimeters or less, T1B being greater than 5 centimeters, and then T2 disease either being patients who have vascular invasion or multifocal disease. And this staging system has been validated by our group and others and should be the accepted worldwide standard by which patients are staged postoperatively with intrahepatic cholangiocarcinoma. More recently, our group has proposed this notion of tumor burden score, which is a composite measure that assesses total tumor number and tumor size and puts this into a single number, a composite score. And what we have demonstrated using data from the consortium is that this is a powerful way to risk stratify patients. In fact, patients who have a high tumor burden score have a 5-year survival only in the range of about 20% and a recurrence-free survival only in the range of about 7%. We've also used machine learning in a separate study to develop different subtypes of intrahepatic cholangiocarcinoma based on size, CA19-9 level, and also the neutrophil to lymphocyte ratio. And you can see here in this diagram how machine learning was able to cluster 3 different cohorts of patients. And of note, those patients in cluster 3, the inflammatory ICC, had a 3-year survival of just over 1 year. So these data suggest that perhaps patients who have a high TBS or patients who have a inflammatory ICC should benefit more from preoperative chemotherapy rather than being taken directly to the operating room because their prognosis is very, very poor. But how about nodal disease? If you look at data from the consortium, even at major hepatobiliary centers, lymphadenectomy is only performed roughly half the time. But when it is performed, the incidence of lymph node disease ranges somewhere between 20 to 30%. And we know that it is very difficult to predict preoperatively who has lymph node metastases. This is a study that we published looking at a calculator or risk tool, and it performed somewhat poorly. So therefore, we advocate routine lymphadenectomy for all patients with intrahepatic cholangiocarcinoma because we know nodal status is very important prognostically. And once someone has N1 disease, that really is driving their prognosis rather than the T category factors of vascular invasion or whether the tumor is single or multiple. And if you look at data from the liver cancer study group of Japan, there is some laterality to lymph node drainage. So if patients have a tumor in the right hemiliver, one should perform evaluation of nodal basins 7, 8, 9, 12, and 13. However, if the tumor is in the left hemiliver, one should also evaluate nodal basins 1 and 3 as they can harbor metastatic disease. And interestingly, in this paper that we published in Annals of Surgery based on data from the consortium, we demonstrated that lymph nodes beyond station 12 were associated with a significantly worse prognosis as they represent second echelon lymph nodes. Currently, the 8th edition AJCC staging manual recommends routine lymphadenectomy of at least 6 lymph nodes. But if you look at data, at least in the United States, only 50% of patients have at least 1 lymph node evaluated, and only about 10% of patients have the requisite 6 lymph nodes that the AJCC staging manual recommends. Well, even after performing major resections and lymphadenectomy, the prognosis of patients remains poor. And in fact, 5-year survival is in the range of about 30%. And that's because patients recur, and they recur often, and they recur frequently at extrahepatic sites of disease. You can see here that in 50% of cases, patients recur outside of their liver. And in this paper that we published recently in JAMA Surgery based on the consortium, interestingly, 1 in 5 patients actually recurred within 6 months of surgery. And we published this risk calculator to help identify those patients at highest risk for very early recurrence, because perhaps identification of these patients would lead us to not operate on them because of their prohibitive risk of recurrence, and instead offer these patients systemic chemotherapy. This is a study, the ABC trial, the Advanced Biliary Cancer trial, that demonstrated that doublet therapy with Gem-Cis was more efficacious than gemcitabine. And then more recently, we've had several prospective randomized trials looking at adjuvant treatment with either Gemox or capecitabine following resection of cholangiocarcinoma or gallbladder malignancies in the postoperative setting. And while the Protégé trial was negative, the BILCAP trial was positive on a per protocol basis. And now many of our medical oncologists will treat with capecitabine in the postoperative setting. But I really feel strongly that the future for intrahepatic cholangiocarcinoma likely lies in targeted therapy. And that's why we routinely molecularly profile these tumors, because a subset of these patients will have an FGFR fusion or an IDH or BRAF mutation, which is targetable. And in particular, if you look now, there are specific agents that have been approved by the FDA in the United States as second-line therapy for patients who harbor an FGFR fusion. And some of these patients, as noted here in these pictures, can have very dramatic responses. So it's important for us as surgeons to get this molecular data, because as I've shown you, many of these patients, even after curative intent resection, will recur, and traditional cytotoxic chemotherapy is often not effective. So a few take-home points about molecular testing. I believe it's essential. It should always include RNA-seq, because we want to look not only for mutations, but fusions, especially in the FGFR receptor. And therefore, we still need to focus on tissue-based testing rather than free cell DNA. So in conclusion, I think I've demonstrated to you that the work from our consortium over the last 10 to 15 years has demonstrated that ICC has a high incidence and a high case fatality, with many of these patients recurring, even despite curative intent surgery. When surgery is done, the surgeon needs to try to obtain a margin negative resection, ideally of at least 10 millimeters, and a routine lymphadenectomy should be performed. Many of these patients should be treated in the adjuvant setting with capecitabine, and these patients should undergo molecular testing to identify targetable fusions or mutations that can potentially direct medical oncologists to treat them with some of the emerging therapeutics that are on the horizon. So with that, I'll conclude. And once again, I would like to thank the organizers for the privilege of allowing me to join you tonight remotely for your conference. And I hope to join you in person perhaps next year. Once again, thank you, and I'll answer any questions.
Thank you, Professor. It was an excellent talk covering the latest in the field of ICC. Can I have the comments or the questions from the floor? Sanjay Nagraj.
Question is on the start by comparing it. Very radical.
I'm not able to hear the person at the microphone. Maybe if the question could be repeated or put into the chat room. I think I can. Yes.
Can you hear me now?
Yes.
Okay. So the
If you
question is
speak
on
loudly, that would be helpful.
yeah. So the question is on the lymphadenectomy. So in carcinoma, gallbladder, and extrahepatic biliary malignancies, there is a lot of emphasis on radicality of the lymphadenectomy, adding to the result. But you seem to suggest that the lymphadenectomy here is not necessarily a part of the radicality, but just a prognostic marker for maybe helping you for further therapies. Is that correct?
Yes. So, I mean, it has frequently been debated whether there is a therapeutic benefit to the lymphadenectomy. You know, I do not think that there is necessarily a survival benefit to the lymphadenectomy. There are some patients who can recur in the hilum with nodal disease that can occasionally be bulky, leading to biliary obstruction and quality of life issues. I would highlight that we do lymphadenectomy for other GI tumors like colon cancer, rectal cancer, pancreatic cancer, not because we believe there is a survival benefit to doing a lymphadenectomy for those cancers, but we believe that it is important prognostically. So I am simply arguing that we do the same for intrahepatic cholangiocarcinoma.
Right. For one more.
Yeah, sure.
Yeah. So so the cholangiocellular variant of HCC, which also often we see nodes. How do you place that? The mixed HCC cholangio combined cancer that we see here, where do you place that in terms of lymphadenectomy?
So I think I'm having a little trouble hearing you. I think your question around is like a mixed tumor, like a hepatocholangio. So we don't operate on a lot of hepatocholangios because typically those patients have a poor prognosis. That is definitely a kind of an aggressive histologic subtype. So many of those patients present with advanced disease, multifocal disease. They never come to surgery. Then the other thing is many of times we don't find that out until, if they do get an operation, we don't find out until after the operation when the pathology tells us it's a mixed tumor. So in the rare instance where I would know that up front and I am operating on that patient, I would perform a lymphadenectomy, but that is a pretty rare instance for the reasons that I have just noted.
Any more comments or questions? Yeah, Professor Miyazaki and
Thank you, Tim. Very nice to hear your presentation. I'm very so happy. Also, I would like to ask one question about you strongly recommend prophylactic lymphadenectomy for all patients with ICC. If tumor is involved, one big tumor involved segment 4 and segment 5A, at that time, what kind of lymphadenectomy are you, do you recommend to that kind of patient?
So I think I hear, so your question was basically if it involves like segment 4 and segment 5.
Yeah, one big tumor.
Yeah. Yeah. So I would probably, do a lymphadenectomy of like, stations 8, 9, 12, and 13 is usually what I do. I know technically, like if it's in 4B, it's in the left liver, but I probably wouldn't chase stations 1 and 3. That's typically what I would do.
You do not recommend lesser curvature lymph node adenectomy. It's not required.
I do recommend lesser curvature lymphadenectomy when the tumor is in the left. Again, like I guess if it's in segment 4B, it's technically in the left. So you could argue doing a lesser curvature lymphadenectomy. I'm just telling you, in reality, what I do, if I'm doing an extended right, then I usually take, maybe 7, 8, 9, 12, and 13. Do I chase it all the way up to like, the GE junction and go after station 1? I typically don't.
Okay, thank you.
Yeah. Please. There are another question coming to you.
Okay.
Tim, this is Milind Jaipur. Thank you for a very nice talk. So you mentioned molecular profiling. At this time, I don't know that most patients who have surgery undergo molecular profiling for cholangiocarcinoma. I'm glad you're advocating it. Is this something now that you're recommending it for all surgical patients that they should undergo molecular profiling? And what pitch would you give them as far as why should it be done?
Yeah, so I do recommend it, and we do it. And I think that's for the first part of your question, if I could hear you. And I thought the second part is why should it be done? And I think the reason it should be done is because look at the data I presented. I mean, the risk of recurrence is high. I mean, if you look at data from the consortium, within 2 years, 50% of patients will recur. And 1 in 5 patients will recur within 6 months. And if they do recur, what are you going to do? You know, many of these patients aren't going to get a repeat operation. This isn't like colorectal liver metastasis where people are getting second and third hepatectomies. They're typically going to get chemotherapy. And right now, GemCis is not exactly something that's been associated with a high response rate. And so they may initially respond to that, but many of these patients, may need second or third line therapy. And if they have an FGFR fusion or they have an IDH1 or IDH2 mutation, I would want to know that because those are very targetable. And the data would suggest that there is a subset of patients who can have a very good response. So that's why I recommend it.
Dr. Pawlik, in continuity of the previous question, now the molecular profiling, do you recommend it as a preoperative biopsy, pre-surgical biopsy, image-guided biopsy of the tumor?
Yeah, many of these patients will have like a core biopsy beforehand. And if they do, and we can get the molecular profiling off of that, then we'll do it. But at the minimum, if I'm planning on operating on the patient, then we can do it based on the specimen I take out.
My question to you is that if it is a pre-resectional molecular profiling, and they are positive, and will you recommend a new adjuvant setting chemotherapy or the targeted therapy in that situation?
Yeah, so that's a good question. So it right now, if they're operable and they have a solitary lesion and they do not have any evidence of extrahepatic disease, whether that be, other organs or lymph nodes, then I would still take that patient to the operating room and take it out. If they have multifocal disease or they have extrahepatic disease, even nodal disease, I would treat them with preoperative chemotherapy, most likely GemCis. And if they had stable disease or responsive disease, I would operate on them. If they have progressive disease, then we would move to second line therapy like targeted therapy. If the patient presented with borderline disease or inoperable disease, and I was looking for a response, then we probably start off with GemCis or GemOx, but then move to second line therapy if they did not get a good response and we needed a response. There is a clinical trial that's going to be opened in the United States now, looking at randomization of patients who have operable disease of intrahepatic cholangiocarcinoma to upfront surgery versus neoadjuvant chemotherapy. So I think that we're beginning to think and move towards, even in operable cases, should we be adopting kind of like a pancreas adenocarcinoma paradigm, where nowadays even people come in with a clearly resectable mass in the head of their pancreas. I treat all my patients with neoadjuvant chemotherapy for pancreas cancer. And I think we're starting to have a conversation. Maybe we should be doing that for intrahepatic cholangiocarcinoma, because it seems to be a very aggressive tumor.
Thank you, Professor Paulik, for a very informative talk, and we'll close this session. Professor Kapoor, you want to? Okay. Thank you very much.
Thank you, Dr. Palik. Thank you very much for joining.
Thank you, Dr. Kapoor. Thanks, everyone. Have a great conference and hope to be in person next year. Bye-bye.
Bye. Bye.
Okay, bye-bye.
I requested Anand to allow me to be here to introduce the next chairperson because whatever little ABCD of molecular biology I know today, I don't know up to Z, of course, is because of two persons, my former colleagues in SCPGI Lucknow, where I was working before I came to Jaipur. One was Dr. Suraksha Agrawal, but she could not be available. I wanted both of them to chair actually this talk. The other is Dr. Balraj Mittal. He was my scientist colleague, and he is the most published and most cited scientist on gallbladder cancer from India. Dr. Balraj, can we see Dr. Balraj on the screen, please? Good morning. Good morning. Thank you. Thank you very much. So I hand over the chair to you. Please introduce Dr. JaVale and chair the session. Thank you.
Okay. So thank you, Dr. Kapoor. It was a great pleasure to join at this conference. So in this session, I have to introduce Professor JaVale. So it is my great pleasure to introduce our next distinguished speaker, Professor Milind JaVale. He is presently the Hubert and Oliver Stringer Professor of GI Medical Oncology and attending physician at MD Anderson, Houston. Dr. JaVale is also the chair of NCI Task Force of Hepatobiliary Cancers. Dr. Milind JaVale is the product of the GMC Mumbai, and he did his residency at SUNY Buffalo. He is now a researcher on gastrobiliary cancer for more than 2 decades. Currently, he is also closely associated with novel targeted therapies in cholangiocarcinoma, which have provided some novel insights into the treatment of the deadly cholangiocarcinoma. Dr. JaVale has also done seminal work on gallbladder cancer, which is the gallbladder cancer, which is one of the major gastrobiliary cancer in the Indo-Gangetic plains of India. So today I invite Professor JaVale to speak on the molecular and immunological profiling of gallbladder cancer. Dr. JaVale, please.
Thank you very much, Dr. Mittal. It's indeed an honor to be introduced by you and to be here with Dr. Kapoor, who I've known for the past decade.
Yeah.
So when he invited me for this meeting, it was hard to say no, because I look forward to always collaborating with him and his group.
Sure.
So my talk is entitled Molecular and Immunoprofiling for Gallbladder Cancer. And my disclaimer here is that gallbladder cancer is somewhat a poorer cousin of cholangiocarcinoma, where molecular profiling, targeted therapy has made great inroads. And I hope that will soon occur in gallbladder cancer as well. So the history of profiling for gallbladder cancer is limited. And I'm going to present some of the data from our group. In the past, profiling generally consisted of HER2 immunostaining, KRAS mutations, and one of the first studies for molecular profiling was not conducted more than about a decade ago. So this is the outline of my talk. I'll first describe molecular profiling in biliary cancers with a focus on gallbladder. I'll talk about targeted therapy, some of the recent advances. A lot of this will be discussed by my colleague, Dr. Eliuri, in the next presentation. My focus will be a little bit on gallbladder and what we achieve with targeted and immunotherapy. Gallbladder cancer is a disease of ethnicity and geography. So we'll discuss differences amongst population, both for cholangiocarcinoma and for gallbladder cancer. And then finally, I'll conclude with immunotherapy. So this was one of the first studies that was conducted by a group back in now almost 10 years ago. It used an old platform called Sequinome, where we look for hotspot mutations. So hotspot mutations are mutations that are seen against a normal genetic milieu of gallbladder cancer. So this was a study conducted with my colleague, Dr. Ivan Rua, who's a well-known pathologist from Chile. We had 72 cases. Most of them had hotspot mutations. This is no longer used. Now we use NGS. At that time, a very few patients had NGS. And the results of this profiling are indicated below on the left of the slide, where you saw some TP53 mutations, rare but still present KRAS mutations, abnormalities in the PI3 kinase pathway. So this showed, first of all, that somatic mutation profiling from gallbladder cancer was possible. Most of these cases were surgically resected gallbladder, but there were some that were biopsies obtained from metastatic sites. Interestingly, as you may see at the bottom of the slide, we saw some cases who had HER2 amplification, and HER2 amplification occurs in about 10 to 15%. EGFR mutations, similar to mutations that you see in lung cancer, occur in about 5%. So in these early stages, like a decade ago, we started using these therapies in our practice. So these are some of our cases in my practice. On the top, slide 8, is a woman I'd seen from an Indian lady who lived in Sugarland, a suburb of Houston, who had a gallbladder cancer. You see it infiltrating into the liver. It was inoperable. She had an EGFR mutation and had a very nice response to an EGFR inhibitor, erlotinib, rarely used now, which lasted for almost a year. At the bottom, that is slides B, is a patient who had HER2 amplification. And this patient was treated with FOLFOX and trastuzumab, which showed a very nice response, and actually ended up having a resection. Although this was a T4 tumor extending from the gallbladder into the underlying liver, because of the nice response, she had surgical resection and did well thereafter for a couple of years, and that disease recurred and progressed thereafter. So these early experiences, now almost a decade ago, showed that targeted therapy for gallbladder cancer was possible. So meanwhile, the next generation sequencing or exome sequencing, that is sequencing of the protein coding portion of the genome, these efforts began around the world. These were two pioneering studies in cholangiocarcinoma. On the left, you see a study from Johns Hopkins, where they looked at intrahepatic cholangio. And on the right, you see a study from the Singapore National Cancer Center of Singapore, where they looked at cholangiocarcinoma in the face of liver fluke infection. Both of these studies showed that cholangiocarcinoma, this is not gallbladder cancer, were enriched with a large number of actionable mutations. So these mutations could then be targeted with targeted therapy. So this led to one of our real life studies. So this was a study that we did with MD Anderson, a former colleague of mine from Ohio State, Dr. Saab, and Foundation Medicine. So we looked at about several hundred patients. So we had 412 patients with intrahepatic cholangiocarcinoma or ICCA. We had 57 patients with extrahepatic, it's called ECCA, and then 85 with gallbladder cancer. So gallbladder cancer is relatively uncommon in the US, about 5,000 cases a year. And we saw for the first time that the pattern of mutations differs between ICCA, ECCA, and gallbladder cancer. ICCA, or intrahepatic cholangio, as was discussed in the previous talk, has a large number of actionable mutations. In fact, 50% of patients. So that like FGFR fusions, IDH mutations, MET amplification, HER2 amplification. Extrahepatic cholangio looks really like pancreas cancer with KRAS and CDKN2A. Now, the low-hanging fruit in gallbladder is HER2 amplification. So in this study, it was 16%. Almost a number, this HER2 amplification is the degree that you see in breast cancer. So this constitutes an opportunity for that relatively modest number, 16%. And as I will describe, there are many other such opportunities that have come down the road. So this study, now conducted in 2016, was one of those which showed that next generation sequencing has the capability of altering the trajectory of biliary tract cancer. So this is again represented graphically in this cartoon generated by my former fellow. And you see gallbladder cancer, that's in the green, has EGFR, HER2, HER3 or ERB3, for which now we have targeted drugs, PTEN, PIK3CA. These are genes for which drugs are not necessarily approved, but certainly in development, and some look promising enough that I think they will see it through the finish line. So this was a study that we conducted with HER2 amplified tumors. So this is a large basket study where we look at different genetic alterations of different cancers. So we looked at HER2 amplification for all cancers. And in that, we isolated about 40 patients with gallbladder cancer who had HER2 amplification. They were treated with trastuzumab and pertuzumab. So this is a combination now commonly used in breast cancer. And we saw that the response rate was 23%. But more importantly, these responses were deep and long lasting, so over 8 months. So this drug was therefore now approved by the NCCN and is a part of the NCCN guidelines for treatment of gallbladder cancer with HER2 amplification. An exciting new agent, which I hope will be perhaps the first agent to be approved for gallbladder cancer by the FDA. The pivotal trial is now complete. It's called zanidatamab. So this drug is actually, it has a bispecific domain. It targets HER2 by the trastuzumab binding domain and the pertuzumab binding domain. It's an irreversible inhibitor. And then it resulted in a phase 1 study of 40%, a disease control rate of 65%. More importantly, patients who had previously been treated with trastuzumab or Herceptin responded to this agent. So this study has now completed an over 100-patient pivotal trial led by my junior colleague, Dr. Shubham Pant. And this trial will be hopefully published next year. And we hope that this will lead to an FDA approval, probably the first drug to be approved by the FDA in gallbladder cancer. Keeping our fingers crossed. But as you'll hear from Madhu's talk later this morning, the trajectory in biliary tract cancer for new drugs has been very rapid and really quite thrilling. So if you see in this table here, before 2010, we used really 5-FU, gemcitabine, because there's nothing else. There was really no drug FDA approved till 2020. We used gemcitabine and cisplatin based on compendia listing. So there was a positive study with gemcitabine, cisplatin, which was superior to gemcitabine. But since then, several drugs have been FDA approved. So in the last 2 years, we have 5 drugs that are FDA approved. And this is an unprecedented trajectory for any GI cancer. And that has led to first excitement in biliary tract cancer. I have to point out that all of these agents, 4 out of these 5 agents, are approved based on molecular profiling. So pemigatinib, infigratinib, ivosidenib, puripatinib, these are FGFR or IDH targeted agents, and they were basically approved because of molecular profiling. So molecular profiling is complicated, it is expensive, but it has yields in cholangio. Durvalumab is the first immunotherapy to be approved, and I'll briefly review the data as regards to gallbladder cancer in my presentation, but just to show that there is great value in molecular profiling in biliary tract cancer overall. Now, in the next couple of slides, I'm going to discuss the differences in molecular profiling across populations. I'll first talk about cholangiocarcinoma because there's more data, but I'll also refer to gallbladder cancer, where we have some early data. So these diseases, as you know, have a very wide range of distribution. Cholangiocarcinoma, you see in green, are the areas of high incidence, like China, Korea, Thailand being the highest, Japan. So these diseases are mostly common in Asia, less common cholangio in Western world, somewhat less in India as well. But I'm seeing more Indian patients because of the epidemic of NASH and fatty liver. What are the molecular differences between cholangio that occurs in Asia and cholangio that occurs in Europe? So we conducted 2 studies, one for cholangio and one for gallbladder cancer, with a very prolific group in Shanghai, using the same platform. So these were same genetic platform. We looked at what are the differences between the patients in Shanghai and patients at MD Anderson. So as you can see in this figure, you have the top 10 lists. You have some that are more common in the US, some that are more common in China. Overall, this study showed that there is a higher tumor mutation burden in Asian patients. So perhaps that's why immunotherapy works a little better. But in the West, we have more targetable mutations. So we have more IDH mutations, FGFR mutations in the West. Also, the pattern in India is somewhat similar to what you see in the West with cholangio, but there's very few data. So this shows that although a lot of the medical literature is based on their data from the West, this is not necessarily applicable across populations because we have to do our own studies in India. Profile of gallbladder cancer looks like in India. So the largest study I think we did was a comprehensive genomic profiling of gallbladder cancer, which was published a year ago, led by by a junior colleague who is now worked for the Cholangio Foundation. So this was a comprehensive genomic profiling of gallbladder cancer across several centers in the United States. Most of them used the Foundation Medicine platform. Some of them were using our MD Anderson platform. So there were 760 tumors. And out of them, 69% of these patients were female. The median age was 64 years. 50% of them were from primary sites, like resected gallbladder, and the remainder were from metastatic sites. So this relatively large study using targeted genomic platform showed that gallbladder cancer has a large number of actionable mutations. So on the left, you have actionable mutations, and then on the right, they're non-actionable genes. I would caution the group that these actionable genes don't necessarily have approved therapies, many of them, but some of them have trials going on. And specifically, we noticed that there were mutations in like ATM gene, BRCA gene, ATR gene. These are genes involved in DNA repair, which seemed like an interesting finding. So we probed deeper and took a little deeper dive into these DNA repair genes. So these DNA repair genes can be divided into direct DNA repair genes, that is ATM, ATR, BRCA, Fanconi anemia. So these are genes that are often inherited, or called germline, but not always. They could be in the tumor itself, called somatic. And then the TCGA, that is the Cancer Genome Atlas, also describes caretaker genes, which don't necessarily have a targetable mutation, but play a role in DNA repair, like PP53. So this study showed that 14% of patients with gallbladder cancer had abnormalities in the DNA repair genes, the direct DNA repair genes. These are targetable with PARP inhibitors, with cisplatin, and this 14% number is the highest seen in any GI cancer. So I think for gallbladder cancer, this, besides HER2, is a low-hanging fruit, where perhaps we can target these genes with specific DNA repair inhibitors. Because these DNA repair inhibitors are associated with a high tumor mutation burden. So when you have a high number of tumor mutations, there's a more likelihood of targeting these therapies with immunotherapy. So this is a figure that is basically a map of all the DNA repair genes. On the top, you see a listing of direct DNA repair genes and what are the associated mutations which are reflected on towards the bottom. So you first see that there is no characteristic pattern of the associated genes. There are really all over the map, but there is certainly a segment of patients who have this direct DNA repair genes that can be targeted with therapies. And I illustrate this here. This is a patient who had this big mass extending from the gallbladder into the liver. And this patient had a PAL-B mutation. PAL-B is partners of BRCA2. So it's a DNA repair gene. So as you know, with various mutagens, you have damaged DNA, and you require these genes to repair the damaged DNA. If you have abnormalities in the DNA repair genes, then the DNA damage continues and leads to carcinogenesis. This can be targeted with another DNA repair inhibitor, or a process called synthetic lethality. So this showed that it was possible to target this in practice. So we have an ongoing study, therefore, for patients with gallbladder cancer and biliary tract cancer who have these sort of DNA repair genes that can receive the DNA repair inhibitor, olaparib. Now, in terms of gallbladder cancer, this is a paper that I did recently with Dr. Kapoor, and which looked at the basically in Nature review of gallbladder cancer. But I was fascinated by the map because I didn't know that some of these countries, the high incidence countries, now seem to be increasing here. You see some places in East Africa, some places in East Europe, Central America, islands in East Asia, which have a high incidence of gallbladder cancer. So the question is, how does the gallbladder cancer differ between the West and the East? So this was a study that we did again with our partners in China. So you will see two figures here. One on the left is the Chinese patients, and the one on the right is the US patients. So even at a high level, a bird's eye view will show that there's a larger number of mutations in the Chinese patients. So the color codes, they start for mutations or amplifications, truncations. But overall, there's just a higher mutation burden in Asia. And these differences between the Asian patients and the Western patients are reflected here. Now, when you take a deeper look at this, there seems to be a higher burden of HER2 mutations and amplifications, higher burden of DNA repair mutations in China than it seems in the Western population. So if you look at specifically, we look at EGFR and HER2 and HER3 mutations, we found that there were more frequent mutations in the HER family in the Chinese patients. So why does this have any implication? Well, when we design international clinical trials, for instance, with targeted therapy, we know which population is most likely to yield benefit. And interestingly, this is a hypothesis of mine, which I don't know it's proven. I feel like HER2 amplifications in gallbladder cancer have a somewhat more indolent history. Now, you may, unlike breast cancer, where they have a more aggressive prognosis, this can be seen in our study in terms of pathological differentiation. So HER2 amplification was associated with a better grade, well or moderately differentiated tumors, and poorly differentiated tumors were in the HER2 wild. I don't know if it's proven. These are really small numbers and stand open to debate. Now, I'm going to refer here to one study done in India by Akhilesh Pandey's group, very interesting study where they looked at a sample of patients from Japan, Korea, and India, and they did a wide analysis. They looked at exomes, so protein coding portion of the genome, transcriptomes, that is mRNA, and whole genomes in gallbladder cancer. They found mutations in several genes, but I'm going to focus on one transcription factor called ETS. Now, within ETS, there is this gene called ELF3, which is associated with high neoantigen burden. So, in fact, they showed that with patients with the ETS gene or ELF3 gene mutation, they have a higher number, they are associated with TP53. You see the yellow figure in the middle is ELF3 gene and TP53. They have a higher number of neoantigens. Higher number of neoantigens mean more likelihood of response to immunotherapy. So while I've described several molecular profiling studies earlier, I think there is a segment in gallbladder cancer that can respond very well to immunotherapy. So in the next portion, the next few minutes, I'm going to talk about how do you immunoprofile. And actually, one of Dr. Kapoor's former students is now working in our lab, and this is what she's working on. How can we immunoprofile patients better to understand the role of immune checkpoint inhibitors in biliary tract cancer? That's the area that she's working on. So another quick reminder that the interaction between the T cell and the tumor is prevented. So that's why tumors are cold by the PD-1 and PD-L1 interaction. So this checkpoint prevents the T cells from interacting the tumor and eliciting an immune response. But these are not the only checkpoints. So there are several others that are listed here. And at this time, we're looking for biomarkers of these checkpoints by immunohistochemistry and mRNA profiling. So that's basically what we are doing in the lab. So Anderson, we have a method of immunofluorescence to assess the immune cells in the tumor. So there are a set of 10 markers that look at PD-1, PD-L1 markers, T cell markers. These are then assessed in the tissue. These are analyzed by a vector scanner, and then there's an image analysis software, which looks at these immune biomarkers. So these biomarkers, this report not only shows us what is the expression of these immune biomarkers, but where are they actually localized in the tumor cells, in the lymphocytes, what is the level of interaction in the two. And these are preliminary researches to see how these could be related to outcome from immunotherapy. So I'm going to present some data on intrahepatic cholangio, where we have done most of the work, and then some evolving data in gallbladder cancer. So we looked at about 100 patients with intrahepatic cholangio, which were resected. We looked at the mutations. So on the top, you see the mutations. And then you see the immune profile. That is a biomarker that I showed, the markers. So this checkered mosaic pattern, as you see below, clearly shows there's no great correlation between the mutations and the immune markers. So we don't see any correlation between these markers. However, we saw that immune markers are higher at the tumor periphery than at the center. And in fact, there is some correlation with survival. If you look at CD4, CD3, TIM3, the level in the tumor, in the central tumor, it seems to have a survival prediction of these, predictive value of these biomarkers. And then we grouped all these biomarkers into different clusters. So the red is high expression and the blue is low expression. So these are grouped into what is the level, for instance, in the red of CD3 high and PD1 high. So cluster 2 is CD3 high and PD1 high. And then the green, that is the CD3 low and PDL1 high, is the cluster 3. So cluster 3 had the lowest survival and cluster 2 had the best survival. So cluster 2 is the immune-enriched cohort, the hot cohort, perhaps the immune-active cohort. As you can see, cluster 2, which we think may be immune-active, is only about 10% of patients with cholangio. So we would think that the immune therapy would work in about these 10%. These were again confirmed on RNA analysis, which showed this cluster 2, the hot cluster, cluster 3, the cold cluster. These are compared on transcriptome profiling. And this is sort of what we see in our clinic, and Madhu will discuss it further. In fact, when you look at pembrolizumab or Keytruda in biliary tract cancer, the response rate is only about 5 to 10%. So we think there's a small cluster, that is a hot cluster, that responds to these therapies. And we need to dive deep and see how we can get markers for that cluster and apply them in our clinical setting. So I'm going to briefly touch on this study, which was our first positive phase 3 study to make the point in gallbladder cancer. So recently, this year, there was a phase 3 trial of GemCis plus or minus durvalumab. Durvalumab is a PD-L1 immune inhibitor, 685 patients, studies conducted all over the world, including in India. So this study showed for the first time that we have something better than GemCis. So the survival improved with durvalumab from 11 months to 12.8 months. So you would think this is a modest advantage. However, when you look at 2 years, at 24 months, the improvement was 10 months, 10% to 25%. So clearly, immunotherapy seems to benefit a small segment of population. Now, what about gallbladder cancer? So you see in red, there were about 85 patients who got the durvalumab GemCis, 85 patients who did not get it, who just got the chemotherapy. What was the outcome in that population? And that's mentioned in this box here. Actually, if you look at the forest plot, the line, the central line, the further away you get from it, the more likely you're to benefit. In case of gallbladder cancer, it's really close, 0.94. So it's like a 6% difference between those who got immunotherapy and those who didn't. And so, at least in this study, it didn't seem like immunotherapy had a great benefit in patients with gallbladder cancer. But these are small studies. This is a small, relatively small number of patients, and the study was not statistically powered. So I understand immunotherapy is not being used commonly in gallbladder cancer at this time in India, but it is being used for all patients in the US now. So, but it does work in some patients, and I'll give you an example from my practice. This is a patient who had a BRCA2 mutation, who had gemcitabine, cisplatin, and durvalumab. On the left, you see this giant mass in the liver, right, with biliary obstruction. And I really thought she was not going to make it beyond a few weeks, but she was stented. She got chemotherapy with GemCis and Durva, and now she's in Durva maintenance, and really an amazing outcome over there. And I don't know, maybe Dr. Miyazaki would say this patient will be resected now in Japan, not quite sure, but clearly that immunotherapy may have a role in small number of patients. So in the last couple of minutes, I'm going to talk of immunoprofiling for gallbladder cancer. And this is a study done in, with 60 patients from US, 60 patients from Chile. And again, I won't dive deep into it except to show that there's some differences between Chilean population and the US population. Pooja is working on this. We'll get some more results later. And I'm going to end for the benefit in terms of running out of time here. So I think I hope I've convinced you that genomic profiling in biliary tract cancer, perhaps specifically gallbladder cancer, is feasible. It should be encouraged for all candidates. Now, the low-hanging fruits currently are HER2, EGFR, DNA repair aberration. Immunotherapy is approved in the US, but it It's not all over the world, and it needs further investigation. And it's just by enrollment in clinical trials, I think molecular characterization and pathology efforts in high incidence countries like India are going to give us the answer. So these are my collaborators. And again, I want to thank Dr. Kapoor and colleagues here in India for your kind invitation.
Thank you. Can we have Dr. Balraj on the screen, please? Thank you,
Yes.
Dr. Biliary. Thank you very much. I'm sure that your talk will stimulate and encourage some of my young colleagues to take up gallbladder cancer, which now the Indian funding agencies have recognized as an Indian cancer. Can we have Dr. Balraj on the screen?
Yeah.
Dr. Hemant?
Yeah. Hello.
Yeah. Dr. Balraj, we have some questions from the audience, and then I'll request you to make some.
Okay, sure. So,
Dr. JaVale, for a wonderful talk. I also kind of join with you and feel that this is an Indian cancer, as Dr. Kapoor mentioned, and we need a lot more Indian data. You showed us a snapshot of the Topaz 1 study, not very effective in gallbladder cancer, as at the issue 0.9 and the confidence intervals, both sides of the unity. Do you think durvalumab will also go the same way as the Merck molecule? You would be aware that just 3 days back, Merck has withdrawn his application for the use of pembro in biliary tract cancer.
So there's a study with pembro that will be published next year, presented next year, GemCis plus or minus pembro. This study, I have to make a disclaimer, was not powered to address the difference in gallbladder cancer. So I think if I said it doesn't work in gallbladder cancer, it's an overstatement because it is approved and we treat patients with gallbladder cancer now. But I think when you look at the big picture, you have to see whether, we should treat everybody like one size fits all, very expensive drug, whether this is, or we should try to find who are the patients who benefit, like those with DNA repair defects.
And I think the biomarker field predicting response to immunotherapy is still evolving, still a long way to go.
Still a long way to go. You're right.
Thank you.
Yeah, very quick question.
hello.
Need to give time to Dr. Balraj.
Yes, sir.
Hello. Any more questions from the audience?
Just one more, Dr. Balraj, and then I'll give it to you.
Okay, sure.
I am TD Yadav from PGI Chandigarh. To study by Achilles, you told we are part of that study. We had done HER2 receptor this thing, and we found only 10% positive, so could not go further. That is one. And second most important is most of the patients we are getting is locally advanced cases are metastatic. So would like to have a locally advanced. I'm talking about FNAB to have a biomarker to start new adjuvant therapy. And if suppose tumor is replaced, then it's okay by the mass lesion. But if there is some bile is present, then always there is a fear of getting bile still while doing FNAB to cut biopsy. So how do you go? Do you go endoscopic or you have some other method to have FNAB to start new adjuvant therapy, immunotherapy?
So like other diseases, we are using neoadjuvant therapy more. Sometimes between lap chole and resection, we use neoadjuvant therapy. And those who have particularly like biomarkers like HER2, we're using like chemotherapy and trastuzumab and resecting later. But it's still a minority that have any targetable actionable alteration. So most patients who are inoperable don't get operable later.
That you have talked about various therapies that are Sir, as what are the tools that are still for the therapies and for the gallbladder so that we can just work and we can develop that thing for the gallbladder. You must be operating the patients of gallbladder cancer. So how many of the patients are you finding the gallstones in those?
So, actually the authority on this is Dr. Kapoor, the stones. But, we find it over 90% of the time. But in the West, there's also gallbladder cancer with ulcerative colitis and Crohn's disease and PSC. So unfortunately, we are not doing very much with the knowledge of stones. Dr. Kapoor, I don't know if you want to highlight.
Yeah, so she asked because their group is working on analysis of stones, benign stones versus malignant stones.
Yeah.
So that's why probably she asked. So in Chile, it is almost 100%. In India, it's about 60 to 70%. And in Japan, it's about 50 to 60%. So a large number of patients with gallbladder cancer do not have stones. And my personal hunch is that these are two different pathways. I think I'll give a few minutes to Dr. Balraj. Dr. Balraj, please.
Okay. So it was really a wonderful talk.
Could you
And,
please put your video camera on, Dr. Balraj? Yes.
yeah. Yes. It's not coming.
At the bottom on the left side of your screen.
Yeah. It's coming. You can't start your video because of your.
Okay. I think we can hear you well. Please carry on.
Okay, so it was really a wonderful talk, and we are really grateful for Dr. JaVale. So he has enlightened us with the real state of the art. Actually, 10 or 15 years back, we had no idea about the molecular profiling of GBC. It was sort of a dead end for all of us. But now, as Dr. JaVale has clearly shown, that there is a great deal of development. Of course, they have most of them, they have so far not translated into the patient care, but there is real hope that we will be able to have some really good development in the coming 10 to 15 years. And also, in India also there is a like a ICMR task force right now. They have asked for good projects for particularly for the molecular profiling. But however, from India, the response has been little poor. That's why what we have to do is that sort of a awareness that so that more people are involved in particularly molecular profiling of cancer. For Dr. JaVale, I have one question because the molecular and immunological profiling of cancer, most of them have been carried out in early stages because these are sort of operable. But the cancers, in most of the cases, it in the advanced stages. Is there any difference between the molecular profiling of the early and late stage of cancer?
So we don't know, Dr. Mittal. I mean,
Okay.
we simply, I don't think that we have done, now the largest study that we showed, 50% were 50% were surgical, and the rest were advanced. My recollection, I don't think there were differences, but I don't know. I haven't really looked.
Look for that. But do you consider that it may be important for the treatment? Because most of the right now the trials are also on the early stages of GBC cancer, or do the trials have taken the late stage of
So the
cancer?
trials, the trials, Dr. Mittal, were all for advanced disease, locally advanced or metastatic.
Okay. And is there any like a gene fusion and other molecular changes in GBC also, like in cholangiocarcinoma? Any data on that gene fusion?
Data on what?
Gene fusion.
Gene fusion.
Oh, gene fusion, yes. So FGFR fusions are really seen in intrahepatic cholangio. They're not seen in gallbladder cancer. There are other fusions that are seen, for instance, RET fusions, but they're quite uncommon. They're very rare. They're more likely in intrahepatic than in gallbladder.
Yeah. So basically, the cholangiocarcinoma and gallbladder cancer, are there any commonality, or they are like a totally like a different?
Interesting. You know, I think extrahepatic looks more like pancreas, but intrahepatic cholangio and gallbladder cancer are different cancer, different mutational profiles, different patterns of spread. And unfortunately, gallbladder seems to have worse prognosis than
Mhm.
these others.
I think we'll have to close the session. Anand is waiting for me to announce that. So thank you,
Okay.
Dr. JaVale. Thank you, Dr. Balraj, for
Thank you.
joining us
Thank you.
online. Thank you.
Okay, thank you.
Thank you, sir. For the next session, will be on novel systemic therapies in the biliary cancers. For this session, I would like to invite the chairing the session, Dr. Anjali Sharma. Dr. Anjali Sharma is the first oncopathologist of Rajasthan, and she started the immunohistochemical marker study in the Rajasthan. Currently, she is working as a head of department, senior consultant, and a head of department at the Bhagwan Mahavir Research Cancer Hospital, Jaipur. And for the chairperson, I would like to invite Dr. Hemant Malhotra, sir. He is a previously, he was working as a professor and head department of medical oncology in SMS Hospital. Currently, he is a director for the Department of Medical Oncology and at the Mahatma Gandhi Hospital. I request our chairperson to invite and introduce the speaker for this session.
So thank you very much, Anand, and welcome all of you to this nice winter morning in Jaipur. The stage has already been set by Professor JaVale, and improvement in systemic therapy for gallbladder cancers and biliary tract cancers is a huge unmet need. For those of us who see advanced biliary tract cancers and gallbladder cancers, which I'm sure there are lots in the audience, it is really truly frustrating to find a patient whose general condition is okay, LFT is normal, and you still do not have any effective treatment. So I think it's a very, very important unmet need and a very important evolving field, and we look forward to the next talk. I request my co-chair, Dr. Anjali, to introduce the speaker to all of you.
Good morning all. Dr. Madhulika Eliore, who is graduate from Case University in Cleveland, Ohio. She did her internal medicine training at Duke University and is now Chief Fellow in Hematology and Oncology at University of Texas, MD Anderson Cancer Center. I invite Dr. Madhulika for her talk. Over to you.
Thank you. All right, thank you, Dr. Sharma, and thank you to Dr. Kapoor for the kind invitation to speak with you all today. I'm excited to be talking about some of the advances and novel systemic therapies available for biliary tract cancer. So as we've already talked about this morning, the problem of cholangiocarcinoma as well as gallbladder cancer is a global problem. On the left here, we see that cholangiocarcinoma incidence, particularly intrahepatic cholangiocarcinoma, has been on the rise in the United States and other countries globally. And this is due to many reasons, but more research regarding the exact epidemiologic as well as molecular reasons for this rise are to be seen. And on the right, we can see that gallbladder cancer may also be on the rise in countries like South America as well as India. However, 5-year survival remains poor across all biliary tract cancers. As we can see here, for patients that present with metastatic distant disease, the 5-year prognosis is poor at 2% survival. And as Dr. JaVale has discussed, for the past decade or more, we have only had one potential treatment for patients with unresectable or metastatic biliary tract cancer. And that has been the combination of gemcitabine plus cisplatin based on the results of the ABC02 trial. And you can see here that this resulted in an overall survival of only 11 months in these patients. And so Dr. JaVale presented data from the TOPAZ-1 study, which has presented a new line of option for patients and presents a new standard of care, which is gemcitabine cisplatin plus durvalumab. And so to go into the TOPAZ-1 study, this was a double-blind global multi-center phase 3 trial, which evaluated durvalumab in combination with GemCis versus placebo plus GemCis in patients with biliary tract cancers. And so patients in the durvalumab group received durva plus GemCis for 8 cycles and were followed by maintenance durvalumab until progression. In the placebo arm, patients received 8 cycles of GemCis alone, followed by observation. And so when we look at the baseline characteristics here, you can see that approximately 50% of the population did come from Asia, and 25% of the patients included gallbladder patients. Of note, this study included all patients, irrespective of PD-L1 status. And so when we look at this efficacy data, so compared to the data that Dr. JaVale had presented, this is the data most recently presented at ESMO. And so we can see that even with an additional 6.5 months of follow-up, that the curves remain separated between the two groups, with a 24-month overall survival of 23.6% versus 11.5% in the GemCis group, leading to a hazard ratio of 0.76. So again, this presents a new standard of care in the frontline setting for biliary tract cancers. And it has been a huge improvement and the only treatment that we have had in over a decade. And so when we look at the responses that patients had with the addition of durvalumab, you can see that most of them were partial responses. However, 2% of patients did have complete responses with the addition of durvalumab. And so in the frontline setting, we have potentially a new frontline option with the combination of durvalumab. We are also awaiting results from the phase 3 GemCis plus nab-paclitaxel, which we hope to see results from in the next year that may potentially provide another option in the frontline setting. So moving on to second line therapy. So over the past decade and until the past 5 years, the standard second line therapy has been a 5-FU based regimen, that being FOLFOX, FOLFIRI, and in Asia, an S1 combination with platinum based therapy. And here we're seeing that the median progression-free survival, again, is very limited at 2.5 to 7 months. So when we look at patients who receive multiple lines of therapy in the metastatic setting, this was a study we conducted in the US with a commercially insured population. And what we can see here is that most patients actually don't even go on to receive second line therapy in the metastatic setting, less than half of patients. And then in the third line setting, even less so, at 16.5% go on to receive third line therapy. And a lot of this has been potentially due to patient selection and lack of targeted agents for patients that can minimize toxicity and provide clinical benefit. This data was presented by Dr. JaVale earlier, but I wanted to highlight again that that next generation sequencing has really changed the treatment landscape for patients with biliary tract, specifically intrahepatic cholangiocarcinoma. And what we can see here is that the molecular alterations clearly differ between intrahepatic, extrahepatic, and gallbladder cancer, with FGFR fusions and IDH mutations enriched in the intrahepatic population compared to HER2 amplifications enriched in extrahepatic and gallbladder cancers. And so now, because of next generation sequencing, we really have a new arsenal of therapies that have been approved in the past 3 to 5 years. And so these are all of the potentially approved therapies and in clinical trials, as well as FDA approved in the United States for biliary tract cancers. But for the purposes of this talk, given the limited time, I will be talking about FGFR2 fusions, IDH1 mutations, HER2 amplifications, as well as advances in immunotherapy. And so when it comes to FGFR2 fusions, I'll be talking about 2 trials, FIGHT 202, as well as the PROOF trial, which led to FDA indications for pemigatinib as well as infigratinib. And so FGFR mutations, there are multiple mutations that can occur, activating mutations, translocations, gene amplifications. But particularly of interest in intrahepatic cholangiocarcinoma are FGFR2 fusions and rearrangements. And so FIGHT 202 was a phase 2 study which evaluated pemigatinib in patients previously treated with with gemcitabine and cisplatin for advanced cholangiocarcinoma. And so this study actually had 3 cohorts. So the first cohort included patients with FGFR2 fusions. The second cohort included those other FGFR mutations. And cohort C were patients who did not harbor any FGF alterations. And so in this study, what we saw was that patients that had FGFR2 fusions and rearrangements had benefit with 35% response rate and a median progression-free survival of 7 months and an overall survival of 21 months. However, in patients with other FGF alterations or no FGF alterations, this benefit was not seen. And so in the PROOF trial, this was a little bit a different trial in that it only included patients with FGFR2 fusions and rearrangements. This was also a very heavily pretreated population. So more than a quarter of these patients had received 3 to 4 lines of prior therapies. And again, here we can see that there was both a PFS as well as an overall survival benefit, even in the 4th and 5th line setting for some of these patients. And so while pemigatinib and infigratinib are reversible inhibitors of the FGFR receptor, we are now developing irreversible inhibitors. And so futibatinib is one of these irreversible FGFR1 through 4 inhibitors. And in this trial, in this phase 2 trial as well, we can see that there was a 41.7% response rate with a median PFS of 8.9 months and an overall survival of 20 months. And so these irreversible inhibitors are important because what we have seen is that patients treated with FGFR inhibitors, almost 75% or more do develop resistance mechanisms due to the targeted therapy. And so most of these resistance do happen because of mutations that happen in the ATP binding pocket. And so our hope with futibatinib as well as other novel agents that are being developed is that these may also be able to overcome resistance to FGFR therapies. So FGFR therapies do have some class effects. I would like to point out 2 of the most important effects that we see with these. One being hyperphosphatemia. And so with this, we can usually control it with a low phosphate diet as well as phosphate binders. And the second main class effect that we see are retinal disorders, such as central serous retinopathy. And so for these patients, ocular testing both before treatment as well as during treatment is very important. And so moving on to IDH1 mutations, I will be discussing the Clarity trial, which led to the approval of ivosidenib. And so IDH1 is necessary for the oxidation of NADP to NADPH, which then leads to the production of alpha-ketoglutarate. However, for patients who develop mutations in IDH1 and 2, there is a pathologic accumulation of 2-HG leading to carcinogenesis. And these mutations are seen in approximately 10 to 15% of patients with intrahepatic cholangiocarcinoma. So the Clarity trial evaluated ivosidenib, which is an IDH inhibitor, in patients previously treated with cholangiocarcinoma harboring the IDH1 mutation. This trial, it was interesting because it was a 2-to-1 randomization, 2-to-1 treatment to placebo, and did allow crossover from the placebo to the treatment arm at the time of disease progression. And so again, here we can see that with ivosidenib, that there was a modest improvement in the median PFS to 2.7 months. And while the objective response was lower than what was anticipated, when controlling for the patients that had crossed over from the placebo to the treatment arm, the overall survival was actually 5.1 months compared to 10.3 months in the ivosidenib group. So again, a really great option for patients that do harbor these mutations. And now moving on to HER2 amplification, I'll be talking about the My Pathway trial, which Dr. JaVale spoke about, as well as the HERB trial. So as we have seen, gallbladder cancers as well as extrahepatic cholangiocarcinoma do have a higher rate of both homologous recombination repair deficiency as well as HER2 overexpression. And so the My Pathway trial looked at dual HER2 blockade with pertuzumab and trastuzumab in patients with HER2 positive metastatic biliary tract cancers. And so this was a single arm phase 2 basket trial And we can see here that the overall response rates were 23% with a PFS of 4.4 months and a really impressive 1-year overall survival rate of 50% in these patients. This trial actually enrolled 41% gallbladder patients and really highlights the importance of HER2 testing within the gallbladder community as well. So the HERB trial looked at trastuzumab deruxtecan. So this drug is actually has a very interesting mechanism of action because it is trastuzumab combined with a topoisomerase payload. So once the HER2 targeted cells internalize this drug, that is when the cytotoxic topoisomerase payload is released. And so this was a phase 2 trial evaluating TDXD in patients with HER2 positive cholangiocarcinoma and biliary tract cancers. This trial was also interesting in that it also enrolled patients with HER2 low expressing tumors. And so you can see here that the responses were seen, the highest responses seen were as we would predict in the patients with HER2 positive tumors. However, in the low expressing group, there was 12.5% response rate as well. And so again, really highlights the importance of us understanding the cutoffs for trialing these therapies in patients, because as we can see here, even patients with low HER2 expression, there are responses seen. And so I talked about the TOPAZ-1 trial, and we said that that trial enrolled patients irrespective of PD-L1 status. And so I'd like to go back and talk about the keynote studies, which evaluated initially pembrolizumab in biliary tract cancer starting from 2017 onwards. So Keynote 158 and Keynote 028 were the seminal studies that evaluated pembrolizumab in patients with advanced biliary tract cancers. And so what we saw with both of these studies is that using a PD-L1 cutoff of 1 alone was not did not provide the benefit as we can see here. So patients who expressed PD-L1 had a response rate of 6.6% compared to 2.9% in those that were PD-L1 negative. However, when we look specifically at the mismatch repair deficient population and the MSI high population, you can see that the responses are improved at 40.9%, with an overall survival of 19 months and a 3-year overall survival rate of 30%. So again, highlights the importance of us selecting patients appropriately, even for the addition of immunotherapy. And so now, hopefully I've highlighted the real advances that we have had over the past 3 to 5 years, specifically in the second-line setting for patients with cholangiocarcinoma. And now we have an arsenal of therapies available for patients in the second-line setting, which will hopefully improve the outcomes that I was able to show in the first slide. And now the research that is being conducted is trying to see whether we can move these therapies to the frontline setting for patients harboring these mutations. And so in conclusion, I just wanted some take-home points that TOPAZ-1 has really led to gemcitabine cisplatin plus immunotherapy being durvalumab as the new standard of care in the frontline setting. We're awaiting results from the GEMCIS nab-paclitaxel study to see if another frontline option will exist for patients with biliary tract cancers. Most importantly, as we have discussed this morning, molecular profiling is crucial for these patients where there are limited treatment options that are standard of care. And so molecular profiling, both in the resectable as well as particularly in the metastatic setting at the time of diagnosis is important to deliver personalized care. As we can see, the landscape of treatment options in the second line setting is shifting rapidly and largely due to the fact that targetable mutations are enriched in the intrahepatic cholangiocarcinoma population. And hopefully, as Dr. JaVale has already presented, further research into gallbladder cancer and the molecular characterization of patients with gallbladder cancer will add to the arsenal of treatment options available for these patients as well. And finally, I just want to also point out that mechanisms of resistance inevitably arise despite these treatments, as we can see from the PFS of range that we have presented so far. And so understanding the underlying physiology of chemo resistance as well as targeted therapy resistance remains an active area of need as well. Thank you to everyone. I especially want to thank Dr. JaVale for his mentorship during my fellowship at MD Anderson, as well as the GI Oncology Department at MD Anderson. And I want to again thank the organizers and Dr. Kapoor for a wonderful second annual Jaipur Surgical Festival this year.
So thank you, Dr. Madhulika, for a very, very nice overview of the systemic therapies available today for biliary tract cancers and gallbladder cancers. So before we conclude, and thank you very much for finishing on time. So we have 5 minutes of questions. Are there any questions from the audience or any questions online? Dr. Kapoor, are we permitting online questions?
Hi, Hemant.
Yes, sir. Please go ahead.
Vineet Gupta from Bangalore.
Yeah, hi, Vineet. Please go ahead.
A great talk, Dr. Madhulika. So I think we are moving into an era where we are moving from lumpers to splitters in biliary tract cancers. The challenge obviously is resources. So I think one of the major challenges that we face as community oncologists is the absence of resource stratified guidelines. Because now the new gold rush is Durva, and everybody seems to be rushing on it with no holds barred. But it's frightfully expensive, and I don't see great survival advantage coming in real terms. So how would you approach this issue in the context of an Indian setting?
Can we have the lights in the hall, please? Like we are done with the presentation. Can somebody switch on? That's right. Thank you. Yes, Madhulika, please.
Thank you very much, Dr. Gupta. I think that's a really important question and one that even in the United States is an active area. And I think to answer your question, I think by splitting, I think is to provide patients with individualized and personalized care, I think is the best option. However, how to best go about that, I think remains to be seen. And one area that we're trying to do that is with the design of clinical trials is with basket trials. And so when we have such small numbers, such as gallbladder cancer in the United States, basket trials allow for a lot of the data that I've presented. A lot of these trials have been basket trials in that the molecular alteration is the entry point of the study, but then ultimately that the trials can be statistically designed to be evaluated in the specific cohorts, whether that be gallbladder or cholangiocarcinoma. And so ultimately, I think being able to find statistically significant ways that we can evaluate clinical benefit in smaller populations remains to be seen. And I think circulating tumor DNA or cell-free DNA is going to be a way for us to potentially evaluate this. In cholangiocarcinomas, and particularly intrahepatic cholangiocarcinoma, the circulating tumor DNA shedding is almost 100%. And so being able to potentially use novel endpoints for clinical response, I think will ultimately give us the data needed in smaller populations.
Thank you, Dr.
Just to follow up,
we need to wind up. Thank you very much. Maybe I can add my comments to Dr. Vineet's comment. I think in this country particularly, it's extremely important to resource stratify. And as far as I'm concerned, as a medical oncologist in this country, I'm not very impressed with the TOPAZ 1 because of several reasons. The first is that the improvement in overall survival is very small. And our main cancers are gallbladder cancer, and it doesn't have very impressive results in the gallbladder cancer setting. So basically, we need to, do research in our own country, and people like Dr. Kapoor and his medical counterparts, and us medical oncologists need to look and find answers for ourselves. Yes, sir. Please go ahead.
Ma'am, very nice and great talk. Just in continuation of the previous question, but pertaining to TOPAZ 1 trial, which has very heterogeneous population. This includes locally advanced tumor, metastatic tumors, recurrent disease after operation, and condition of our country, like which has like low and middle income countries. These immunotherapy, which are very costly, don't you think these results are a result of statistical jugglery to make it significant? And these results are, these all studies are some company driven. And if you see in between the lines, the survival is 1 or 2 months. It is 10 versus 12 months. Do you really think that this is going to make a difference?
Yeah, it's a great question. And I think that the benefit in terms of overall survival that we're seeing with the Topaz 1 study is minimal, as you pointed out. However, as we can see, the final data has not been published from the Topaz 1 study. And when we look at the 2-year results, there is actually a doubling of the OS rate at 22.6% versus 11.5%. So, and the curves do remain separated even with a follow-up at 36 months that was recently presented at ESMO. So I agree but that I do think there is a small population that does benefit from the addition of durvalumab, but understanding who that population is, I think does remain to be seen. And understanding kind of the full data from the Topaz study also will be an important part of that.
So I think I 100% agree with Dr. Madhulika that there is a subset, albeit a small one, which does benefit with immunotherapy, and which is true for most other solid tumors in which immunotherapy is approved. And we need to really refine our biomarker field and identify this population. And then possibly it will be more rational and justified. But the science is there is no question about that. Dr. Pipri, one quick, brief, pointed question.
Thank you very much. Excellent lecture. To improve the survival of advanced or locally advanced gallbladder cancer, can we add the radiotherapy, external beam radiotherapy?
So
What is your experience?
I'll defer to Dr. JaVale if he wants to also
Because the
speak on
survival
this.
is very poor.
So Dr. Pipre, Dr. Madhulika is a trained medical oncologist. This is not a fair question to her.
No,
I can tell you that if you balance the efficacy and the toxicity in gallbladder cancer, the toxicity is way more than the efficacy, and that's why it's not the standard of care.
Okay. Thank you very much.
So any other questions, comments? Dr. JaVale, would you like to, as the leading expert in the world on this, conclude?
Sure. Thank you very much. Great talk. Great talk. In answer to the radiation question, there are selected patients who can do it. The point I want to make here is really great opportunity to trial in India. There has and reality is, I think we have to be in a place like this, for instance, where you treat patients, you have to have the trial infrastructure because it can pay for itself. And you cannot really tackle this disease without development. I've seen that in China. I've seen the evolution of the disease. That's similar problems to ours.
So I'm happy to tell you, Dr. JaVale, that this institution and this university is actively encouraging industry-sponsored clinical trials also. And in my own department, we have 5 pivotal international studies ongoing. We just opened a very interesting study in conjunction with our hepatology colleagues and our intervention radiologists on HCC. So things are moving in the right direction. So Dr. Madhulika, we'd like to thank you very much for this very nice talk. And with the permission of my co-chair, we'll conclude this section. Thank you very much.
Thank you, ma'am. Thank you, sir. For the talk on the next topic will be on HPV oncology in India and uncertain glory. I would like to invite Dr. R.J. Sharma as a chairperson. Dr. R.J. Sharma is a senior professor and head of Department of Surgical Oncology at Sri Ram Cancer Center, Mahatma Gandhi Hospital. I would like to invite a chairperson online, Dr. Paleshwan Joshi. Dr. Paleshwan Joshi is a professor and head of Department Surgical Gastroenterology, Tribhuvan University Teaching Hospital, Kathmandu. I request chairperson to invite our speaker and introduce him. Thank you, sir. Over to you.
So good morning, and the bridge was Dr. JaVale's comment on
the trials in India, after the two basic talks, we now come to the ground reality. And Dr. Sanjay Nagral would be talking about where we stand in hepatobiliary pancreatic oncology in India, an uncertain glory. And our co-chairperson is Dr. Joshi from Nepal. So good morning, Dr. Joshi. Dr. Sanjay Nagral is a surgeon with expertise in surgical gastroenterology and hepatopancreatic biliary surgery, including HPB oncology. He has special interest in the treatment of liver tumors, acute and chronic pancreatitis, gallbladder, and bile duct stones and strictures. He has been in practice for 30 years and has been trained in multiple reputed institutions in India and abroad. He did his undergraduate and postgraduate studies at GS Medical College and worked at KEM Hospital, Mumbai till 1999 as Associate Professor of Surgery. He did fellowship at the King's College Hospital and the Royal Free Hospital in London from 1995 to 97. He is the director of the Department of Surgical Gastroenterology at JSF Hospital in London. So over to you, Dr.
Thank you. I was actually planning to start my talk by saying that this will be a big change from the previous two talks, but in a sense, the discussion of the last few minutes, in a sense, dovetails into what I want to say. And by the way, the bridge that you talked about with the talk, and by the way, JaVale turns out to be from my school and college in Mumbai, which I just discovered some time back. So first of all, a thank you to Dr. Kapoor and the team here and the institute. I was first actually invited by Dr. Kapoor and his team at the SG week of the Sanjay Gandhi Postgraduate Institute in the mid-90s. And yesterday spoke about it, and it was a great time because we used to all stay together. And again, here I am. By the way, I tried to make that pink. It's the first time that in any slide in my PowerPoint, I have tried to make the pink color, but it's not showing so well. But let me also immediately sort of go to the rather curious title of my talk and the story behind it. So the last year's Jaipur Surgical Festival, I gave a talk on, so it was about cholecystectomy complications. So I gave a talk titled Collateral Damage of Post-cholecystectomy Complications. And I think Dr. Kapoor at the end said that we would like to have talks like this. And I remember that I said that, you're having it as a Jaipur Surgical Festival with inspiration from the Jaipur Literature Festival. So why don't you invite certain writers, surgeon writers, doctor writers who've been writing in outside of surgery. That did not happen, but he said, why don't you give a talk on that? And therefore, what I'm hoping to do, and it's a little ambitious attempt and almost an audacious attempt, is to actually combine two issues. One is a zoom out view of what is happening in HPB oncology in the ground level in India. And the second is I'm going to sort of intermittently show you some books. And these are books which I have read and liked, largely written by Indian authors, and perhaps have some, all of them are written by, most of them are written by doctors, but have some connection to what I'm going to say in my talk. This talk is sort of based on my own personal work, like many of you in the audience, working in this country. I work both in the private and public sector till very recently, but I've been also associated with what can be generally termed the bioethics movement, the people's health movement, increasingly connected with patients' rights groups, and also through the bioethics lens, palliative care movement, which is now a fledgling but very important movement in India. I have also been closely associated with the medical humanities group at my alma mater. And some of you may know that for the last few years, I write columns in two fairly well-known newspapers. So the title of my talk is from a book. And this book is
written by these two authors, one of them fairly well-known Nobel Prize winner based in the US, Amartya Sen. But the other, who's I think one of India's extremely erudite thinkers, and he stays in India, although he's a Belgian national, called Jean Drèze. And they wrote this book called India and its Contradictions. And, I think one of the themes that I want to immediately take on in this talk is the fact that when you zoom in into HPV cancer, we can have a lot of detail on what we are doing. But when you zoom out, the picture becomes a little different and perhaps, as I say, a little uncertain. And literature is zooming out. Literature is essentially pushes us. Writers push us to zoom out. And that's exactly why I thought I will take this title. So here are some questions. What is the big picture of healthcare in India? What are the challenges to cancer care in particular, but also HPV oncology? Of course, we have improved expertise, and we know now that many centers in India do fairly advanced work in technology. But is it indeed making a difference to our ordinary citizens? And finally, a question I pose to you, and we must ask, is what do actually our patients want? We want to do things for them, but what do they want? Now, I'm not going to read through this slide. Most of this is well known, but any discussion on healthcare in India and cancer care in India must acknowledge the elephants in the room. And there are several elephants in the room which indirectly impact on whatever we do and what is our relationship with the patient. And some of the important elephants in the room, which our guests from abroad perhaps should know, is that there is no universal healthcare in India. And it's a very private sector dominated healthcare system wherein individuals pay out of pocket. The incidence of statistically, it's about 70% of people will pay out of pocket. I am aware that increasingly this is changing, and including in Rajasthan, where there are schemes now which are sponsored by the government, and the Chiranjeevi scheme here is one of the relatively well-known and successful schemes in India. But we also have an elephant in the room called Ayush. And Ayush is a very important elephant because very often our patients who come to us have actually sought opinions and treatment from non-modern doctors. So here's my first book. And this is somebody some of you may have met, known, works in Gangaram Hospital, Amrish Satwik, who is a vascular surgeon. And actually he just wrote one well-known book. But Amrish is actually increasingly writing. He did a lot of work during COVID, and this book talks about the British in India, and it's interestingly titled Perineum, the Nether Parts of the Empire. I just go to jump back to the zoom out issue of what is it that this part of the world invests in healthcare. And again, please don't read the graphs in detail, but clearly data shows that this part of the world, South Asia, invests the least in healthcare, education, and social assistance as a part of the GDP. What is also important is that when you compare even South Asian countries, India still is investing from its GDP as a percentage of GDP, one of the lowest proportions. Whereas smaller countries in this part of the world are investing higher and higher, and that also includes Bangladesh and Sri Lanka. And here's a slide, the two slides are borrowed from my ex-resident doctor and now colleague, who's C.S. Pramesh at the Tata Memorial Hospital, who incidentally is leading a fairly big initiative on cancer care, which I'll come back to later, which talks about what is the spending percentage for healthcare in India. And clearly you will see that it is all largely private funds. And that's a comparative sort of slide which I put up, although it's a little facile to compare the UK with us. These are two different worlds and civilizations in a sense. But look at the difference in the percentage in terms of the GDP spent on healthcare. Book number 2, two pediatric surgeons, Kalpana Swaminathan and Nishrat Sayyed, write together. And they write with the pseudonym Kalpesh Ratna. And it's about 10 books, and their last book is on the COVID epidemic. But before that, they wrote this very interesting book called The Quarantine Papers. The projected cancer burden in India, this is Mohandas Mallat. Again, somebody worth reading, been consistently writing, ex-Tata Memorial, who went into epidemiology. And again, therefore, taking a zoom out view. And here's from one of his Lancet Oncology papers, which projects the increasing incidence of cancer in India. And on the left side, they have a Ernst & Young study, and this is 2015. So it could have changed a little, but telling us the current gap between what India needs in terms of cancer infrastructure and what is available. I put up 3 papers here. Again, please don't read them, but they all bring out 3 different messages. The first is a paper we wrote, I co-wrote with co-authors from 4 or 5 South Asian countries in the BMJ, where we looked at surgical services in this part of the world. And essentially, we concluded that there is still a large unmet need for even basic surgical services in this part of the world. But the study I want to actually focus on, and this was in Lancet Oncology again, which is done by a global surgical cooperative group based in the UK, which actually suggests that mortality after cancer surgery in LMICs is higher and is not explained by the later presentation of the disease. Because we know that our patients present late, and I'm going to look at an example of gallbladder cancer. And therefore, there is our post-operative mortality and morbidity in parts of the world is higher, and that's something worth noting. And then, of course, something we know intuitively as surgeons in India, but a recent work done by CMC Vellore with a group from the UK, which looks at what is called catastrophic expenditure in public health in cancer care. And they actually looked at patients in Vellore who had colorectal cancer and showed how many of the cancer care actually not only puts pressure on the patient, but destroys families. This is an expat Indian cardiologist in the US, Sandeep Jor. This is actually his second book. His first book was called Intern, and it's a book I would strongly recommend because it talks about the dilemma of a cardiologist who is working in a very monetized system in the United States. And increasingly, all of us in India feel this dilemma because we are increasingly monetized in our day-to-day work. The top 25 cancers in India, again, staying a little bit on the zoom out view. And again, there's a detailed list there. This is data from Globocan 2020, but I've just put for you the ranking of liver, gallbladder, pancreas. As you can see, the mortality rank is higher. So these are diseases, cancers which kill. And it's a small percentage, but a substantive percentage. And for a country of India's size, that would translate into large numbers. And this is a Lancet Oncology study from India, which looks at the burden of disease. And again, don't look at the complicated slide, but suffice to say that pancreatic cancer in this study, this is 1990 to 16, seems to have gone down, but both gallbladder cancer and liver going up. And liver is, I have put that in red there. It's easy to understand that we have an absolute epidemic of NASH and NAFLD, and I think you're going to see liver cancer in a huge way. Kaveri Nambisan is a woman surgeon, interestingly trained in the UK, came back and is working in rural India. And she has written about 10 books. But if I have one book to recommend, it is this one. This is called The Story That Must Not Be Told. Now, in my own career, which started in the early 90s in KEM Hospital, where I got interested in HPV surgery, thanks to Dr. Mathur. And now I have seen substantive progress in around me also. So I think one needs to put that on the table. So we have, of course, now access to lots of sophisticated stuff, imaging. We can do much more surgery. I think we have good advanced ICU care in the corporate, large private sector and a large government hospital, which is making a difference. And we don't often acknowledge that. But we also have the availability and the possibility of chemotherapeutic agents and targeted therapies. The questions that followed before my talk are, of course, the big dilemmas that we face, that very often these drugs are exceedingly expensive and we don't know what they are actually doing to our patients. And of course, in terms of liver cancer now, we have the feasibility and the possibility of liver transplantation. Again, the big challenge is how can we offer it to more people. There has been some progress in funding for cancer. So the March Insurance Scheme, including PMJY, the Prime Minister's scheme, many more cancer units. Surgical oncology training, I think, has certainly beginning to come of age, and so also HPV as a specialty. And there is, of course, that sort of tension between the two specialties, which I shall not get into, because in India, we tend to work in silos, and therefore sometimes it ends up in who should be treating more. So this is again slides from Pramesh, which is an important initiative which he leads, which is the National Cancer Grid. And I'm not going to go into the detail, and they've got a very good website. But essentially, it's an effort to eliminate disparities in cancer care, also an effort to put down national guidelines. Book number 6 or 7, I've lost count, but Abraham Burgess, again an Indian physician, traveled to the US. His first book, incidentally, was on the HIV epidemic in the US. It's called My Own Country. But this is a book I would recommend, one of his new ones, because it's in the plot. The plot moves from India to Ethiopia, and then finally to the US, and ends with a live donor liver transplant between two brothers. So I come to the bit about why do I call the progress and the glory of HPV oncology in India as rather uncertain at this time. So here is one way of looking at it. So this is the seen part, what you heard in the last 3 days. But this is the unseen part. And I think it is the unseen part that we, those of us who work in the field, sometimes are insulated from, because we work in silos, but sometimes for inability to zoom out and look at the big picture. And that is where I think reading beyond our textbooks helps. So we are not very sure about what are the long-term outcomes of our patients, the complications. Cost effectiveness is a very important area. And last 1 year, I've been actually serving on a health ministry committee, which looks at health technology assessment, which is attempting to look at cost benefit, because many of these surgical procedures are now being included in the national scheme of the Prime Minister Jan Arogya Yojana. So we are using the Markov model to look at the HTA. We really often look at the patients who come to us as survivors, but tend to ignore those who have not come to us. And finally, of course, the issue which I've been referring to, which is the catastrophic expenditure. How am I doing on time? Where's the timer? I can't see a timer. Okay, about 10 minutes more. Okay. So here's a story which still happens in my practice, and many of you can identify it. So somebody who starts with jaundice and dyspepsia is treated as acidity, or as in some parts of India called pitta, for 4 weeks, treated by friends, family advice, neighborhood doctor treats for another 4 weeks, often goes on a fat-free, spice-free, non-veg-free diet, Ayush drug. So complete protein. So the 10 kilo weight loss in the first month or so, not getting better, referred to the ultrasound, which shows obstructive jaundice. Then there is a sense of panic, and there is a specialist referral. The specialist, depending on who the specialist is, will order a CT, MRI, PET CT, often all three. And I'm sure you see patients walking into your clinic with big bags, and sort of you spend half an hour shifting through the CTs, the MRIs, and the PET scans, etc. Some of them are biopsied. Liver tumors are quite regularly biopsied. And often, sometimes with the endoscopist who will say, let's do an ERCP first, relieve the lesion, relieve the jaundice. Sometimes the hepatologist will relieve the jaundice with a PGBD. 3 months later, to us, 15 kilo weight loss, 2 lakhs in the workup, completely exhausted, tired, and then we talk of surgery, and then cancer, so there's pressure for early surgery. So I think this is a snapshot of what actually happens outside hospitals. And this is how the real life of a cancer story, let's say of somebody with a cancer of the head of the pancreas is in India. So we are also the challenge of looking at outcomes. And I did attempt to go through papers, and there are several interesting good publications now on Whipple's immediate post-op outcomes, including a multi-center study. But what we seem to still lack in our data is medium term, if you can say 2 or 3 years follow-ups, but certainly almost negligible data on long-term survival. And of course, we almost have no data on quality of life, DALYs, and what palliative care is doing to these patients. We also have a challenge of multidisciplinary approach, and this is my personal experience. The 3 institutions I work in Mumbai, fairly big, all of them sort of academic, but we still are not able to get a genuine MDT going. It is often done as symbolic reasons, but it's not actually a MDT which decides for in a joint fashion in a certain equivalence way. So there is this concept in India that MDT should be voluntary without a mandate, which often defeats the purpose. And I think it has something to do with the power differentials in Indian healthcare institutions. Surgeons still tend to be much more powerful than their other colleagues. And finally, an area which is begging to be and crying out to be heard, listened to, and which we tend to other. So typically, we will say this goes to palliative care. This is palliative care without really understanding what it means and without understanding our share of the responsibility. So most HPV cancers in India, if anybody does a study, will be palliative care situation. But what is palliation? What do these drugs do? So we'll heard targeted therapies, chemotherapy. What do they palliate? Because they do have side effects, and they also, of course, are very, very hard on the pocket. So these are questions that are very relevant. What does that 3-month increased survival? That question was asked right now. What has happened is that the palliative care services have been left to the NGO sector, and the NGO sector has come up in a big way. But patients often want their original clinician to be there till the end. And there's a sense of abandonment from patients when we withdraw from their care by saying that we can't do anything more. And I think this is a serious question that we need to address, and we need to perhaps mainstream palliative care. And I'm going to show you a book now written by a gentleman called Dr. M.R. Rajgopal. Many of you may have heard of him, from Kerala, who's an anesthesiologist who turned palliative care physician, who runs a big organization called Pallium India. And he wrote this book last year, which is a very interesting read. And many, many NGOs now are working in this field and pushing us to look at this field from a more holistic angle. I don't need to introduce you to Atul Gawande, the rock star of what can I say? What should I say? I label as a writer, surgeon, writer, endocrine surgeon, by the way. I think his writing he's not really forayed into fiction as yet, but very important writing. And checklist, of course, we know, but his last book, Being Mortal, actually talks about end of life, and he talks about his time in India, the way his grandfather passed away and what he sees in the US, and it's an interesting comparison. So I'm just coming to the end of my talk by focusing on 2 or 3 issues. Number one, what do patients want? Of course, they want cure. But if cure is not possible, I think even our ordinary illiterate Indian patients want to know the truth and the prognosis. They want to be involved in decision making. They, of course, need relief from symptoms. I've already mentioned the fact that we need to be clear about what should we palliate. And in that palliation, they want pain-free existence, they want sleep, they want food, and minimum disruption of life and income. So I think when we talk about palliative care, we need to really understand what is it that patients want. Okay, so again, well-known book, Paul Kalanithi, a third-year neurosurgery resident at Stanford, diagnosed with advanced lung cancer and came out with this stunning book. He's no more with us, but again, this is, I think, more about what a patient feels. And here's a surgeon who was a patient, and it's an extremely evocative book, and I'm sure many of you have read it. So my last 2 slides. So what is to be done? What do we do? I mean, I have no easy answers. There are no take-home messages in that sense here. But I think we need to zoom out periodically. But I think we need to advocate for access. And in the South Asian context, doctors actually punch well above their weight. Doctors are very influential in South South Asia. And in Rajasthan, I'm sure in Jaipur, the big doctors can influence state policy to a big extent. We need to change focus on long term. We need to integrate palliative care. And finally, of course, we need cost-effective solutions. And I'm going to sort of show you this BCLC chart. We did a detailed journal club on this a few months ago. Now, this is great work, and we know the BCLC classification and the guidelines. But when you translate it into India, an average Indian hospital, what does it mean? Are these modalities really available to us? Are we really taking an MDT approach, sitting down together and classifying patients like this? Are with the unorganized and unregulated healthcare system, will we ever be able to bring at least elements of this algorithm into our practice? And of course, who will treat the stage C and D? Because the stage C and D really is still a big stage in India. And Pramesh's group did this very interesting paper, which is part of a global movement called Choosing Wisely. And they said Choosing Wisely India, where they have pointed out 10 what they call low value or harmful practices that should be avoided in cancer care. And I'm not going to read through them. There are many of them we discuss in silos, but they have put them together. And it's very, very relevant what they say. So for example, they say, do not treat patients with advanced metastatic cancer in the intensive care unit. And please visit some of the hospitals in Mumbai and you will know what I'm saying. So what's uncertain? And at the end, I need to go back to the title. What's uncertain? Are we treating patients at the right time? You can say something beyond us, but the story I told you of jaundice. Are long-term outcomes substantive and getting better? We still don't know. Maybe, but we don't know. Is the collateral damage that we inflict on our patients sometimes worse than the disease? If you do a bad Whipples with positive margins, what are you really doing to the patient? In fact, the patient post-op may be some kind of a surgical cripple. And are we devastating families in the process? And finally, the question I have asked repeatedly: what are we doing to those who cannot be cured? Now, I hesitated to put this book originally. This is, of course, something I was part of, and many of you know about this book. And actually, the title of the book is a little misleading, and I fully take ownership for that, although my senior authors, one of them passed away last year. But this book is actually was an attempt to provide the corruption lens to look at the structural challenges in healthcare in India. And those of you who have actually read it, taken a deep dive, will realize that this is not scandal, but this is about connecting the corruption that people talk about to the structural inequities. And incidentally, this book also went to two literature festivals, not Jaipur, but Delhi and the Brahmaputra Festival at Guwahati. Finally, ending with non-doctor, but a US-based feminist philosopher, Susan Sontag. And the reason her work is important because she suffered for 3 cancers in her lifetime and finally succumbed to the 3rd one, where she says something very interesting. And this is my last slide and I'm ending. And this is for all of us. Why should we address the issue of holistic care? Why should we look at it from the patient's perspective? Because as she says, that illness is the night side of life. Everyone who's born and all of us holds dual citizenship. We are now in the kingdom of the well, but there is the kingdom of the sick. And although we will all prefer to use the good passport, as she puts it interestingly, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other passport, the kingdom of the sick. Thank you for your attention.
Thank you, Dr. Sanjay. Amazing talk. Presented very differently. And there have to be many more people like you who can say, stop, look, and think, are you doing something wrong? Are you doing something right? And a lot of introspection needs to be done. And thanks for introducing the various authors, doctors to us. And the name today comes to the literary festival, I think the surgical festival. So I would request Dr. Joshi, who's on. co-chair, to give his final comments.
Thank you very much. First of all, I would like to thank Professor V.K. Kapoor for this wonderful invitation. And I would like to congratulate Professor Sanjay Nagral for such an excellent lecture, very much philosophical, and most of whatever he has said relates in our clinical practice in Nepal as well. And talking about the cancer care in Nepal, we do not have there are very few centers which has everything that takes care of a cancer patients. And we have a cancer patient hopping around many centers in order to get various investigations for radiotherapy and chemotherapy. And one-stop cancer care centers are very few in Nepal. And as you also mentioned, that the cancer treatment is very expensive, and that also applies to our patients as well. And the one of the thing, when we did the root cause analysis of mortality in patients who underwent Whipples, we found that it was the cost, it was the finance that led to failure to rescue. Because when complications develop in these patients, and when we tell them that they have cancer, then the patient party tend to withdraw treatment, and that is very saddening, in spite of the facilities that are available in the hospital for their management. And regarding the HPV cancer, although according to the epidemiological study that was conducted in 2017, the most common HPV cancer in males is HCC, and it's gallbladder cancer in females. But in hospital-based, according to hospital-based statistics, the most resectable cancer is the periampullary carcinoma. And the story of jaundice that you just mentioned also applies to our patients in Nepal. And yes, the perioperative outcomes of various HPV cancers has been published, but as you mentioned, the long-term outcomes has not been discussed. And with the initiation of liver transplant surgery in Nepal, and at our center also in Tribhuvan University Teaching Hospital, the management of the surgical treatment of cholangiocarcinoma has increased. And although we need to look for the wait for the long-term outcome as well. And I would like to congratulate and thank again to Professor Sanjay Nagral for such a beautiful lecture, and which relates, I think, to most of us who is practicing HPV oncology. Thank you.
Thank you, Dr. Sanjay.
Can I make a comment?
Sure.
So, great talk by Sanjay. Sanjay has been my teacher, my guide in my postgraduate days. I have a different perspective though. What Sanjay said is absolutely right. He's introspected the ground realities. But at the same time, when there are mid-level surgeons present here, students present here, it's very important to make them realize that while what he said is true and it sounds good to hear and to read, the reality is that there are many centers who, in spite of all these limitations, they are doing well. They are treating cancer patients at absolutely no cost. At place where he worked with us, not a long time back, we do Whipples, hepatic resections, post-complicated pancreatic necrosis, biliary strictures at almost zero cost. And what you said, what you showed, that 10 mistakes which should not be done, it's right. There are many people in corporate sectors which they do it for reasons we all know. But there are reasons why it has to be done, which one has to take into perspective. So that's what I just wanted to come.
Sure.
I think again, very nice session, Dr. Nagral, and always at JSF, we keenly wait for you for a special session by you, which is not only a scientific, academic, but for the social perspective also. I think the nutshell of the entire presentation is, I think, a mentor for GI surgery for all of us, Dr. Samir Nandi. He said the problems are common, whether it is Indian, American, or Western, but we need to find an Indian solution for all these problems. I think that is a nutshell what you want to conclude. And so we always hear that from him. I think I will disagree with what sir has said. yes, government sectors are doing good. We have many patients being treated in a very low cost fashion, but I think only 5 to 10% get that facility, and 90% still strive for those facilities till date. 90% of our patients which we have, I think we have to focus on them.
Thanks, Doctor. And I think he has stirred a lot of emotions, and we can do a chit chat during tea time. Sir.
Good morning, sir. It's always a feeling that I can't share that to listen your lecture, either in JSF or either in Jaipur Literature Festival. I love to read all your books. Just wanted to share that you have included all those books which are nicely written, like When Air Becomes Breath. Just to include, and just a little bit suggestion to include a nicely written book by Randy Fosh, Last Lectures.
Yes.
I think you should include that book also.
Was that made into a book or is it just a lecture?
PDF.
PDF,
So
okay.
it's
Yeah,
kind
yeah.
of book.
So,
But
yeah.
that person, he has shared the moments which one can have to include in his day-to-day life. So I think.
Yeah, sure. So for the sake of the audience, Randy Posh,
Last lecture.
advanced pancreatic cancer, and lecture given to a university students.
So
And
it's a kind of compiled
yeah,
PDF
yeah.
form.
Dr. Kapoor is telling me to continue the surgical festival rather than the literary festival. So
Okay.
thank you, Dr. Sir.
Thank you. Thank you.
Thank you, sir, for nice discussion. Now I invite you all for tea break and we'll start our next session on 11:40. I would like to invite for moderating this session, Professor T.D. Yadav. Professor T.D. Yadav is a professor of GI surgery at PGI, especially interest in HPB and liver transplant. Sir, over to you, sir.
A very good morning, and thanks team of the JSF and our teacher Professor Kapoor for giving us this opportunity to have our opinion on very controversial topic in our country, at least in this part of country it's very controversial. So I have been given the list of 5 moderators. Dr. Usha, Professor Usha Datta, she is from PGI Chandigarh. She is HOD Department of Surgical Gastroenterology. She has to join online. And Dr. Baiju Senadipan, he is a senior consultant and GI oncology and bariatric and laparoscopic surgery. He has a very nice running program of education in the name of Senadipan Education Trust, Thiruvananthapuram. Welcome, Dr. Usha and Dr. Baiju. And other friends are here. Dr. Durgatosh Pandey. So he is from Tata Medical Center, Varanasi. Dr. Durgatosh, he was there having a cup of tea and somebody asked him to come. And Dr. Nag, Professor Nag, he is a professor of GI surgery, GV Pant Hospital, New Delhi. Dr. Nisar Hamdani, lecturer, Department of Surgical Gastroenterology, Super Specialty, Government Hospital and Medical College, Srinagar. Dr. Nisar, please join us. And Dr. Nirjar, Assistant Professor, Department of GI Surgery, AIIMS Rishikesh. So I welcome you all, and I have divided this panel into a few components, and we will try to take the opinion of our panelists. Then finally, at the end, 15 minutes, I have been asked to spare 15 minutes for the audience to participate. So I think at the end only that 15 minutes will be okay. So this is how we are going to have it. So these are the faculty. So Dr. Usha has done lots of work on epidemiology and gallstone, and she's from PGI. So Dr. Usha, can we start with you? Can you give your idea on epidemiology and natural history of the gallstones? Because it's a topic which will generate lots of controversy and lots of discussion also. So possibly at the end we might give some final comment.
Thank you, Professor Yadav. Thank you for your kind introduction, and thank you to Dr. Kapoor for inviting me in this surgical forum. Asymptomatic gallstones, epidemiology and natural history. Am I audible and are the slides visible?
Yes, you are audible.
Okay. So here, these gallstones come in all shapes and sizes. It affects people of all shapes. So in contrast to what Bailey and Love says, fat, fertile, 40 females, we see it in also the young, malnourished, multiparous women. It also can be 1 to about 100 stones or even more than that. It can also be found at different sites inside the gallbladder lumen, at the cystic duct, in the CBD, at the ampulla vater. It can be also seen at the terminal ileum when patients present with gallstone ileus. It can present with various symptom complexes. So when we have a biliary colic, the stone is at the cystic duct, partially obstructing, and the stone may fall back when the patient has a biliary colic. Or when it gets impacted there, it's going to cause acute cholecystitis, and it can migrate into the CBD and cause cholangitis. And it can also cause cholangitis with cholangiovenous reflux and a septicemia kind of a situation. So as we all understand that the natural history of gallstones can be asymptomatic or symptomatic, and the natural history varies whether it has been symptomatic or asymptomatic. 80% of the gallstones are asymptomatic. It is considered to be symptomatic if it has biliary colic, acute cholecystitis, cholangitis, pancreatitis, biliary cancer, or complicated if there is Mirizi syndrome or gallstone ileus. In the West,
can I stop you here in the your first slide? Because we are talking about which group of asymptomatic stones will require some sort of treatment. So can you go back to your earlier slide?
okay, I'll reshare it.
No. Okay. So I just want to ask you, what percent of the people would go to direct complication of the gallstone disease rather than coming with the biliary colic?
Yeah, I will just tell you, Dr. Yadav, I'll just complete it and then we can, I have those slides. Just give me a minute.
But what my take is that if you go small points that we are taking at the same time, so that we can give a message. So there are 80% people you say that probably they became remain asymptomatic, may not be diagnosed, require any treatment in the life. But then when they become symptomatic, what is the history of the symptomatology? That how they go to symptomatology? Are they going directly to the complication of acute gallstone disease, or they can have a biliary colic?
Yeah, the GREPCO study showed that patients often, before they present with complication, develop biliary symptoms. So there is a window where we can start acting. However, a recent cohort study from United States Cleveland Clinic in 22,000 patients has shown that some patients can directly present with complications and 1/4 of them will require intervention. I'll just show you the slide. Just give me a few minutes. So in the West, the epidemiology is 10 to 20% have gallstones. In India, it is 5 to 10% and steadily increasing because of increasing metabolic syndrome. In North, we did a study in 220 patients and we did FTIR analysis. 33% are pure cholesterol, 65% are mixed and 2% are pigment. In South, it's predominantly pigment, but mixed is increasing. So this is the initial study on a Danish cohort study. 664 people uncomplicated. They had only colic in 12% on follow-up at 20 years. But complicated stones, CVD stones, pancreatitis, complication in 5%, acute cholecystitis in 3%, and gallbladder cancer, they did not see any. So the cumulative incidence of symptoms as well as complications steadily increase over time. So it is not that if the person remains asymptomatic in the first 10 years, he'll remain asymptomatic all his life. There's a cumulative increase in the incidence of symptoms and complication over a period of time. And here we can see.
Dr. Usha,
yes,
we can stop here, then I will come back to you again. So the message here is that the gallstone, as you see the natural history of the gallstone disease, that 80% of the people would not have. Can we share my slide now? Please, yeah. So 80% of the people will not have, and there is also a clear data that people who are going to have complications of gallstone disease, usually direct complication rate is in the tune of 3%. So there is a very nice study, 24 years follow-up of gallstone disease from Norway, and they have shown that these are the people. None of the people have developed gallbladder cancer, but that we cannot translate into our country. But these are the data. Maximum patients, only 6% of the patients required cholecystectomy in 24 years, and they have followed it up with the ultrasound at that particular time, and then followed later on also. So going back to Dr. Durgatosh. So there are lots of, in our country, if you see, there are lots of discussion going on that all asymptomatic gallstones should be operated. Please let my slide share this thing. Share my slide. Then, okay. So there are lots of discussion about every patient should be operated. All patients in North India should be operated, North and East India. Some patient will be operated. So if you are seeing a symptomatic stone patient, when you will say that these are the patients I will operate, would you like to have some patient, because you are working in a area which is very high this thing. You are working in BHU, we are also in Chandigarh. So what is the policy and what do you recommend?
So I wish there was a clear answer on this.
unfortunately, we certainly have an association of gallbladder cancer and gallbladder stones. But is that association positive? That is something which we do not know. And my own view would be, own distilled view from the several studies would be, that there might be something which is causing both stones as well as cancer through probably different mechanisms. And there is, if we go back to the genetic studies, now there are some data is emerging from our own country, which is talking about this ABCB mutation in
data application you are
yes,
talking
yes.
about. Okay.
So ABCB mutations, which to me suggests that there is probably that is a common causative factor. It's not that the stone is causing the disease. It is probably that mutation which is causing the gallbladder to have more stones as well as turning to the more disease. Coming to your question about should we operate on such asymptomatic stones? Now, we cannot translate this question
So
into a
this
yes
is
or
your
no.
slide. This is slide you
Yes.
provided by you. Yeah.
Yes. So if we look at several patients follow-up, we don't see many gallbladder cancers in these studies, which are predominantly from the West. When we look into our own data, we see that there is a strong association between gallstones and gallbladder cancer. Yet, I would hesitate to recommend a cholecystectomy for all asymptomatic gallstones in a population-based program. I cannot recommend it for the population. If one has an access to a very good surgeon, very good center, well, go ahead. My brother had an asymptomatic gallstones. He got himself operated in Bangalore, which is fine. I mean, these are anecdotal things, but should we translate it into a population-based recommendation? My answer would be no. Because
So
that
these
has
are
got
the
its
these
own
are the
pros.
three queries I have prepared. Does the duration for which the patient has the gallstone play a role in pathogenesis, meaning thereby the duration makes you think about? That is one. Do the size, weight, and volume of the gallstone? Dr. Nirjar also can take this question. Volume, Dr. Nirjar. And does the number and type of birth? These are the three important things we want to know when we are talking about asymptomatic stone which has been diagnosed.
So what we think is the question number 1 and 3, I do not have an answer to. Question number 2, the size of the stone, as it increases, the chances of its association with cancer increases. More than 3 centimeters, some people say. That is not carved in stone. That statement is not carved in, I mean, in stone that a stone more than 3 centimeters needs to be removed. But you asked about the risk. These are the risk factors.
So, Nirjar, Dr. Nirjar, you want to add something? Dr. Durgatosh said that any size, Dr. Durgatosh, you are talking any size in particular epidemiological area, people are residing in suppose in Chandigarh and in BHU, Banaras.
So I'm talking mainly about a population which has a very high incidence of gallbladder cancer, which our population has. In fact, incidentally, when last week we looked into our hospital-based cancer registry, we could see that 9% of all cancer registrations, which includes everything, all cancers from head to toe, including hematolymphoid, pediatric, etc., 9% are gallbladder cancer. This is a huge number. When we talk about that population, I'm stating this figure that more than 3 centimeter stone has a high association. However, should I say that they require cholecystectomy? I would still be here.
Dr. Nirjar.
If we talk about evidence, so whatever studies has been done in Western data, we have that more than 3 centimeter stones are seen associated with the relative risk of 10, and in other studies also with the relative risk of 9 in comparison of the 1 centimeter stone, that those studies suggest. With the same time, one study suggests that there is a volume which is the main contributory factor for the association with the gallbladder cancer. That is around 10 ml volume of stone is associated with the relative risk of 11 with the gallbladder cancer, rather than a number of stone. But definitely for our population.
So you see in the slide I have picked up about the volume. Do you agree with that? 11.7 versus 6.
Sorry to interrupt.
Yes.
Dr. Beju says that the voice is not clear, so could you please all speak into the mic and little louder?
So, sir, moderator voice is clear, Dr. Beju?
Actually, I can hear you. I cannot hear the voice of the panelists.
Okay, okay. So I am coming to you in the next this thing.
No, I wanted to hear the panelists also.
Okay, okay. So please give another mic, please. Come closer to the come closer to the mic. This one. Yes, Dr. Nirjar, go ahead, please.
So as whatever slides you showed, sir, in that we can see that p-value is significant when the volume is higher of a stone.
So what I could collect, just to summarizing this number size, as we are discussing in epidemiology, high volume gallbladder cancer area, Dr. Sanjay Gandhi PGI, Dr. TMC Varanasi RBHU, where Dr. Durgatos is working, Rishikesh, and we are working. So most of the people, I try to find out about the stone size other than what you said, that you found that there are more than 3 centimeter. The studies show that there are 4 studies have said yes, there is a association is definitely there, but there is a risk of gallbladder cancer. 2 said no, and duration more than 20 years. There are 3 studies which said no, but 1 study has said has published that there is no association. So it's very difficult to summarize about the size, but still we can say that if a person is residing in the area where gallbladder cancer is very high, if person has a family history of gallbladder cancer, and if other factors like gallbladder wall, everything is okay, then probably one can take a decision based on the person. Regarding volume also, but same thing is there. There are conflicting studies. So the people who talk about that a stone is this, the stone is causing gallbladder cancer. There are studies about field cancerization. They said that this particular bile is also cancerogenic. So it's not only stone. So one of the studies suggests that before stone was formed, the bile was cancerogenic. One of the person is pushed the stone inside the gallbladder and tried to in an experimental study, but could not find. But Tata study, 2 studies from Tata. Earlier they have said same thing that multi-center study. It was almost a review, and their conclusion was that usually there is association, but causative factor is not known. So that's why it's not recommended. But the recent study what Dr. Durgatos talked about, they have done some genetic studies, and based on that, if there is a gallbladder stone and there is that genetic variation is present, probably it can be advised. And this is the survey. So I will go to the one more problem. And Dr. Nisar, what about porcelain gallbladder?
So porcelain gallbladder, it has been conventionally considered to be the risk factor for gallbladder cancer. But once we follow the literature, see the literature, the paper by Sandys described porcelain gallbladder into 2 types. One was the diffuse calcification, and it was the this focal calcification. Focal calcification, if I'm not wrong, it has been associated with the malignancy.
Selective mucosal calcification,
yes. So it was further mentioned that the association of porcelain gallbladder with gallbladder cancer has been overemphasized. So, but still we need to consider it as a pre-malignant condition and definitely consider for surgery.
So all porcelain gallbladder you are suggesting are that particular segment which has been differentiated from the classical porcelain gallbladder. You got my point? What I said, suppose you get a patient referred that this is a porcelain gallbladder.
Right.
Every patient you will go and do cholecystectomy, or you will investigate more.
So
ultrasound is there. There is a porcelain gallbladder.
Definitely, the CT scan can be considered. But very important thing in our setup is that whatever evidence we read as students, as practitioners, as scientists, is not easily to be conveyed to the patients because they don't have that much of awareness. So many times they leave the decision to us, and then we are stuck up with the issues of follow-up, whether they can follow up or not. So we have to take a better decision based on the socio-economic status, the educational status, and the availability of the healthcare system the patient is from.
No, these are the
so
these are the logistic problems.
Yes,
So
yes,
we should talk science that
Yes.
whether it is done or not. Logistic we are not
So
discussing.
definitely we should do CT scan. We should consider CT scan and then decide about the patient.
Okay. So going further ahead and trying to see other changes in the gallbladder, probably ultrasound may not be enough. So Dr. Nag, there are sometimes we are finding that there is a pain, patient is coming and there is a the ultrasoundologist mentioned there is a sludge in the gallbladder.
Yes.
So how should we proceed about that?
Patient is asymptomatic sludging. Basically, for symptomatic gallbladder, there is no confusion. There cholecystectomy, laparoscopic cholecystectomy should be done. For asymptomatic gallbladder stone, generalized
Our whole
consensus
discussion is asymptomatic.
that's okay. So whole that is expected management, except some situation like it has been discussed, like gallstone size more than 3 centimeter, gallstone size more
No,
than
please talk
5
about
mm.
sludge. Size we have discussed.
Sludge is smaller, this thing. This patient may develop sometime acute pancreatitis and all, then that maybe we can discuss with the patient and that may be a candidate for the this thing. Prophylactic cholecystectomy.
Yes.
Sir, I want to add one thing that most of the time sludge are secondary to other problems, like in prolonged fasting, TPN, and most of the notice at that time. So I feel whenever we notice sludge and the symptoms are not clear, we can wait for 4 to 6 weeks and let the sludge clear. If it is not clear and
You add
persist, we can
UDCA
take
or
the
just wait? You can add UDCA. Is there
we
any?
can give UDCA, although it make the bile thin and it may make the clear.
So my personal experience is that if I'm very much scared when a peripheral ultrasonologist mentions there is a sludge in the gallbladder. So in PGI, when somebody says sludge in the gallbladder, so we request our friends to do color Doppler. And you could see that in that particular picture I have taken, here is a, because sludge is very dangerous. So here is something, it was described sludge. But if you add color Doppler, you are seeing the vessels. Usually sludge will not have vessel, but gallbladder cancer will have some sort of vascular supply. So I think in an area where we are working, high endemic area, most of us who are sitting here and by the panelists and Jaipur also is the same. So North India. So I think if there is a sludge only, I think we should go one step extra and try to see. And again, as Nirjar said, that we can give UDCA and wait for some time, recall the patient. So the close observation is very much required. Sludge alone usually is not recommended, surgery is not recommended. If required, then we have to see whether sludge is going up, this thing getting up. If symptom comes, then no problem. Otherwise, do a color Doppler, good color Doppler, ultrasonologist can tell you that, and wall changes should not be there. That is also very, very important.
I would like to add one small thing here. With sludge, you can add prokinetic agents and repeat the ultrasound after 6 weeks. If the sludge clears, then there is no need for treatment. If the patient has persistent sludge, then these patients are at high risk for developing gallstones, so they should be under close follow-up.
Okay, thank you, Dr. Usha. Very nice point. Yes. So, Dr. Baiju, so these are the stone disease we have tried to cover with porcelain gallbladder. We have to be very careful, investigate more rather than miss one cancer. Dr. Kapoor used to say, I will do 10 tests more to diagnose one more cancer, so that we should not be missing one gallbladder cancer, because these are the people, they will be diagnosed very early, and these are the people where cure is possible. So, Dr. Baiju, am I audible to you?
Yeah, you are audible.
So how do you manage a patient? Will you manage a patient of gallbladder polyp?
Yeah. Thank you, Dr. Kapoor, for giving me this opportunity and to allow me to join online. And thank you, Dr. Yadav, for the nice introduction. For me, the question given is gallbladder polyp, and you can show the slide that there are different classification system for.
Can you show my slide, please?
You can put your slide, no problem.
So go ahead.
Yeah, this is a classification system proposed by can you show the slide, please?
Slide is, are you not able to see the slide?
No, I am not able to.
Can you share the slide with that?
Yeah, I'll share my slide, please.
Okay, you could. So gallbladder polyp also is sometimes.
Yeah, there is a classification system proposed by on Mumbai Nair. It's called the Mumna classification, and says divided into type 1, 2, 3, and 4 depending on the size, and the risk of malignancy is given here. And you can see that if it is more than 10 millimeter size, the risk is high, and you need to go and do a cholecystectomy. And if it is 6 to 9, it is intermediate risk, then you can propose the patient is ready for surveillance. You can postpone the cholecystectomy, and you can see but there is in the type 4 with less than 5 millimeter with Indian ethnicity. They say that the risk of malignancy is more, and the patient has to be submitted for cholecystectomy if he is fit. But that will not stand true in the case of South India, because we get different types of gallbladder cancer epidemiology here. We don't actually see much of gallbladder cancers here. Now it has been almost 20 years of my career. I have seen less than 10 number of gallbladder cancers in my career. And that too, there is not much of association between gallbladder cancers and the size of the stones. So this last type 4 may not be applicable to South Indian people.
So my question is gallbladder associated with the polyp. Then what will you do? Association gallbladder stone with the polyp. In that same gallbladder, there is a polyp also.
Yeah, this is a study from North American Journal of Medical Sciences. They actually tested the relationship between gallbladder stone and the gallbladder polyp. And this is a recent study. They say that there is no significant difference in the involvement of malignancy when there is an associated stone. And there is no, it's not only that there is no increased incidence of malignancy, is that the cholecystectomy is as advised is just because the chance of the cholecystitis or the complications are more with the size of the stone, and the gallbladder polyps are coexisting. It's not because of malignancy. And another point is that actually the South Indian people, this relation is not at all visible. And there is another study I will show the next slide, that there is no association with the size and the stone and gallbladder cancer.
Dr. Nisar, can you add from North India? Do we have both the perspective? If there is a stone with the gallbladder and the polyp associated?
Sir, with the gallstones.
Kindly share my slide, please. Yeah, you go ahead, please.
Asymptomatic gallstones with the polypoid lesion of the gallbladder. We definitely like to stratify what is the risk factor. When referring to this slide, this was classification given by us with Kapoor sir about the polypoid lesions of the gallbladder. Basically, what we label as polyps are mostly not polyps. They are polypoid lesions of the gallbladder, because ultrasound, which it identifies as a polyp, is usually, in most cases, is a pseudopolyp. We can see that these cholesterol polyps and adenomyomatosis, they constitute pseudopolyps and are 95% constitute 95% of all polyps, and they have zero chance of turning into malignancy. But on ultrasound, scanning ultrasound, we cannot differentiate between pseudopolyp and a polyp. So for every practical purpose, we'll identify, label it as a polypoid lesion. So a polypoid lesion in presence of an asymptomatic gallstones, number one, we have to stratify as per the risk factors, whether we have any indication for cholecystectomy in absence of a polyp. That is one thing, then the patient has to undergo this cholecystectomy. Number two, in presence of risk factors, especially like this mentioned, that in presence of associated gallstones, or if we have a sessile polyp with a focal wall thickness, which we label as 3.5 in some centers and 4 millimeters, sorry, 3.5 millimeters and 4 to 4.4 millimeters in some centers, and solitary polypoid lesion of gallbladder, we must consider cholecystectomy.
So you want to say that a gallstone with polyp has a different perspective, and you
Definitely.
must go further and try to look into
Yes.
the thickness, and it might be stone, and
Yes.
there may be starting of the gallbladder cancer.
Yes.
So that in
One more
North
thing.
India,
One more thing I would like to add is that presence of stone somehow interferes with the surveillance of the polypoid lesion, and especially the type of the stone, number of the stones, whether gallbladder is packed with stones or not, or it's a solitary stone, small stone. It somehow affects the surveillance. So we cannot take this in the North Indian region.
so we are now very sure that gallbladder polyp is, if there is associated stone, we should investigate little bit further and try to close follow. And if size is increasing more than 6 millimeter after 3 months or 6 months, then you have 6 millimeter per month after 6 months, then you should be very, very careful.
So if the initial size is more than 6 millimeters, it's an indication of cholecystectomy. If this on surveillance, if it is increasing more than 2 millimeters in every surveillance, then it's an indication for cholecystectomy. Or at the presentation only, if it is more than 10 millimeters, then in addition to cholecystectomy, it is one of the indications for evaluating it for a suspected gallbladder cancer.
Yeah.
So the patient needs CCT and should be evaluated as suspected gallbladder cancer.
So, Dr. Nag, so my question to you about these are the hemolytic anemia, certain anemias where there is a gallbladder stone is found incidentally. So, what is your take on this type of?
Hemolytic anemia is one condition where laparoscopic cholecystectomy is recommended because unexpected management both in children as well as in adult population complication rate is very high. There are two ways to do cholecystectomy. We may we may wait and watch each patient when symptom develops and then we can operate. Other approach is to do the elective cholecystectomy. It has been found elective cholecystectomy has a significantly less complication than this thing emergency cholecystectomy. So it is better in these patients to do elective laparoscopic or prophylactic cholecystectomy because most of the patient, around 80-90% patient will develop the gallstone in these patients. And one more thing, these patient needs to be regularly followed up for the all hemolytic disorder patient. If even they don't have the gallstone, they should be regularly followed up with the ultrasound for the development of gallstone.
So this is for all hemolytic anemia, thalassemia, sickle cell anemia.
Yes, hemolytic disorders.
All okay. So hemolytic disorder, if there is a stone incidentally found when you are doing something else, then probably it's required that you should go and do a elective cholecystectomy, lap or open, whatever this thing you have. So I go back to Dr. Our friend Dr. Baiju. Dr. Baiju, you are doing lots of obesity surgery, you have written, and you are going for a bariatric surgery and there is a gallstone asymptomatic. What will you do?
Actually, there are studies in the literature saying that prophylactic cholecystectomy should be done. And if gallbladder stones are there in the gallbladder, when you are doing bariatric surgery, it should be taken out. But there are people who are doing prophylactic cholecystectomy even without stones also, because the incidence of gallbladder stones are more with the bariatric surgery immediately after surgery, within 1 year of surgery.
So you mean to say that if you are going bariatric, the gallbladder has to be removed in all bariatric surgery, or there are some?
Even if asymptomatic with the gallbladder stones, even otherwise, even without bariatric surgery, other surgeries also, if you are going for a laparoscopy surgery, it's better otherwise remove the gallbladder if the stones are there. But bariatric surgery, even if the stones are there, you have to if the stones are there, you have to remove it. And even if there are not stones, there are studies that prophylactic cholecystectomies are beneficial. But I don't agree with their perspective, because there are studies against that one also.
So I had both type of as you are saying. But what is as a surgeon your take? If you are suppose you are working in South India, North India, any difference, or any bariatric surgery you will do it cholecystectomy?
No, if the patient is having gallbladder stone and the patient is going for a bariatric surgery, I will remove the gallbladder along with the surgery. If the patient is not having gallbladder stone while the patient is submitted for bariatric surgery, I will not do the cholecystectomy at the same symptom.
So coming to Dr. Durgatosh, we are in the textbook we used to read that there are people who are having you are going for another surgery, and then if there is a gallstone, there are certain group of patients where concomitant cholecystectomy should be done. So what is your take on that? Because these are the things for the everybody for day-to-day practice, and if we can have generate some idea. So
as far as I'm concerned, because I deal with only cancer surgeries, and specifically there is also an increased incidence of
share my slide, please.
Increased incidence of gallstones after a gastric cancer surgery as well. So in that group of patients, if I find a stone in the gallbladder which has been asymptomatic, and you see, often when we say asymptomatic, we don't know whether the patient was asymptomatic because the patient has gastric cancer, has presented with some symptom, and that symptom may be a mix of this and that. So if I see in a patient with who is undergoing a gastric cancer surgery, gastrectomy, and has a gallstone, which was supposed to be asymptomatic, I'll not hesitate to remove it during that particular surgery. But
So
not for other things. I mean, I would not do the same in a hemicolectomy or in a low anterior resection.
Because
Not
of
all the
type of surgical wound you are talking about.
Yes.
So I don't know, but I could not find much literature. But what about transplant? Suppose but there are reports of a patient is going for transplant. You should do a cholecystectomy. Asymptomatic stone is there.
So again, another disclaimer, I have not been associated with transplant for the last 15 years, but yet because of my previous association, I can comment on that. A patient who has got an asymptomatic gallstone now, we can classify this into two questions. One, the patients waiting for transplant, and the other patients who are post-transplant. So in patients who are awaiting transplant, a patient has renal failure or heart failure, those are the patients who would require this kind of transplant. And any surgery will carry a very high risk. And why subject the patient to such a high risk when the patient is asymptomatic? That would be my take. In a patient who is a post-transplant candidate, in that case, there is data which I saw recently in a cardiac transplant, but that data is also conflicting. In a post-cardiac transplant, they say that if a patient develops a gallstone and is asymptomatic, and the patient requires an emergent surgery, then that patient has got a very high risk of morbidity and mortality. Yet, those patients had a very low incidence of biliary follow-up, which means that many such asymptomatic patients were missed. In another survey-based study in the United States, that same conclusion could not be drawn, which said that yes, if you follow these patients quite closely, biliary follow-up even after cardiac transplant, then the elective follow-up of such asymptomatic gallstones is quite well taken.
So other panelists, any one of you have anything to say?
So most studies recommend prophylactic cholecystectomy in patients with the transplant.
Cardiac transplant, it's as you said, there is some controversial data, but it seems that more and more people are talking about in favor of removing the stone. As you said, that complications are more when you are going for for this thing. Dr. Usha, this is the probably last from our side. Then we will go to the panel because I am seeing at the time also. So Dr. Usha, there are talk about microlithiasis and small stones. Then what is the role of in UDC in these patients where you are not able to find by very small stone? It is just symptomatic. We have talked about size, a large size. We have talked about polyp association, small stones. So you have done a motility study also. So what is your take on that?
When we find small stones, which is less than 1 centimeter or less than even 5 millimeter, these are stones which are at high risk to cause pancreatitis. So we are worried when we see them. Second is, if the gallbladder function we tested by ultrasound or HIDA, if the ejection fraction is less than 40%, these gallbladders are not going to be otherwise also functional. So then these stones and a dysfunctional gallbladder, these gallbladders can come out. If the stones are small and the gallbladder function is more than 40%, UDCA therapy can be tried, and UDCA has to be given for minimum 3 to 6 months. If it is just simple cholesterol stones without calcification, radiolucent, these stones will respond to UDCA. So for a stone to respond to UDCA, it should be small, it should be radiolucent, it should be primarily the cholesterol type of stone, and it should have a good gallbladder function. So in this subset, I would try UDCA.
So I am going to other side of what you said UDCA. I am thinking other way around, that if gallbladder is functioning, and if there is a small stone and cystic ductic pattern, UD HIDA, and these patients, can they have more chances of having CVD stone, and could that be one of the indication of asymptomatic stone gallbladder being taken out?
I think, Dr. Yadav, these stones are more likely to slip from the cystic duct into CVD. I agree with you on that. But these small stones, if they are asymptomatic with good gallbladder function, may also be a category of patients who will respond to UDCA. So a UDCA trial for 3 months may be worthwhile.
Okay, so I thought these are the very salient points which I wanted to cover in 1 minute, sir. In 45 minutes, which I've been given, sir has said 15 minutes for the audience. So I open this thing for the audience, and at the end, I have 2 slides based on the what I could go to the literature. Dr. Puneet, you came, sir. Start, please.
Actually, first, just a few comments. One is, I was very happy to see a gastroenterologist actually caution us about UDCA, because every single prescription I have seen of a patient coming to me with gallstones referred from a gastroenterologist has UDCA in the prescription. So I wish this is shared in the ISG as well. So the second point about UDCA is that we have different stone distributions across the country. The epidemiological studies from Tamil Nadu and Kerala show black pigments. UDCA is only effective for cholesterol stone, but a large proportion of North India is also mixed stone. So I'm not sure it's going to be useful even in the symptomatic setting. So asymptomatic, recommending is probably overkill. The second is about the polyp. Even the Mumna classification just said, I just quickly looked at it. It's not based on any data, needs to be validated.
Yeah.
It's a review article. It's given a suggestion. So I think before we adopt it, we should be careful. We've recently published our own results from Kerala. 108 patients of ultrasound diagnosed polyps. None of
with the stone. Here we are talking about the stone with polyp.
Ultrasound detect just for polyp, just for the background of polyps first. None of them, I think about 20 or more were operated. None of them actually had polyps. They were all, it's just the ultrasound diagnosis of, so I mean, we need to extrapolate that. Asymptomatic, a stone which is not casting an acoustic shadow is labeled as a polyp. I think all of you showed 95% as polyps are cholesterol polyps. So we should not confuse what we are seeing post facto in a specimen with what we are diagnosing in ultrasound. There's a huge mismatch there. And I mean, the same thing with stones as well as a positive. I agree with Dr. Vinay and Dr. Kosh and all that. We need to be careful before we, first Jaipur Surgical Festival also, there a lot of senior surgeons were advocating routine, and I think we'll need a separate subspecialty of dealing with biliary injuries then. I think we have a simple way of doing, I beseech all the gallbladder cancers I've seen in Kerala, very few of them actually had stones in the specimen. So I really have serious doubts whether and I think it's very easy to look at it by looking at the.
But Dr. Puneet, we very clearly have said that except to tax asymptomatic stones, all our panelists have said that should not, don't require surgery.
Yeah, but I mean, there was subtext that, association of polyp size and all those things.
Polyp association is different. That's why Dr. Nisar said that we have to investigate further. It should not stop there. That is the in a ethnic area where there is a more stone. So I think what you are saying, same thing we have already said, that when there is a stone with the polyp, then little bit more better investigation, periphery ultrasound, we say with institutional ultrasound, all these things have to be taken into consideration to avoid a development of gallbladder cancer. Asymptomatic stone, we are
requesting that all the people who are seeing gallbladder cancers, can they just review all their biopsy reports? The gross report should tell us the actual stone, rather than correlating with the pre-op ultrasound or whatever, because there might be a lot of confusion. There might be calcifications within that. gallbladder, it might be an epiphenomenon. The obstruction of a gallbladder might actually cause stones to form. So I think, we need to look at actual stone or sludge-like things which are concretions which are casting similar shadows. So we should actually have, we can generate that data from within the country. So I beseech we should have a, multi-center study looking at that.
Okay,
And finally,
thank
since, similar to the MUMNA and all that, a lot of suggestions were given. My suggestion, and it's completely without any base, but just a suggestion based on soft data is we could do a HIDA as Dr. Usha suggested, but also to look at the function of the gallbladder to decide whether we're going to need stones. So what I have seen is, and this is unpublished, that's why I'm giving you all those riders before. Many of these patients who have atypical or asymptomatic stones, if the HIDA is showing a non-functioning gallbladder, they have very high chance of getting converted into a and even get complications presenting first time as pancreatitis and all that. So just a suggestion that if we are considering, we could do a HIDA. I know it's going to increase the burden, but at least it deserves a study. And we've actually suggested, I think Nijar would remember, to one of the nuclear medicine PGs.
Okay, sir. Any other comment? Any other question?
Can I just make one comment here, Dr.
Please let the young girl ask question, then I will take your comment.
Good afternoon, sir. Thank you for the amazing talk on asymptomatic. Actually, I'm working with gallstones and gallbladder cancer. I'm doing my research on that.
Please be brief. Please be brief. No, otherwise we will not have time to conclude.
So I want to add a point on that. Like recently, we have conducted a study on the association of gallstones and gallbladder cancer. So the thing which we have found is the association of heavy metals that was found in the gallstones, and they were quite prevalent in these gallstones, which could be the cause of gallbladder cancer. Also, one more thing I want to ask that basically the asymptomatic gallstones, we are also working on serum parameters for diagnosing these gallstones. So can any one of you who are you are doing the surgery for gallstones can suggest some of the serum parameters that we can investigate upon for the gallstones for developing?
So you are working with sir. Sir is the pioneer in all these things, and you can talk to him. He will tell you what are other things are required. Till date, database we have nothing to suggest. So yeah.
Can I come in?
Actually, I have collected the gallstones from the patients who were having gallbladder cancer. We have selected the patient who had gallstones and gallbladder cancer both, and then we have gone for the analysis of these.
Any other query, please, from the audience? So we have please. Yeah, Rohit.
I have a question.
Yeah. Introduce yourself and cast. We have 5 minutes more. Yes.
I am Dr. Rohit, but I am a PGI pass out other student. I am working in Ambala now.
Go ahead. Question. Sir has said only 5 minutes we have.
On practical query that sometimes I have patients who is like 25-year-old girl who is having asymptomatic gallstones. Compared with that, there is a lady who is 65-year-old.
So 20 years, there are suggestions, soft suggestions. Let me come to this thing. I will answer your question. My summary will answer your question.
Should
I will tell. Just wait. Yes, please.
Thank you very much, Dr. Radav. And
please question, please, because we don't have time.
My question is, when the gallbladder stone is asymptomatic and the sludge are present there is doubt or suspicious malignancy is there. Why not we are recommending the PET CT?
Straight away PET CT is not recommended. As I said, you can do a color. You can, if your suspicion is more, you have to take the clinical history also. If our suspicion is more, if you have a loss of appetite, loss of weight, with a stone disease, large stone, there is a sludge, you should think about the gallbladder cancer. And there you can add color Doppler, and you can go one step ahead, do a good CT scan. Straight away PET is till date not recommended. So CT scan will clear.
CT gives only anatomical.
Sir, CT has a clear cut. Even ultrasound has. I
and
have
PET
not.
CT gives the confirmation or detection about 96% accuracy.
Sir, we are
malignancy.
We are.
Involvement
Please
of
listen.
lymph node.
Please listen. If you want to say whatever you want to say, then the panel has no role.
Okay.
The question is, you want to diagnose. See, PET scan is to stage above the CT scan. So here you are talking about suspicion, then diagnosis. If you have a suspicion, there are clear-cut criteria on the ultrasound to suspect a gallbladder cancer. One step above is CT scan. That is also clear-cut criteria. If CT scan suggests gallbladder cancer and you are sure taking the history and all, then you can go ahead and a PT scan.
Thank you very much.
Thank you.
Dr. Yadav, Dr. Yadav.
So we have one more question for some.
So PET CT is not diagnostic of gallbladder cancer. Sorry. So I wish we had a radiologist as well in the panel, because very often what we find is in the report, we need to have whether there is a focal thickening in the gallbladder or not. Sitting in a cancer center, that appears to me as the single most important piece of information in an ultrasound of abdomen where a gallstone is present. Whether there is a thickening of the gallbladder and whether it is focal or not.
Durgatos, this is our coming to that. There is a GB rats published by PGI and Sajjay Gandhi PGI. There are multiple people. Please go and read. Pankaj Gupta is the first author. So you can read it. There are multiple things mentioned in that, and based on that, you can take your decision. So just to wrap up, with the permission of my moderators, there are certain pointers which are sure that we should do it. Like Dr. Nag said, hemolytic anemia disorder is stone with the polyp, as we have discussed with some riders. We are not going to do it. Cardiac transplant data seems to be shifting towards the getting asymptomatic stone being operated. Other elective operations usually no. Asymptomatic stone no. Gastric cancer, as Dr. Durgatos said, case to case one can decide because you are working in the same area. And the porcelain gallbladder, there is no suggestion, but we have to investigate more to rule out the gallbladder cancer. So what is the Indian scenario? I am quoting the sir's article, and if you see, Rohit, your question also, the young females which is going to survive, we are more than 20 years, we are thinking that there is a life, and if a patient is asymptomatic with a large stone, they have that, then we can go ahead. In North India, again, I said, these are the soft indications. Sir has suggested large stone, and Dr. Mohan Das data in 2006 suggested that cholecystectomy or asymptomatic gallstone can reduce the gallbladder cancer, but nowadays it's not a practice. So this is the what is that summary of the whole panel. So comment, sir, you
can I just come in here 1 minute, please?
So
yeah.
Dr. Usha, you please finish in 1 minute because we have time is running short.
Yeah, 30 seconds. Here we have just finished a PhD study. 220 patients of gallstones who were symptomatic underwent cholecystectomy. Their gallbladders were analyzed in detail. 40 to 50% have metaplasia of the gallbladder. Studies from Chile have shown that the gallbladder cancer is through the inflammation, metaplasia, dysplasia pathway. At the age of 44, 50% of our symptomatic stones are having metaplasia. That means if we hadn't operated, a subset of this would have gone on to develop cancer. So it is the large stone and a lot of bacteria on the stone and the gallbladder. 82% are culture positive mucosa. So my suggestion here is we should keep this discussion open and not close it by saying that no elective surgery, but these patients have to be on very close follow-up for any early signs. And as Dr. Yadav suggested, we have published GB-RAD from PGI, and this is a multicentric thing. Please read it and see how you can utilize it in clinical practice. Thank you.
So just to respond to your query, because asymptomatic stone we have discussed in detail, metaplasia usually doesn't translate to the dysplasia and cancer. That is one. Second is that there are discussion about metaplasia. If that is the reason, then it should have a squamous cell carcinoma rather than adenocarcinoma. So adenocarcinoma is the commonest. So I think those things cannot be translated. Yes, observation in a high volumes area is very important. Thanks everybody. Thanks my honorable panelists and sir for giving us this opportunity. Thank you.
Thank you, Dr. Yadav and the panelists. I think we will interrupt for 2 minutes because some of the students want to go. So last 2 days prizes we will announce so that they can receive physically. So what we thought that for each oral paper and poster paper each day we will prize, we got 5 sets of the book Surgical Gastroenterology by Dr. Sanjeev Haribhakti. They have been given as a gift by the publisher, Paras Medical Publisher. So in the liver group, in the oral video and interesting cases, Dr. Arun Kumar ML, but since he is a senior person consultant, we will only give you a certificate. We will reserve the book to be given to a student. Ajay, can you please come? Ajay. In the student category, Arun Kumar A. So you are getting a set of the book by Dr. Haribhakti. Arun and Srijit have shared because they scored equal. We are giving you one set. You need to exchange with each other. In the poster group, Dr. K.A. Siva Subramanian. Dr. Sanjeev Haribhakti, again, like Dr. Ajay and many others who are present here, is an SGPGI alumnus, now a consultant GI surgeon in Ahmedabad.
At Mahatma Gandhi Medical College and Hospital for conducting the second Jaipur Surgical Festival.
Dr. Mithun, second. I will try my best to request the publishers if they can give more copies, then we will send the copies to the second prize winner. For the next day, Ayush. Ayush. Second prize, Vibhu Jain. Murlidhar. Dr. Murlidhar. Anybody from Ayush College that receive it on his behalf? Only the picture is for you. Congratulations to all the winners. So the next session is was to be by Dr. Adarsh Chaudhary, but he indicated that he cannot come, and he said that he will participate online. But he has sent a video which is not by him. I was thinking of skipping this session, but since one of his young colleagues, Dr. Diksha Kapoor, has done all the work, she has recorded the video as a replacement for him. So we will just run the video. We will not have any audience discussion on that. Diksha, are you online?
Yes, sir. Good afternoon, sir.
Yeah, so since you've done all this, we will play the video. Okay.
Thank you. Good morning, everyone. I would first like to congratulate Dr. V.K. Kapoor and his department at Mahatma Gandhi Medical College and Hospital for conducting the second Jaipur Surgical Festival, with a focus on HPV oncology. It is a great opportunity for the postgraduates to learn from the best in HPV surgery. It is truly an academic fest which brings both national and international faculty on a common platform. Today, I'll be talking to you about lymphadenectomy in carcinoma gallbladder. This is an important area of discussion because carcinoma gallbladder is endemic in India, and all of us in our surgical careers are going to see a lot of the disease. And lymphadenectomy and the importance of it is an important concept in the surgical management of this entity. My talk will include the patterns of lymphatic spread and lymph nodal stations important in CA gallbladder. What is the importance of para-aortic lymph nodes? How positivity of lymph nodes impacts systemic therapy, and what is the standard of lymphadenectomy and what all should be removed in CA gallbladder. It's very important to understand what lymph node stations are important to us while doing a lymphadenectomy for CA gallbladder and what are the patterns of spread. So the closest lymph node to the gallbladder is the cystic lymph node, followed by the pericholedochal lymph nodes, the lymphatic spread to the hilum, nodes anterior and posterior to the right hepatic artery, common hepatic artery, and the celiac axis. Moving posteriorly, lymph nodes behind the main portal vein, moving down behind the head of the pancreas, the superior portion and the posterior portion, and moving further down, lymph nodes along the superior mesenteric vessels, and the interaortocaval lymph nodes, which are considered a site of distant metastasis. Lymph node spread in carcinoma gallbladder is mainly along three routes. From the right side, from the cystic node, the lymphatic can spread down to the pericholedochal lymph nodes, down to the posterior superior pancreaticoduodenal lymph nodes, followed by the superior mesenteric lymph nodes. Along the left of the HDL, from the pericholedochal to the retroportal to the right of celiac. From the right of celiac and the superior mesenteric lymph nodes, the metastatic spread goes down to the interaortocaval lymph nodes. And a third route is from the cystic lymph nodes up to the nodes along the liver hilum. These patterns of spread were initially described by Shirai et al. In 1992, where they studied the pattern of spread using vital staining in patients undergoing surgery for carcinoma gallbladder. Like any other oncological disease, lymph nodes have an important role to play with respect to prognosis in carcinoma gallbladder. And it is intuitive to understand that lymph nodal staging parallels T staging in CA gallbladder. AGCC 7 had a focus on the lymph nodal stations that were positive, and the new AGCC, that's the 8th edition, focuses on the number of lymph nodal positivity, which we'll be discussing in detail. Celiac lymph nodes and interaortocaval lymph nodes are usually associated with worse prognosis, and interaortocaval lymph node positivity parallels distant metastasis in CA gallbladder. These are figures which have been accepted for a very, very long time from a multi-center Japanese study, which quoted that overall rate of lymph node involvement in carcinoma gallbladder is to the tune of 50 to 70%. In T1A disease, lymph node positivity is only to the tune of 2.5%, and it goes up to T1B to about 16% patients. In patients with T2 disease, the rate of lymph node positivity is 44.3%, and T3 to T4 to the tune of 72%. The two T stages here that need discussion are T1B and T2. There was a controversy long ago with respect to the role of radical lymphadenectomy in T1B disease, which is now an accepted dictum that patients with T1B should undergo completion radical cholecystectomy with the standard lymphadenectomy. In T2, the recent AGCC has divided T2 into further T2A and T2B with difference as to where is the tumor located on the side of the peritoneum, which portends a better prognosis, versus towards the side of the liver, which is associated with the worst prognosis. For the role of lymphadenectomy in T1B disease, now there is data from India, looking at a retrospective data from 2010 to 2021. Tata Memorial has published its data of 76 patients with T1B carcinoma, in which they reported a node positivity rate of about 21%. When looking at the survival in patients who had node positive versus node negative in T1B, they found comparable median survival, but there was increased rate of recurrence in node positive T1B to the tune of 43% versus low rate of recurrence at 8% in T1B that was node negative. Looking at the patterns of recurrence, it's intuitive to believe that the survival would be better in T1B, which was node negative, but probably the sample size was small and was not powered enough to give a difference in the overall survival for node negative versus node positive disease in T1B malignancies. The change of AGCC guidelines in the 8th edition, subclassifying T2 into T2A versus T2B, came from these 3 important studies, which went ahead and said that tumors that are located more on the side of the liver has a higher rate of node positivity to the tune of 48% versus 18% if they were located on the side of the peritoneum. That translates into a worse 5-year survival with T2B disease with a higher rate of liver and nodal recurrence. The possible reasons for this are the higher rates of lymphatic and venous spread from the side of the liver versus side of the peritoneum in carcinoma gallbladder. The 8th AGCC also moved the lymph nodal classification from grouping of the regional versus metastatic lymph nodes to the number of lymph nodes. So the 8th AGCC said N0 was if no lymph node was positive, N1 if 1 to 3 lymph nodes were positive, and N2 if more than 4 lymph nodes were positive. This is an important study which gives evidence as to why this change occurred, which was published from Japan, which showed a difference in survival. 5-year survival for no node positive disease being 81%, for a single node positive to the tune of 62%, 2 to 3 lymph node positive to the tune of 43%, and patients who had more than 4 lymph node positive, only 15% 5-year survival. The study is criticized for its long duration. It was a retrospective study and looked at patients that span over 20 years. A number of patients had undergone liver resection and pancreatoduodenectomy. Pancreaticoduodenectomy if the pancreatic head or the duodenum were involved, to obtain good clearance of the posterior-superior pancreaticoduodenal or the superior mesenteric lymph nodes. Also, there was no standard adjuvant therapy regime. Only about 50% patients received adjuvant therapy in any form, inconsistent regimes, and for inconsistent duration. So although AGCC did change the classification of N0, N1, and N2 depending on the number of lymph node positive, but then the impact of lymph nodal stations cannot be completely denied. This is a recent study from 2018, also from Japan, which looks at their data spanning about 26 years. They divided their patients into region A positivity, region B positivity, and region C positivity. Region A being patients who had lymph node positive in the cystic duct, common bile duct, and hepatic artery. B being those who had retroportal and posterior pancreatico superior lymph nodes positive, and C being celiac and superior mesenteric lymph nodes positives. They found that if no lymph node was positive, survival was best, which is expected. But when lymph nodal stations of cystic, pericholedochal, hepatic artery, retroportal, and pancreatico superior duodenal were involved, the outcome was similar. The worst outcome was there in patients who had lymph nodes at the celiac axis and the mesenteric veins involved, and the survival in these patients paralleled survival with metastatic disease. But the removal of posterior superior pancreatic or duodenal and the celiac axis nodes is still recommended. There is evidence to suggest that there is skip metastasis and towards the posterior superior pancreatic or duodenal lymph nodes, and they tend to have a worse prognosis. And sometimes patients with positivity of posterior superior pancreatic or duodenal lymph nodes and celiac lymph nodes have a similarity in overall survival. But the recommendation is that all of these lymph nodes should be removed because it improves staging. And there is a lot of evidence which goes on to suggest that probably one of the most important prognostic factors is the lymph node ratio, not the absolute number of lymph nodes removed, not the lymph nodal stations, but the lymph node ratio. Initial evidence for lymph nodal ratio came from a study from India by Dr. Negi and Dr. Chaudhary, which looked at around 60 patients of carcinoma gallbladder who underwent surgery and said that if the lymph nodal ratio was more than 0.50, it was a poor prognostic factor for overall survival versus those who had a better lymph nodal ratio. The accepted figure these days is a ratio of 0.15, which is an important predictor, which comes from an important study published in 2015 in Annals of Surgical Oncology, which was a multi-center study looking at large data from 4 high-volume CA gallbladder centers across the world, which said that if the lymph nodal ratio was more than 0.15, it portended a worse prognosis. So the recommendation still is to remove the posterior superior pancreatic or duodenal lymph node, which is found behind and below the portal dissection. So for this, while doing the right-sidal portal dissection, the hepatic artery proper and the gastroduodenal should be exposed completely. An artery coming from the gastroduodenal can be traced encircling the bile duct at its lower end, reaching towards the posterior aspect of the pancreatic head, where the posterior superior pancreatic or duodenal lymph nodes are found. Further extension of this goes on to the retroportal lymph nodes, and further dissection towards the posterior and medial side from the retroportal lymph nodes exposes the celiac lymph nodes. The celiac group of lymph nodes can also be approached from the top, extending the dissection from the common hepatic to the celiac. Interaortic group of lymph nodes are an important group of lymph nodes when we are talking about carcinoma gallbladder. Evidence comes from this Japanese study published in 2000, which said that the patients with distant metastasis and those with para-aortic lymph node positive had a parallel in their overall survival. They also went ahead and reported that a high number of patients with posterior superior pancreatic or duodenal lymph nodes positivity had a high para-aortic lymph nodal positivity rate. They also mentioned that positive para-aortic lymph nodes was associated with poor one-year survival at 43% and a median survival of 5.8 months. So generally, if the para-aortic lymph nodes are positive in patients with carcinoma gallbladder, further resection towards a radical cholecystectomy is not recommended. Evidence from this comes from an important Indian paper published in 2013 by Dr. Agarwal, which said that interaortic lymph node positivity was a poor prognostic factor, and routine sampling and frozen section at the step of initial exploration can avoid surgical procedure in about 19% patients. There are some authorities who don't absolutely believe in this concept. And in a young patient, fit patient, even if interaortic lymph node is positive, there may be a role of giving the patient the benefit of radical surgery followed by adjuvant chemotherapy with possibly some survival benefit. So this is an important question. What is the role of lymphadenectomy and what is its impact on adjuvant therapy in carcinoma gallbladder? This is an important study, which is the BICLAP study published in 2019 in Lancet Oncology, which looked at capecitabine compared with observation in resected biliary tract cancers. This was a randomized controlled multi-center phase 3 study which said that lymph node positivity patients benefited from capecitabine, and on a subgroup analysis, which went ahead and said that patients with muscle invasive carcinoma gallbladder also benefited from adjuvant capecitabine. This is, although the total number of patients with carcinoma gallbladder was only 79 in this study, but this is still probably one of the largest prospective data suggesting the role of adjuvant therapy in CA gallbladder in T3 plus and N1 plus disease. This was a systematic review and meta-analysis, which also supported the use of adjuvant therapy in patients with lymph node positive disease. This looked at about 6,700 patients with bile duct and gallbladder tumors ranging from a very wide time frame of about 50 years from 1960 to 2010. But the odds ratio does support the role of adjuvant therapy in lymph node positive disease with a p-value significant at 0.004. These two beautiful studies published in 2021 have 4 very important messages to convey, which are that proper lymphadenectomy is important for accurate staging. So removal of level 1, level 2 lymph nodes is recommended, and lymphadenectomy improves survival in patients with carcinoma gallbladder. The studies also reported that there is a wide variety of what we call adequate lymph node dissections. The values vary from east to west. The Japanese, of course, have a higher tendency to do a radical lymphadenectomy in patients with carcinoma gallbladder, whereas a huge sect of American surgeons would probably do only clearance of level 1 lymph nodes. And therefore, the standard lymphadenectomy is underutilized. And of course, lymph node positivity is an indication for adjuvant therapy. This is my second last slide, and I'm just going to summarize what is enough when it comes to standard lymphadenectomy in carcinoma gallbladder. So it is removal of the lymph nodes around the cystic duct, the hilum, moving down along the hepatic arteries, the anterior and posterior to it, those behind the main portal vein, moving towards the left along the common hepatic artery, going towards the celiac, coming posteriorly, the retroportal vein, the retroportal lymph nodes, and inferiorly, the lymph nodes along the head of the pancreas, the posterior superior, and if feasible, the removal of the station 14 lymph nodes exposing the lower part of the uncinate process, although this is controversial. But all of this radical lymphadenectomy is probably done if lymph node station 16B1 is negative on frozen section analysis, barring a few select patients who are young, who are fit, and are likely to benefit from a radical resection, even in the positivity of lymph node 16B1 station. So this is my last slide, and I just want to summarize by saying that radical lymphadenectomy is recommended in patients with T1B and above disease. The recommended lymph nodal harvest is at least a 6 according to most recent guidelines and society papers. Removal of level 1 and level 2, which includes the cystic duct, pericholedochal, lymph nodes along the hepatic artery proper, common hepatic, and celiac, retroportal lymph nodes, and lymph nodes along the posterior superior pancreaticoduodenal lymph nodes are to be removed in level 1 and level 2 clearance. Lymph node ratio is an important prognosticating parameter, and therefore a proper lymphadenectomy is recommended. There is a role of doing frozen section analysis in patients before proceeding with a radical cholecystectomy, so that if a para-aortic lymph node positive status is found, there may be relevance in abandoning the procedure in patients who are not fit or are elderly for a radical cholecystectomy. If the lymph node status is positive, it is an indication for adjuvant therapy in patients with carcinoma gallbladder. Thank you.
Thank you, Dr. Diksha. Moving to the next session.
Good morning,
Next session
everyone.
is on.
I would first
Would you like to say something?
Hi, Dr. Anand. No, thank you. I think the recording played again. Thank you for giving me the chance, and I hope I did some justice to the topic.
Now moving to the next session on the choledochal cyst and the cancer. What is the evidence? For this topic, I would like to invite the chairperson, Dr. N.R. Das, sir. Dr. N.R. Das is a senior professor at the AIMS Delhi, Department of Surgical Gastroenterology. And for the online, our chairperson, Dr. R. A. Shastri, he is the senior consultant and GI and HPV surgery at KIMS Hospital, Krishna Institute of Medical Sciences, Secunderabad. I would like to request our chairperson to invite a speaker on the diet.
Is Shastri sir is online? Is he online? So, good afternoon, sir. Can you hear me? Okay, good afternoon. And we are moving on to the next session on another possibly pre-malignant condition, or is it? To speak on that, I would, it's a privilege and honor for me to request Dr. Puneet Dhar to give his version on this topic. He is at present director and chairman, Amrita Institute of Medical Sciences, Faridabad, and earlier, prior to this, he was in the parent organization in Kerala. All of you know him. He has been here all over. Dr. Puneet, please.
Always a pleasure to be here. Thank you for the kind words. Bring you greetings from Amrita again in the second innings. So I think choledochal cyst is a concept, a faith, a belief. It's called congenital. We're not sure it's congenital. We found evidence of it being acquired as well. Patients who've had cholecystectomy, cholangiogram established no bile dilatation, suddenly later in life they get it. It's not a cyst by the surgical definition of a cyst, because that's a lined, epithelial lined sac which is closed on all sides, which is open on both sides. So I think biliary ectasia would be a more appropriate term. Of the choledochus, the etymology is the part of the bile duct where the cystic duct is already joined the common hepatic duct. So from then on, it's been expanded, from Barter, who first described it, to Alonso Ledge, who described, added two more, and to Dani, who added further. And there are attempts by various people to add 6 and more. But I think we probably need a simplification as far as the malignancy part is concerned, because eventually it's about symptoms and malignancy. So I think when we look at imaging, we all get that moment of epiphany when we realize that it is not a biliary obstruction when you look at the MR or CT or whatever. And we find that there's no discrete cause of a block, but there is an abrupt change in caliber at the hilum. So, I mean, beyond just the dilatation, I think we even had frustrated attempts at including things where there is no biliary dilatation at all, the form frustrated by Lilly, where you have all the other features of typically seen with choledochal cyst. Even though, I mean, I join issue about the typical features of histology, because there's nothing typical. It's just, the features of inflammation in the bile duct wall. So you'll always find the report as consistent with choledochal cyst. It's never pathognomonic of choledochal cyst. And therein is a clue for the carcinogenesis also, perhaps with all the metaplasia, dysplasia and all that. And which is treated by resection HA, normally causes an improvement of the symptoms. Incidence, we don't really know about the parent entity itself. 1 in 1,000 in Japanese, to 1 in 13,000 to 150,000 in the West. India, we don't have hard data. I tried searching extensively on this. I didn't find any data. I hope the PGI, where they do routine autopsies, could give us some idea, but we don't have that at the moment. I suspect it is somewhere in between, closer to the Japanese with the way we are seeing it in, on imaging and all that. So most of them are diagnosed after symptoms, but which used to be 10% earlier, but now in the recent decade, with widespread availability of cross-sectional imaging, it's about 36% are diagnosed. So many of them tend to be asymptomatic. So we need to know that whether we need to treat only based on symptoms or the actual risk of developing a malignancy. There's a very few benign diseases where we actually do prophylactic surgery. It's always a quality of life issue. Whether it's chronic pancreatitis or achalasia or whatever, it's always a palliative thing in a benign disease. But here we do it even without symptoms because of the risk of developing malignancy. So we need to know what is the actual incidence. Getting an early malignancy is invariably a chance, and getting a symptomatic malignancy, the survival is poor. So, getting an equipoise is extremely difficult. So what are the questions we need to ask is, what is the risk of cancer? What is the need for surgery and when do we time it? What is the frequency and modality of monitoring if there's any residual risk as well? So this excellent study a few years back actually pulled all the data till about a decade back, and large proportion is of course from Asia. In fact, some of the Asian centers had, it was more than the entire experience from the West, Europe and US. So the findings for adults, because they looked first at that, the malignancy is there in 7.5%, and most of this was in the adult population. The true incidence is probably unclear, as most are reported from surgical specimens. So we wouldn't really know as the incidence in the ones who are not operated. So it'll miss out all the indolent tumors, some of which may be a window of opportunity, or who knows, like neuroendocrine tumors, G1, they may actually not need any treatment either, like those metaplasia and dysplasias in gallbladder cancer. Bulk of them are from the bile duct wall itself, so they are cholangiocarcinomas. A small proportion are gallbladder cancers, and much rarer it is to get in stomach, in pancreas, and the periampullary region. So you can have the duodenum as well. Prognosis is uniformly poor, especially for the symptomatic cysts, not just the symptomatic malignancy. Where the cysts are symptomatic, the prognosis is uniformly poor. And most series have a survival ranging between 3 and 48 months after diagnosis of the malignancy. A bulk of them actually less than 36 months. The commonest is actually seen in type 1 and type 4, which forms the bulk of, it probably parallels their incidence in the among the parent entity itself, having most malignancies. So that's one of the reasons why I wonder whether 2 and 3 should really be choledochal cysts. 2 are very rare in most series. 3 is actually lined by duodenal mucosa, so I'm not sure if they would be, bile duct. It should be in the definition of bile duct cysts at all. APBDJ has the highest association with malignancy. In addition, it's found commonest in Japan, and the least was in US. The least was actually in Indians, followed by the US. So some sort of food for thought there. Interestingly, it was, progressively, decade by decade, there's an incremental increase in incidence. So clearly, we do not need to do it early at diagnosis in childhood. Enough, evidence for that. Now, whether we need to do it in incidental choledochal cysts, there are no prospective randomized studies. Just like I wish there were randomized studies on asymptomatic gallstones, we just don't have them. All of them are association studies. There are no autopsy data, no data on intentional follow-up of asymptomatic cases, all of which can be sort of looked at. The data may underestimate the true incidence as well as the role of in situ or indolent cancers. The metachronous cancer in the intrahepatic part, both ends, the ones which are not resected actually, is possible, but it's rare. Per primum it is rare, but does exist. So prima facie, it's quite clear that excision of an asymptomatic choledochal cyst would significantly improve prognosis. Historically also, we have some evidence that, before excision was routinely recommended, when they were doing bypasses, there were very high chance of recurrent symptoms, strictures, and cancer, which was higher than the population. Justification for prophylactic excision is inability to diagnose malignancy accurately early enough before surgery, even if you use PET and all that. Low morbidity of surgery, relatively low morbidity of surgery, because most of this is done in experienced centers. And there's poor outcome with initial expectant management of asymptomatic cysts. And poor prognosis once the cancer is diagnosed. So with all this, probably there is a case for a justification. We don't really need to prove the exact data. So, I mean, even now, it would be, the last year also, it's a case report when you get a long-term tumor-free survival. So it's with that dismal prognosis, probably it's wise to, go for the prophylactic surgery. So why does cancer happen? Don't really know. Probably quite likely that stasis, infection, bile acid acting as mutagens, the metaplasia, dysplasia. But as TD said, if it is the metaplasia route, it should be squamous. And actually, there are a few squamous, but mostly in the lower parts, in the duodenal ends, which are associated with this. APPDJ, even without cystic disease, but with cystic disease also, it's very high. So some role for reflux there, and genetic factors. And this, chart shows you all the possible, reasons why those things could happen. A variety of mutations and all that, factors and inflammatory reasons. Again, to show that early enough, the same study with same group from Hanover, which showed the previous one, also showed that if it's resected early in childhood, none of these the KRAS or BRAF mutations are seen as markers of malignancy, or even the inflammatory markers were not seen in early on if it's resected. So some evidence that you can actually delay it till they're adults. So how long to follow up after, what is the risk of post-op cancer if we've resected a choledochal cyst? There is definitely a pre-malignant potential of the entire biliary tree. Whether this is a field change or it's stasis, we don't really know, but it is there. There is a role of the method of bypass, some soft evidence if if it's used as a hepatoduodenostomy, because many pediatric surgeons consider that a more physiological, that you're getting the bile back into the duodenum, and some, especially in children, it used to be advocated. But some soft evidence that, the pancreatic ferments are still there to reflux into the bile duct and possibly cause carcinogenesis. Whereas when we are doing a loop of jejunum, there is no mixing of there's not enough space for the pancreatic juice to go up the bile duct and potentially cause deep carcinogenic. The residual disease, it could be a manifestation of actually a pre-existent some form of dysplasia or in situ cancer. And there is again soft data in case reports and all that, where they showed that when they went back to the native biopsy reports, they found that there was some changes there. So it could be a pre-existent cancer, and most of these are manifested in the first 2 or 3 years after the resection. Incomplete removal of cystic elements, of course, is intuitively would be having its effect, and many studies have attested to this. Both the proximal end, leaving the cyst on the hilar end, and the distal end, for fear of causing pancreatitis or damaging the pancreatic duct, especially given the long common channel, that this could, these could cause cancer as well. So this. After cyst excision, 28 patients, of which 23 were analyzed because complete data was available for them. So 6 had intrahepatic, 8 had at the hilum or the anastomosis, in the proximal remnant cyst in 3, and in the distal remnant in 6, so substantial amounts. And the risk of subsequent, this is another review which showed risk of subsequent biliary malignancy in patients undergoing cyst excision is 13, 15, 23, and 32 years after. So there is some field change or some other issue which is at play. So there's a plea for a long-term follow-up, lifelong follow-up. And those are the recommendations, although especially these recommendations, yearly abdominal ultrasound, laboratory controls. I'm not sure whether there's no evidence again that this is shown useful. CA99, at least in the chronic pancreatitis cohort, Dr. Balkrishnan had a huge series which every single patient with elevated CA99 that he sent to us had, inoperable advanced malignancy. So I'm not sure we'll find it, but I'm not sure whether we'll find it at a useful stage. So we still don't know the best way. So I would take issue with the standard classification and probably agree with this gentleman that the standard classification scheme may be confusing as far as the malignant etiology is concerned. And the type 1, type 4, there is the type 1 also has intrahepatic elements. Just like the hepatitis B carrier, all of them may have some liver disease. Just like that, there might be already some intrahepatic, and it's just what is manifest at that time. So they're probably a single entity, and all the others are actually completely unrelated to choledochal cyst and should no longer be thought of as subtypes. So to briefly summarize, there's a clear association of colorectal cysts with cancer, but most studies are retrospective. Even asymptomatic biliary cysts should be offered prophylactic surgery. There's enough evidence for that to reduce the induction of malignancy. The commonest is cholangiocarcinoma, followed by cancer gallbladder. It's common with Todani type 1 and 4, and with the presence of long common channel. There's a risk after cyst excision can be maybe linked to the radicality of the resection of the cystic component itself. So we traditionally remove the entire extrahepatic elements, but there's a tendency to leave at both ends. So that should be carefully done. And the cancer can be delayed even long-term, so a lifelong follow-up and surveillance is needed. And unfortunately, despite all this, the outcome is poor, despite all this aggressive treatment, including surgery, or once malignancy is actually present. I thank you for the patient listening.
Thank you, sir, for that crisp and to the point discussion on this topic. Though I think you would agree that we don't have enough evidence to give clear-cut recommendations on this issue. If Dr. Sastry is online,
so you're muted.
Should you comment something, sir? In the meantime, if any questions from the audience. Sir, please.
This is being recorded, I think, for the
dilemma. I have a patient, 60 years, incidentally detected polyps. Am I justified in offering thinking that in a routine practice, 35, 40 years in the case, thinking that it then pre-managing
So I don't have clear answer that, I was laughing because I had the exact same, I was going to show you those images where, the PMR, I have exactly same 60-year-old patient who was actually diagnosed incidentally as gallstones because she was asymptomatic. For some reason, she underwent MR, full angiogram. MR showed, that typical fusiform cyst. Now, since it's fusiform, she also had atrophic pancreas. I was going to show you that MR, but in the interest of time, I actually cut short that. But absolutely something which we face, we don't have any clear answers. In this patient, my worry is whether we are missing an actual malignancy. So I've booked her for a EUS, to make sure that there's no malignancy or none of these stones are there. In fact, the MR missed the stones. It was only on ultrasound that we saw those stones. So, but the age data does show that the later it is, so, the belief that intuitively we feel that if they're younger, they have a longer lifespan to get a malignancy. So we should intervene early. But if somebody is escaped early, I'm not sure. I think it should be balanced with the actual risk for that patient. So if she's otherwise fit in this day and age, many of our relatives live up to 90, 100. So we should take it as with that thought process that they are actually probably more likely. We saw that decade by decade incremental increase. So if they're otherwise fit, we should probably recommend a resection. It's easier if it's symptomatic, of course, but if it's choledochal lithiasis, you're saying? Oh, with the cholecyst. Yeah, absolutely. Yeah. So a very difficult this thing. So I think if it's done at an expert center, there is not really a huge difference in. I mean, do you remember any choledochal cyst in an uncomplicated patient? So if there is no portal hypertension, no inflammatory changes, none of those things are there. It's a straightforward. It's just that instead of a lap, it might be open, and many people are happy to do it even laparoscopically. So I don't think there's going to be a huge difference in mobility if the patient is otherwise fit. The issue comes in, when the patient is unfit, and to what degree of unfitness that we need to look at that. So it's if you're operating and you counsel them before, it's a good idea. I remember Dr. Aranya's last patient, GB Pant, as he was leaving, it was something like what you're describing. We didn't know it was pre-op, but on per-op, the GB actually avulsed top. That was the exact last case. And he said, I've been giving lectures on bile duct injury, and now I have to go down with this ignominy. And we put in the choledocoscope, and there was a huge choledochal cyst which had been missed in the pre-op imaging because we only used to do ultrasound, and they had missed it. So because we didn't have a consent, so the answer was easy. But in your case, I think if you're reasonably certain that you're not going to increase the morbidity of the procedure, it's probably better taken out, especially in the elderly who have actually got a higher risk now, even now. So we don't have evidence that finding it, spyglass being normal, are you going to do a spyglass every month, every year? When do you do it? We don't know that.
So before the next question is asked, Dr. Sastry is online. So sir, would you like to comment something? Is he online?
And he's got his hand up also, I think.
Yeah.
Dr.
Please
Shastri,
go ahead,
sir.
sir. Sir, can you hear us?
There might be an internet issue.
Someone can try to
Till then,
connect
Arun
to him
can.
and then indicate to us again.
I think Arun.
Sir, somebody in the age group of 40 to 80 years, totally asymptomatic or minimal symptoms, something like dysphagic symptoms. Ultrasound showing a dilatation of CBD more than 11 to 14, 15 millimeter. MRCP showing could be an early type 1 or Comipus 1C type of an early choledochal cyst. In this age group, is it worthwhile before jumping into a choledochal section to wait for 1 to 3 months?
Absolutely. So like I said, this patient I was just talking about, I've told her that since she has stones in her gallbladder, I don't know whether it could be a passed off stone. So the EUS also have actually planned a little later. By then, if there's any inflammation there, all that would have also subsided. So absolutely, the malignancy is not going to come tomorrow. We don't need to scare them the way we scare them in gallstones, that you're going to get the malignancy tomorrow.
Extremely rare, but there is a potential that such a patient can evolve into an early periampullary or it's an very early manifestation of an pancreatic adenocarcinoma or a periampullary carcinoma, which can.
So somebody has to be very unlucky to get in that very first 3 months. So definitely worthwhile with that scenario that you said that of gallstones, there could be a temporary dilatation, ectasia because of the passing stone. So I think it's worthwhile waiting.
So thank you for your talk. I just have a few comments. We keep doing quite a few. And we have in fact written a chapter under review in the upcoming GIS annuals, and we have labeled them as choledochal malformations, as many authors have done in the past. Regarding the malignancies, as you rightly pointed out, in fact, these are seen only with type 1 and 4. And most authors feel that, it is perhaps because APBDJ is associated only with 1 and 4, 3 and 5 do not have associated APBDJ. That's the most accepted hypothesis. But based on my all experience, which is, of course, not published, so you may discard it outright, I rarely ever get to see APBDJ in our patients, even if it is type 1 and 4. And I've had at least about, 2 patients who had earlier been operated elsewhere, where I've seen malignancy. One in a girl which had a hepaticojejunostomy, not choledochal in childhood, but developed and developed a cholangiocarcinoma, and one of the severe remnant choledochal cyst.
You're talking about APBDJ?
Yeah, I've seen these.
No, but how have you assessed the APBDJ? It depends on the technique. If you're saying on ultrasound, we won't be able to say. So
Yeah,
even
MRCP.
even MR, I know we keep saying it's close to the gold standard, but I'm not sure it is. Even in internal pancreatic fistulas, we've burnt our fingers a lot of times. So it's prone to, it's if you get to see a good APBDJ, it's there. Yeah. But if you don't, so I'm not sure you can say that we don't have an APBDJ. You get my point? Yeah, so getting an APBDJ is positive predictive value is good, but I'm not sure the negative predictive value. But if you have ERCP evidence of no APBDJ, I would take that as hard evidence. But so that's a very good way of looking. Look at all your ERCP data. Yeah, we do have an active center.
We do get to see the biliary duct and the pancreatic duct cancer, and we go by the definition of 15 millimeters. But then you're right that the pancreatic juice can still reflux even if it is say 2 millimeters. Yeah. So it can reflux and it can give rise to a malignancy. Having said that, in my own experience, I've seen at least about 4 patients who had carcinoma gallbladder, a dilated bile duct, and it was not reported at choledochal. And I would like to convey this message based on my experience, which is unpublished.
No. This is published actually. APBDJ is more associated with gallbladder cancer. So if you have with or without choledochal cyst, but APBDJ is actually more, for some reason, I still wonder whether the refluxate would get into through the valve of Pfister selectively, but it's described more with gallbladder
But
cancer.
I've seen some operation notes done elsewhere, wherein people have found a carcinoma gallbladder, a dilated bile duct, the LFT was normal, there was no superior pancreatic or duodenal node, and somehow they missed on realizing that it would have been a choledochal cyst because the patient was never investigated in the past. And I think that should come in the operation notes and the diagnosis, which could have been missed choledochal cyst. So in a
No, you're
scenario of
absolutely right. I
CAGB,
think missing it is very common.
Yes.
That's absolutely true.
Yes.
Absolutely true.
That's
Like I
what I
said,
wanted
it
to
jumped
emphasize.
from 10 to 36% when you use the imaging. Absolutely.
So I think for any dilated bile duct in the absence of superior pancreatic or duodenal node, normal LFT in the setting of carcinoma gallbladder should be labeled as a choledochal.
Okay,
And
from
if we
prostate,
go by
okay.
that definition,
Yeah.
it might so happen that the incidence of carcinoma gallbladder might be actually higher than cholangiocarcinoma in this setting.
That's a valid point. That's a valid point in given our setting of higher,
So Dr. Sastry is online. So before I go on to him, I have 2 points. One is it pertinent that in a asymptomatic choledochal cyst, if you find on imaging APBDJ, are you going for a incidental resection of the bile duct? Second question is whether presence of stone increases the rate of malignancy in choledochal cyst.
So the
So
second question
I didn't find this.
The second question is easier, no, but because it's an epiphenomenon. But the first question is a little more complicated. Sorry, what was it exactly? That if
in a asymptomatic choledochal
yeah,
cyst,
so
if
I
you
think
find
the presence of APBDJ is an independent risk factor. Choledochal cyst is the two are very frequently correlated, but both are independent risk factors. So even without the APBDJ, an asymptomatic choledochal cyst, if would be a candidate for surgery, a definite one. It's all those borderline ones which are little dodgy.
Okay, thank you. Sastry sir, please, for your valuable comments.
So you're muted, at least the voice is not
We
coming.
can't hear you.
It's not showing you as muted, but you're muted, I think. No, sir.
Have you unmuted, sir?
There's no mute sign there. So now you muted. Now you're unmuted, but we still can't hear you. You'll have to log in again. Is the mic volume okay, sir? Yeah, it's I think a volume issue. It's very, very faint now. I think they're hearing it from Dr. Kapoor's phone now, not from. Yeah, you can speak into the phone. We can hear it from Dr. Kapoor's phone, actually. Speak into the phone, sir. उसको निकाल दीजिए. Yeah. From the laptop, yeah. Sir, speak on the phone. We have Dr. Kapoor's phone on the mic. Yeah, you can speak into the phone. Huh. Yeah, please carry on. Yeah, I could hear many. I was partly listening to the APBDJ. I think it's very important to recognize APBDJ, particularly in the elderly and the middle age with age-symptomatic choledochal cyst. You always have a problem with a choledochal cyst asymptomatic presenting in a 60-year-old or a 70-year-old. You are not sure where the risk of malignancy would stop. There is no guideline as to that. So in a 70-year-old when a choledochal is present, I think as APBDJ is an associated factor, I think it should operate. Even otherwise, in a fit patient with a good performance status, it should operate because malignancy is quite high in these patients.
29 years she has remained asymptomatic, and for the past 1 year she has recurrent cholangitis and repeated imaging did not show any mark. And she was called up a drainage. The PTPD was done and it was internalized. And when he operated, she was surprised we found a cholangiocarcinoma there. Not only that, with malignant ascites. So one precious year was lost. So I think it's an important call to recognize that choledochal cyst keeps its malignant potential for a long, long time, and it keeps increasing with age. What to do with patients with APBDJ but no choledochal cyst even? How to recognize that, because the malignant potential is present as far as the gallbladder and pancreas are concerned with APBDJ. That is a question, how to recognize that, and when do you suspect even that they have APBDJ. That I think is one area which requires some clarification, but we don't as yet have any clarity there.
I think that answers partially Dr. Dash's question that it's a
Yeah.
double whammy if you have APBDs as well. You probably can push a little harder.
It's always a pleasure to discuss something where you have very little evidence. So there the experience comes up. Thank you for a very nice discussion and nice presentation. Thank you, sir. Thank you, Professor Sastry and Dr. Punita. Thank you, audience. With this, should we close the session for lunch?
Thank you, sir, for this chairing the session, and I thank you for speaker, sir. And now we'll have a lunch time, but we'll take a break for half an hour, and we'll start at 2 o'clock. I will invite you for lunch. Thank you, sir. Surgical Festival. I would like to invite our two chairpersons, Dr. Shrishti Jain, who is the director of the ECMO Center and Associate Professor of Critical Care at MGM Jaipur. Along with that, I would like to invite Dr. Biju Potakat, Professor and Head of Surgical Gastroenterology, JIPMA, Puducherry. Professor Biju.
Am I audible? Am I audible?
Yes, yes, sir.
Okay. Can we start?
Yes, yes, please.
Okay, so next session is about perioperative nutrition HPB surgery. And we have a eminent speaker, Dr. Osman Abbasoglu. He's a professor of surgery. He's a general surgery training at Hazretop University, Turkey. And he completed a clinical transplantation fellowship at Baylor University Medical Center, Dallas, United States. And he served as a professor of surgery and director of nutrition support team for long years at Hazretop University. And currently also is the director of clinical nutrition master's degree program at the same university. So we have a very right and eminent overseas speaker to cover this topic. And on behalf of chairpersons, sir, I invite you to deliver the talk.
Thank you very much for the nice introduction. And I would like to take Professor Kapoor and my dear Indian friends for their very kind invitation and also for their friendship and hospitality. In the next 15 minutes, I will talk on perioperative nutrition in HPV cancer. This is my disclosure. And in the next 15 minutes, first, I will talk on the importance of malnutrition and indications of nutrition therapy. Then I will talk on pancreatic duodenectomy, early enteral and oral realimentation after surgery. And finally, I will talk on immunonutrition and conclude my talk. Malnutrition is associated with poor prognosis in HPV surgery. I think this study summarizes very well the risk of malnutrition in HPV surgery. The study was published last year in Clinical Nutrition SPAN, and more than 600 patients were included in this analysis. And the authors found that malnutrition is independent risk factor for mortality. I think you can clearly see in the screen that in liver cancer, in bile duct cancer, and in pancreas cancer, malnourished patients have overall low survival rates. According to this study, I think we can say that if a patient is undergoing HPV surgery, this patient should be evaluated for nutritional status. What are the indications of nutrition therapy? Here, I would like to refer to SPAN guidelines, European Society of Parenteral and Enteral Nutrition. SPAN says that perioperative nutrition support therapy is indicated in patients with malnutrition and those at nutritional risk. There is no doubt. What about the well-nourished patients? For well-nourished patients, we have 5 days rule. If your patient will not be able to take oral food for at least 5 days, then think about a nutritional treatment. And according to ESPAN, enteral nutrition is first choice. Now, I would like to move to pancreas cancer. I would like to share the first series of Whipple, who popularized pancreatic duodenectomy. And this paper was published in year 1941. In his first series, Whipple noted that leak rate was 20% and mortality rate is 29%. These numbers were high. What about in year 2022? Please note that all complications and pancreatic fistula rate has not been changed since Whipple, but the mortality rate decreased significantly to 2-3% in experienced centers. What are the reasons for decrease in mortality rates? I will not go over all these reasons, but I will just attract your attention on the last item, multidisciplinary nutrition management. I think that nutritional management contributes very much to this increased mortality rates after pancreas surgery. Now let's come to surgery. During surgery of a pancreas cancer patient, should we make a nutritional plan? The answer is yes or no. We can use a nasojejunal tube, which you see on the left-hand side. Nasojejunal tube is practical, but there is a risk of dislodgement and may cause discomfort for the patient. What about jejunostomy? Although rare, jejunostomy may result in leaks and bowel obstruction. So I think we can say that consider enteral access during pancreatic duodenectomy only in high-risk patients. It's not a general recommendation. Enteral nutrition is associated with shorter length of stay after pancreatic duodenectomy. This is a meta-analysis which was published 2 years ago, and about 700 patients were included in this meta-analysis. When you look at this figure, the length of hospital stay was significantly decreased in patients receiving enteral nutrition. On the other hand, according to this meta-analysis, there were no differences in fistula rate, infectious complications, and delayed gastric emptying. So this meta-analysis says that enteral nutrition is safe and associated with shorter length of hospital stay. Is it generally accepted in the literature? Actually, no. There are some studies which are in contradiction to the finding of this meta-analysis. This is a multi-center French study on more than 200 patients. Please look at the postoperative complications rate and post-op pancreatic fistula rate. All these complications were significantly higher in enteral nutrition group. So what I understand from this multi-center randomized trial is nasojejunal early enteral nutrition after pancreatic duodenectomy may not be safe in all the patients. We should consider, but please think about safety also while starting early enteral nutrition. Why there are some problems with early enteral nutrition? The reason of enteral nutrition is gastrointestinal dysmotility after pancreas surgery. It's very common. Why? There are many reasons, including paralytic ileus in problem infections. And because of this GI dysmotility, nutritional goals cannot be achieved in many patients. So what should we do in these patients? GI is not working perfectly. Despite this, start tube feeding with trophic EN. Trophic EN means, let's say, 500 to 700 milliliter in a day. It's roughly 20 milliliters per hour. This is trophic enteral nutrition. It's not good enough to feed the patient, but it is good enough to feed the intestines and to decrease infectious complications. What's the solution in patients with GI dysmotility? Supplemental parenteral nutrition. Both ESPAN, European Society, and ASPAN, American Society, suggest that if at least 60% of energy target could not be reached with enteral nutrition alone, please consider supplemental PN. In all my talks, I say that enteral nutrition and parenteral nutrition are not opponents. actually they are friends. So we can use both at the same time on the same patient. And importantly, after re-alimentation, after oral feeding, do not forget pancreatic enzyme replacement therapy. And this is clearly proposed in the International Study Group of Pancreatic Surgery. Now I will move to complications of pancreas surgery. First, and the most catastrophic complication is pancreatic fistula. It's very common after pancreas surgery, roughly 20%. And the mainstay of the treatment of pancreatic fistula is nutritional treatment. This is one of our patients who developed leak and abscess after pancreas surgery, drained successfully percutaneously, and the patient was on parenteral nutrition in the beginning, then enteral nutrition, and recovered very nicely. The second important complication after pancreatic surgery is delayed gastric emptying. Its incidence is around 20%, and again, mainstay of gastric emptying management is nutritional treatment. What are the strategy and goals in delayed gastric emptying? Discontinue oral feeding, energy 30 kilocalories per kilogram, protein 1.3 gram per kilogram per day. And if you have the facilities, if you can advance the tube to the jejunum, please consider enteral nutrition. But most patients may require parenteral nutrition. Enhanced recovery after surgery is very popular in the, basically in the last 2 decades. And early oral nutrition is one of the key elements of ERAS protocols. Now, I would like to share ESPAN guidelines on hospital nutrition. Fortunately, I was one of the authors of this guideline, and this guideline was published last year. And in the next few slides, I will refer to ESPAN guidelines on hospital nutrition. Procedure of re-alimentation after surgery. Many patients could not tolerate early oral feeding after surgery, and we suggest small 5 to 6 meals per day, not 3 main courses. Patients may tolerate 5 to 6 meals per day better than 3 main courses. This may help, but there are some barriers among surgeons. I'm a surgeon. I have to confess that we are not very keen on starting early oral nutrition after surgery. Why? Because of fear of anastomotic leak. Look at here. It's an anastomotic breakdown after pancreatic duodenectomy, peritonitis, a lot of problems. But this is not true. Early nutrition does not result in anastomotic leak, but vice versa is correct. Patients with anastomotic leak may not tolerate early oral nutrition. That's true. And for the correct or precise timing of oral nutrition after surgery, I think we need some more large sample randomized clinical trials. Now, in the last part of my talk, I will focus on immunonutrition. Is European Society of Clinical Nutrition point of view changed over the years? I think the answer is yes. What's immunonutrition? In summary, it's modulation of inflammatory response with substrates like arginine, omega-3 fatty acids, and nucleotides. This is ESPAN guideline in year 2006. It's the old guideline. And in this old guideline, there was a strong recommendation for immunonutrition. 16 years ago, strong recommendation for immunonutrition in surgery. But afterwards, there were some meta-analysis and nice randomized clinical trials were published. This is a meta-analysis involving 61 studies. And you can see on the right-hand side in the figure, this study favored immunonutrition regarding length of hospital stay. Length of hospital stay was 2 days shorter in immunonutrition group. Similarly, infectious complications were also decreased with immunonutrition. No difference in mortality rate. But when we look at in detail to this meta-analysis, the authors analyzed the quality of these studies, and they focused on 8 parameters. Interestingly, none of these 61 studies had high quality. They were either moderate or low quality papers. So we have a question mark regarding immunonutrition studies. Similarly, as a group of physicians, we published a paper in JPAN in year 2019, fish oil containing lipid emulsions in adult parenteral nutrition. In other words, immunonutrition in parenteral nutrition. In general, not enteral nutrition studies are included in this analysis. And again, interestingly and surprisingly, we found that 76% of investigated studies had very low quality evidence. Most studies were underpowered, used inappropriate statistical methods, and lacked details on study protocols and methodology. So we have a problem with immunonutrition studies in surgery. And as a result of this, in the recent ESPAN guidelines in 2021, no evidence for routine preoperative immunonutrition. In selected patients, it may be beneficial, but routine application, question mark. And finally, I want to focus on a very important point, oral nutrition supplements after surgery. As being surgeons, after discharging our patients to home, we forget about their nutrition. They are fine. And mainly oncologists deal with their problems. But we should change this practice. Oral nutritional supplement therapy should not be discontinued as long as the problem persists. These supplements are available, and although they are a little bit expensive, I think we should consider them in malnourished patients or in patients who have malnutrition risk. Dear chairs, dear delegates, I would like to conclude my talk. Patients undergoing HPV cancer surgery should undergo nutrition screening and intervention. If our patient is malnourished, we should make a plan. Any patient who cannot receive normal diet in perioperative period for 5 days should receive a kind of nutrition therapy. This may be oral supplements, this may be enteral nutrition, this may be parenteral nutrition according to the clinical conditions of the patient. Enteral route is preferred in HPV surgery, no doubt. But many patients may require supplemental or total parenteral nutrition. And parenteral nutrition is not a poison. If you do parenteral nutrition according to the guidelines, it's safe. And finally, selected cancer patients may benefit from perioperative immunonutrition. Thank you for your attention, and I am ready to take questions, if any. Thank you.
Thank you so much, Dr. Osman. That was a wonderful session, and we are really lucky to hear the talk directly from the author of the guidelines for the ESPN nutrition. So thank you so much for your wonderful talk. So I belong to critical care fraternity, and I would like to ask you that how frequently do you see the problem related to the refeeding syndrome in your clinical practice, especially related to the ICU patients?
Okay. Thank you for this very important question. Sometimes we forget about clinical nutrition, but sometimes we rush in a hurry to give some nutritional therapy. If the patient is severely malnourished, and if the patient has a severe weight loss, usually 10% in the last 2 to 6 months, and if the body mass index is less than 18, and if the patient didn't take any oral nutrition for 5 to 7 days, please be careful. In my presentation, I summarized the energy goal as 30 kilocalories per kilogram per day, but in the severely malnourished patients with significant weight loss and who were unable to eat orally for 5 to 7 days, we start with a low dose. Let's say 5 kilocalories per day. Instead of 30, we use 5.
Right.
So on the coming few days, we increase this gradually. Why? Because if we overfeed these patients in this critical stage, they will develop refeeding syndrome. And the most prominent clinical features are hypophosphatemia, hypokalemia, arrhythmias, So you may lose your patient while feeding your patient. Thank you for bringing this important issue into discussion. So be careful and watch blood chemistry carefully and gradually increase to achieve your nutritional goals.
Right. So thank you so much also for touching upon the enhanced recovery after surgery protocol. At our institute, we are implementing this and trying to bring this in the culture. But really interesting thing we see about application of ERAS in practice is that we human beings, we tend to unlearn slowly and learn the new things slowly. So that is a very interesting progress. Like after the surgeries, we used to see that because of the fear of the anastomotic leak, patients would be nil by mouth or NBM status for like a day or two. And I think that was the key slide which you showed, that the nutrition wouldn't lead to anastomotic leak. So I think the message which I would like to carry on for all the students here, be it from the surgical fraternity or from the critical care fraternity, that ERAS protocol has to come in our day-to-day practice. So yeah, thank you so much, sir, for your talk. In the benefit of the time, I'll end the session.
Okay, thank you.
Dr. Biju, would you like to ask anything?
Just only one question. Thank you for the nice talk, sir. In the pre-operative period, patients with cancers waiting for surgery, what will be your optimum point with respect to protein status of the patient? How long you will wait and what is your cutoff point?
Okay, as far as I understand, you're asking about the preoperative evaluation and management of patients regarding protein.
Correct. That's correct.
Okay. The main idea is if your patient is well nourished, take the patient to surgery immediately, no problem. But if your patient is severely malnourished, there are some criteria for severe malnourished patients. Body mass index less than 18, lost 10% of body weight, or nutritional risk score is more than 5. In these patients, SPAN suggests 7 to 10 days nutrition before surgery. So feed your patients for roughly a week and then take the patient to OR. And during this period, the protein goal is 1.3 gram per kilogram per day. If you do this, the postoperative complications will decrease. I think this is a big mistake, something we see a cachectic patient with pancreatic cancer, and don't think about his or her nutrition status and take the patient to surgery, and afterwards the patient develops leaks, infections. So 7 to 10 days, protein goal is 1.3 gram per kilogram per day. Energy goal is 25 to 30 kilocalories per kilogram per day.
Yeah, thank you very much. Thank you.
Thank you.
Thank you so much, sir.
So that talk, I think, filled a lot of informational voids as far as nutrition was concerned. And I would like to thank the speaker as well as the chairpersons. So we'd like to move on to the next talk, which would be the role of PET in HPV cancers. I would like to invite the chairperson, Dr. Karan Tipre, who is the professor and head of Department of Nuclear Medicine at MGM. Along with that, I'd like to invite Dr. Monica Gupta, who is practicing as a gastrointestinal hepatopancreatic biliary and laparoscopic surgeon at Manipal Hospital in Vidyanagar, Jaipur. Please, I would like to welcome both of you.
Good afternoon, everybody. Next session is on positron emission tomography in HPB. And I would like to, first of all, I would like to thanks to Dr. V.K. Kapoor for organizing and inviting me this in this conference. And I will call to Dr. Shivendra Singh, Dr. Shivendra Singh, surgeon.
I'd like to welcome Dr. Shiven Singh, sir. He has been our teacher in Jaipur Hospital. He needs no introduction. He is a leading expert in GI oncology and liver transplant services in Delhi. He has done his MBBS and MS from KGMU and MCH from Jaipur Hospital, Delhi. And he has been for as a liver transplant fellow at King's College Hospital, London, UK. And he is member of He's member of various associations, and his main field of interest is laparoscopic, robotic, and GI cancer surgeries. So welcome, Dr. Shiven, sir.
Thank you for kind introduction. First of all, I'd like to thank Professor Kapoor for inviting me and giving this opportunity to be a part of this meeting. So I'll be giving a clinical perspective or surgeon's perspective of PET in HPV malignancies. So I'll be covering mainly in 3 diseases: hepatocellular carcinoma, CAGB, and CA pancreas. Where does the role of PET scan comes in? So as you know, the most common tracer that is used in PET scan is FDG PET, which is commonly used in oncology. It is a glucose analog that concentrates in the neoplastic cells in the proportion of their glucose metabolic activity. So more the glucose metabolic activity is, the more light up occurs on the FDG PET. So increase in glucose metabolism correlates with the presence of more aggressive tumor cells. So more light up on PET scan, the more aggressive tumor it appears. So there are various parameters that is given, SUV max and SUV mean, which are commonly reported. But the other parameters which are important is maximum metabolic tumor volume and total lesion glycolysis, and that is coming, and they are much better indicators as compared to SUV alone. So coming to the SCC, that is the first cancer that I will be discussing. So PET scan is usually not most of the time useful, especially for FDG PET in SCC for diagnosis, because it is not taken up, especially in well-differentiated hepatocellular carcinoma. So sensitivity for FDG PET in diagnosing SCC is less than around 50%. And the tracers which have been used are FDG, which is not of much use. The tracers which are more active, useful, and that are C11 acetate, 18 fluorocholine, and now recently the FAPI, that is fibroblast activated protein inhibitor. That scan is coming in a big way for GI cancers, and other is a PSMA PET that is also coming up for use in SCCs. So problem is the FDG PET is not taken up in with the hepatocellular carcinoma, especially for well-differentiated. So C11 acetate is good because it is taken up in most of the patients of SCC, even for well-differentiated SCCs. Then the drawback is that C11 acetate has a very short half-life. So you have to have a cyclotron in your unit itself. You can't make a nuclear from Jaipur and take it from and do it a PET scan in Delhi. The center cyclotron has to be there on site. Then only you can use C11 acetate. And that is why it is not possible in most of the PET centers. Other that is most accurate is 5-18 fluorocholine, but that is also not very readily available. And this has almost 100% reduction rate in diagnosis for both primary as well as metastatic. And but drawback is limited availability, limited data, and more phase 3 trials are needed for this fluorocloning. This you can see, this is a tumor in the fluorocholine. This is lighting up, but in FDG PET, no tumor is seen. So it is very much accurate as compared to FDG. In here also you can see the PET scan, there is no mets or nothing is seen, but on fluorochlorine PET, you can see a lot of lesions are there in the liver. So other thing, few case reports have come, and now the few series are also there for PSMA PET. PSMA is a PET scan which is used for diagnosing of prostate cancer, but now recently it is being used for hepatocellular and few other malignancies. And it has shown that it can change the management around 50% of hepatocellular carcinoma by diagnosing metastatic disease. But more data is needed for this also. Another thing that I told was FAPI, and that is also new modality, and that is coming in a big way for GI malignancy, especially for mucinous tumors or signature carcinomas. Those are also get picked up on FAPI scans, not on PET scans. So advantage is best modality for SCC is dual tracer. Use FDG as well as C11 acetate. C11 acetate is good for well-differentiated tumors, and FDG is very good for poorly differentiated as well as finding a metastatic disease. So if you combine a dual tracer, then you can achieve a best results for diagnosing and staging for SCC. So other important role is of tumor thrombus, whether it is a bland thrombus in the CLD or it is a tumor thrombus, that also you can see on the arterial phase also enhancement, but sometimes it is not very well seen on CT scan. There PET scan will be very helpful, whether this is a tumor thrombus or is a bland thrombus. So at present for NCCN guidelines, it is not included for staging, but if the high SUV intake is there, that it shows it is a very poorly differentiated tumor, it is going to behave very poorly, and these patients should not be taken up for transplant or very aggressive surgeries because they are going to fail very quickly, and the local regional failure, even a systemic failure, is very high. So more FDG-heavy tumors have very poor prognosis for SCC. So it can be used in selecting a good risk patient for transplant or aggressive treatments. So what is the present status? It can be used for in combination of C11 acetate and FDG PET, that is the best, but it should not be used for diagnosing. FDG PET should not be used for diagnosing of primary SCC. That is based on the triple phase CT scan, not on a PET scan. It can be useful in diagnosing the nature of tumor, and also it can be useful in assessing the response to the neoadjuvant treatment. If you are doing an immunotherapy or assessing the response, it might be useful if the PET scan or FDG PET was active in the pre-treatment setting. So addition of PET lead to discovery of metastatic settings lesion around 18% of patients, and it can avoid unnecessary transplant in around 11 to 15% of patients. So before transplant, it is better to have FDG PET to rule out patients with poor prognosis and aggressive tumors. Coming to PET in gallbladder cancer, so the diagnostic role of PET is very poor. There is a sensitivity of 75 and 88%. And but the diagnosis of residual tumor in incidental CGB is around 78 to 80%, and extrahepatic mets was 56%. These are initial studies, but recently the new study has shown that 86% detection rate of primary tumor or residual disease. But most of these studies were retrospective, and they'll have a good sensitivity, but specificity was lacking. So we did a prospective study, and this was published in EGSO in 2020. This is a prospective study. We used role of PET scan in resectable gallbladder cancer, not in metastatic or low, but only a potentially resectable or resectable GBC to assess how it can change the treatment plan. In this study, we have 149 patients. After CT scan, the plan was neoadjuvant chemo 76 because these were locally advanced, and surgery upfront is 73. But after PET scan, the treatment plan changed to palliative chemotherapy in 34 patients of locally advanced and around 12% of upfront resectable patients. So additional findings were seen around 30% of 30.9% of patients in resectable GBC, and the change in management occurs in 23%. So roughly around quarter of patients, you have a change in treatment plan by doing a PET scan. Either it can change from upfront surgery to neoadjuvant chemotherapy, or for neoadjuvant chemotherapy to palliative chemotherapy. The management change was around 34% locally advanced cancer and 12% in an upfront resectable GBC patient. In node positive patients, the change in management was seen in 27% as compared to 16% in node negative. For distant metastasis, sensitivity was 70%, specificity of 85%, and diagnostic accuracy of 79%. We have few false positive also, but the false positivity rate was only 7%. So based on this study, now the gallbladder cancer is recommended by UK guidelines for PET scan in CAGB patients. So coming to the other problem is incidental GBC. because the surgery is occurring soon. So FDG PET might be taken up with a lot of inflammation type areas in the port side. So what is the role of incidental GBC? This is the initial study in which it was shown that the PET avoids unnecessary surgery in T1B or more by finding a metastatic disease even in early gallbladder cancers in incidental CGB. This is the recent study around 2 years back from PET CT from TMH, and they have seen that they had done the PET scan with median time of 42 days. There was no uptake in 59% of patients, and local regional uptake was in 41%. But the patient who had no PET scan, no positivity on PET scan, they have chances of lesser residual disease as compared to local regional positive PET scan. That was 23% versus 52%. And they concluded that PET scan can be useful in planning treatment, especially in T1B patients. And if there's no light up occur on PET scan, you can observe, but this is a controversial area. This is the recent study from Japanese center, and they've qualified, assessed how it can be useful in following up these of gallbladder cancer, whether PET scan is more effective in following up. And they concluded that it was better than CT plus tumor markers in diagnosing port side recurrence as well as local regional recurrence and PET scan. So this conclusion shows also that the PET scan might be better in following up patients. Coming to the CA pancreas, again, this is the landmark study by NHS group, that is PET Panc study. This was a multi-center study, and this has analyzed prospectively how the PET scan changed the management plan in pancreatic cancer patients. And they found that around PET CTs changed the management plan around 45% of patients and prevented futile surgery in 20% of patients. And they concluded that PET scan should be included, and that is included in UK guidelines for CA pancreas for preoperative evaluation for staging work. Again, other role of PET scan is in pancreas is a prognosis. If the FDG uptake is very high, it indicates a poor prognosis and survival is less. So usually high uptake in the lesion is associated with poor survival or poor long-term survival. So for PET scan CA pancreas, NCCN guidelines recommend for high-risk cancers, especially for borderline locally advanced disease, markedly elevated CA99 or severely symptomatic patients. But it can also be helpful in assessing the response to radiation or neoadjuvant chemoradiation, whether a tumor is responding. It can be useful in assessing the response. And that is why it has been used because it can predict a response very early. When after 2 weeks of chemotherapy or radiation, you can assess if the FDG activity is coming down, that the tumor is responding, and you can continue with the neoadjuvant chemotherapy. So for our recurrence also, the PET CT can detect recurrence earlier than contrast CT scan, and with the accuracy of around 90%, 92%, as compared to 72% of CT scan. So at present, the PET and CA pancreas is usually based on institutional preference. The NCCN recommends in selected group of patients. UK guidelines mostly recommend for all patients it should be done. But it should be always be done in borderline resectable pancreatic cancer or locally advanced pancreatic cancer. So NCCN at present only recommends for high-risk features that include large primary tumors, very high CA99, bulky lymph node disease. If there is history of severe weight loss or severe back pain, these patients should undergo a PET CT in CA pancreas. Coming to role of PET in intrahepatic cholangiocarcinoma, these are aggressive tumors similar to CAGB, and the role of role in ISCC is evolving. It is by slightly better than CT scan in picking up lymph nodal mets, and also it changes the management plan in around 25% of patients. So at present, the PET scan is not recommended NCCN guidelines, but it can be rule out metastatic disease in 25% of patients. And it can also help in detecting a nodular cholangiocarcinomas less than 1 centimeter, which are not picked up on PET, CT scan or MRI. Coming to PET in hilar cholangiocarcinomas, the FDG PET detect nodular cholangiocarcinoma less than 1 centimeter, but it is less helpful in infiltrating tumors. But important role is in patient with PSC, in follow-up, you can do a PET scan to find a suspicious cholangiocarcinomas, and this has very good sensitivity and specificity in PSCs for detecting cholangiocarcinomas. FDG PET versus CT scan, the malignancy detection is around 80% with CT scan, but increased uptake seeing only 60%. So it is not very accurate in diagnosing. And also for lymph nodal involvement also for hyalocholangiocarcinoma, it is not very accurate. But it can detect metastatic disease, can change the management plan in 1/3 of patients. So coming to in the dual type FDG PET, it is slightly better as compared to standard. What is difference between standard and dual time is here in the delayed phase CT PET scan is taken after 1 to 2 hours, and it increases the diagnostic sensitivity and accuracy up to 76.8%. And it is better for lymph nodal mets, especially in delayed phase. But there's no additional benefit of diagnosing metastasis, and the sensitivity and accuracy remain around 75 to 90%. So for NCCN guidelines, don't recommend at present. If any equivocal findings are there, those cases PET scan might be useful. Coming to PET in colorectal liver metastasis, this is important to rule out extrahepatic disease prior to doing any liver resection. This is the only thing that is important, that always do a PET scan prior to doing a metastectomy or liver resection. So NCCN also recommended if you are planning any liver-directed therapy, whether it is resection, TACE or tear, it is better to rule out extrahepatic disease and before taking up a local regional treatment. And this is recommendation for NCCN guidelines for latest recommendations. Coming to other role that is important is PET in neuroendocrine tumors. As you can know, the neuroendocrine tumor is most of the time used as gallium active or DOTA-8 or DOTA-NOC scans are most widely used. And these are used for both the diagnosis and staging purpose to characterize the biology of tumor as well as the responsiveness to sandostatin LAR with the somatostatin analogs. The FDG PET are generally preferred for grade 2 and grade 3 tumors, and DOTA-NOC is preferred for grade 1 tumors. And the combination of the both DOTA-NOC as well as FDG PET is helpful in deciding the best therapeutic strategies. Other radiopharmaceuticals like gallium oxandine is useful in insulinomas, and 18F dopamine is useful for SSTR negative tumors. So there are 3 tracers available in market. The DOTA-TOC, which is active for high affinity for receptor 2 and 5. DOTA-8 is only for receptor 2. And DOTA-NOC is best for because it has an affinity for receptor 2, 3, and 5. But there is no overall practical difference between the results between whether it is DOTA-NOC, DOTA-8, or DOTA-NOC. Usually the sensitivity and specificity remains the same. But it changes the management plan, whether it's surgical, medical, or staging in around 20 to 50% of patients with neuroendocrine tumors. All neuroendocrine tumors should have, grade 1 should have a DOTA-NOC scan before starting any treatment. This you can see, this is a FDG PET on the left side, and this is DOTA-NOC. It is lighting up on DOTA-NOC, but there's no activity on the PET scan. This is the below is the PET scan, and you can see that it is active. So most likely it is a grade 1 tumor, not a grade 2 or grade 3 tumors. Similarly, this patient, you can see it is not lighting up on DOTA-NOC. It is the top one is a DOTA-NOC, but it is lighting up on FDG. So this appears as a grade 3 NET, which is aggressive and is going to behave very poorly. Also advantages for picking a small primary site, DOTA-NOC is many times useful, especially if the tumor is carcinoid located in the small intestine. Here is one patient, you can see this was not picked up, though there was some lesion was suspicious, but on DOTA-NOC it was lighting up. It shows that there is a neuroendocrine tumor in the small intestine. Also, it helps in detecting the lymph nodal mets as well as multifocal location. Like in this NET pancreas, there are 2 sites with different multifocality was seen. So to conclude, the PET is still not indicated as standard of care for staging workup for most HPV malignancies, but more and more data is emerging. PET should be done for all CAGP patients, including incidental GBC, and PET should be done for all border resectable as well as locally advanced pancreatic cancer at present. And FDG PET should be done prior to liver transplant or any aggressive local treatment to rule out metastatic disease, prognosticating and assessing the response, assessing the nature of thrombus in portal vein. DOTA-NOC scan is must for grade 1 NET, and combination of FDG and DOTA should be done for grade 2 and grade 3 neuroendocrine tumors. For colorectal mets, PET scan should be done to rule out extrahepatic metastasis prior to hepatectomy. New tracers like FAPI, C11 state, and PSMA will improve accuracy in future. Thank you.
Thank you, sir. Very nice, well summarized presentation. And I think all the information was there. 2 or 3 points I'd like to ask. Will you like to touch upon the usability of PET in discriminating between the thick wall gallbladder, benign versus malignant, and thickening at the hilum, benign versus malignant? So is there any usability or utility of
Still, it is controversial that the diagnostic role of CAGB is still less than 70% accuracy is there. The role of PET scan in diagnosing in thick wall, whether it's malignant or inflammation, is very suspicious because the inflammatory lesions also light up on PET scan. So there is not much role unless the new tracers come up. At present, there is no role of in diagnosis of thick wall GB, whether it's CAGB or inflammatory.
Thank you very much. Dr. Singh very nicely explained and showed all the slides and usefulness of PET, PET-CT, and DOTA, and PSMA and FDG. Thank you very much. Thank you, sir. Dr. Kapoor, thank you.
Thank you very much for this very comprehensive presentation. My question is the role of PET-CT in the evaluation of response to chemotherapy. In my country, oncologists are using PET scan for their evaluation of response to their protocol. And in many patients, they have very good results, PET negative. But in surgery, when we do resections, the pathologists report tumor or viable cells. So I would like to learn your experience and your thoughts about the role of PET-CT in the evaluation of response to chemotherapy. Thank you.
So we have been doing PET scan before and after neoadjuvant chemotherapy for all CA pancreas and CAGB, but it is still not accurate to predict the responses. It predicts the response, whether there is complete no disease is there, doesn't correlate. And we have published our experience for PET scan in assessing whether there is residual disease for CA esophagus, and we have found that it doesn't correlate whether there is a PET is negative. Most of the time it will be a still residual disease. So it still doesn't correlate with complete pathological response, but it only showed that it is responding to treatment. So it shows the response, but pathological complete response it can't predict.
Dr. KJ Singh from Chandigarh. Very nice lecture. And, if you have done a difficult, like you said, inflammatory, it's not very clear. So if you've done a difficult lab poly and it comes out to be incidental CAGB, how much time do you wait before doing it?
At present, we are doing a study in our center, so we do all irrespective of time. The advantage is once you are evaluating for incidental gallbladder cancer, don't look for the site of surgeries. There it will light up. Our focus is looking for distant mets, whether it is interaortic lymph nodes, finding mets in supraclavicular or lung mets. So they are not affected. These are picked up, then they are definitely metastatic. But don't get distracted by the local plight of a port site or a local site in the GB fossa.
Very nice this talk. Sir, from your presentation, I noticed that in all kind of malignancies, the predictive value is ranging between 20 to 40%. So can be used as a blanket statement in 1/3 of the cases, PET-CT is useful.
1/3 of cases, it will change the treatment plan.
Management.
In most of the patients, it will see, you can say across the HPP malignancy, roughly around 20 to 28%, it is changes the treatment plan in most of them.
Any question from audience? Thank you very much, Dr. Singh, for wonderful talk on PET in HPV. Thank you very much.
I would like to thank the speaker and the chairpersons for such an extensive discussion. Next up, we'll move on to discuss the role of ICG in HPV surgery. To discuss the same, I would like to invite Brigadier KJ Singh,
who's a senior surgical gastroenterologist currently stationed at Command Hospital, Chandigarh. And we will be joined by Dr. Dhiresh Mahajan online, who's an assistant professor in Department of Surgery, Kathmandu Medical College and Teaching Hospital, Nepal. I would like to welcome you. Can we get the online faculty?
Good afternoon, everyone.
Would you like to welcome the speaker, or should I do it?
Yes, sir. Please go ahead.
Like some other recent developments in HPB surgery, which have come but really not stood the test of time or still evolving, ICG is one of them. We've seen it come in a big way, but where exactly does it stand? Some people have been using it experimentally so far. So to talk more upon that and give us an kind of a focused assessment of how do we go about it, where all it is applicable, HPV surgery, we have Dr. Shrikant, who's done his MS from Jaipur, Pondicherry, and then he did his MCH from SGPGI Lucknow. He was a consultant at Manipal Hospitals, Bangalore, and presently he is at the Sahasra Hospital, Jayanagar, Bangalore. So welcome, Dr. Shrikant. Do we have him here? Oh, right there. And looking forward to your lecture.
Good afternoon, everyone, chairpersons, faculty, and delegates. I thank Professor Kapoor for having invited me here, and my close friend, Professor Ajay Sharma from Lucknow Times. My talk is on ICG fluorescence in hepatobiliary surgery. There's a lot of work which has happened in the last at least 2 decades in the area of hepatobiliary surgery, use of ICG fluorescence. Most of the data which came in initially from the East, and now there are reports coming in globally. But surprisingly, we don't have published data from our country. I'm sure there is an exposure of use of ICG fluorescence for gallbladder surgery in different centers in our country. But we don't have data which has been presented from which you can draw inferences. We have acquired this in the last 3 years. So our experience with the use is in the area of gallbladder surgery, and I would say preliminary in the area of liver tumor. So the role in gallbladder surgery in identifying tumors, liver resection for guidance, and in a living donor liver transplantation. These are the areas that ICG is being used. The first description in gallbladder surgery was in 2018, in 2008 by Ishigawa. And subsequently, over the next 10 years, a lot of data had accrued in the area of liver and biliary. And the first consensus meeting was held in Shanghai, which had about around 13 experts from the Asia-Pacific region. And 8 of them were pioneers in ICG-related techniques. I would use the term in clinical use. It is not experimental. It is being used routinely in surgery in some of these centers, and it's been recommended clearly for use in certain clinical situations. The consensus panel here, the modified Delphi method, statements which were drawn out of the discussions which happened, and a consensus was obtained from all of them, finally were made as recommendations. So the data in laparoscopic cholecystectomy has been looked into in a randomized fashion to compare patients with the gallstone disease undergoing surgery in white light vis-a-vis ICG fluorescence. There is one randomized study which showed that the operating time may be shorter. The time to achieve CVS is faster in the patients with ICGF. This is because you have the extrahepatic biliary tree which shows up, and you are aware of it early in surgery. The dosing has been highly controversial. Also the timing, starting from the time of induction to the drug being given 24 hours before. The caution here is that it's to be, one has to elicit a history of iodine or seafood allergy, because these are patients who could have allergic reaction with ICG, although the reported incidence is 1 in 10,000. So it is rare. So you get an informed consent and do the procedure. It's relatively inexpensive. We practice giving 2.5 milligrams given 2 hours before surgery for gallbladder. Now on the left side, you see the image. Initially, if you see the image here, in the initial description, the problem with ICG was you had a NIR mode, you had the real-time laparoscopy mode. You had to keep switching between the two. This was initially. A lot of advances have happened. The current system, at least that we use, the left image, it gives 3 images. You could have this, which is the NIR pure, the laparoscopy view on the right, and the left corner, you would have the augmented image, which means the computer fuses the left top image, NIR pure image, onto this image and gives you the left lower. So you get an idea of where the extrahepatic biliary tree is. And that is post-dissection on the right side. So its role, if you have to summarize in laparoscopic cholecystectomy, is at the outset, you don't have anything else now. You go in, put a scope and see, you know where the bile duct is. You don't have anything like that. IOC comes later on if you want to do it. So at the outset, during dissection, and at the conclusion of dissection, and even having completed the procedure. So in 3 areas, you have completed a lap poly, that's the lower right image that you see. And the first time when we were using, we were quite stunned by the brilliant images that you get with a confluence seen like that, which you don't get. And this is not true in all patients. You could have issues which you discuss quickly. One would think that it would help in acute cholecystitis. Herein is the challenge, that the tissues are thickened, and perhaps the visualization of extrahepatic biliary tree is a little inferior in a situation where it should help more. Having said that, with improvements in the image systems, the imaging systems, and also critically viewing the NIR images, the pure ones, vis-a-vis the augmented images, where the sensitivity drops because it's computer generated. The pure images seem to sometimes provide information in these situations. You see, this is acute cholecystitis. This is a case of CBD exploration. You have the CBD visualized, you have the supraduodenal part where you place the choledochal. You don't need to aspirate because you know where it is. And if there is a bleed from the edge of the choledochal, easy to pinpoint the site of the bleed against a fluorescent bile compared to a white light image where you will have a bile and blood mix and you don't know the point of bleed. So that's something we have found useful. Catheter inserted, the right lower image, into the cystic duct. If there's a leak, it would be evident. Methylene blue could be used in this situation, but you would have the field which is getting contaminated by the bile if it by methylene blue if it leaks and makes suturing difficult. In cases that we have used, if you see, could it be used only in complicated gallstone disease? Could be a question. But, only a routine use would permit you to find situations, unusual situations, which you always find with gallstone disease, and therefore you would have situations, let's say internal fistula. These are patients who would be converted to open in a difficult situation. But when you have an extrahepatic biliary tree visualized, as in the left top image, the CBD is seen, the fistula site is seen, easy to take down the fistula and manage it laparoscopically. So is the case with a remnant gallbladder. Now, ICG cholecystography, although most of the groups would give intravenous, 2.5 milligrams, and about 1 to 2 hours before surgery, use at the time of surgery, which we have used in 2 patients and we have given up. This was early in our experience because it's not you will have a bile leak from the site of puncture in the gallbladder, and that fluorescence is enough to kind of skew the images and not make your interpretation of the extrahepatic biliary tree accurate. And also, if you use a transhepatic route into the gallbladder, even there, the bed dissection, you would have fluorescent leak. So it's not something which is found favor in most of the groups. If you have blood in the field, you still have the fluorescence. It doesn't mask the fluorescence. So you could proceed. Also, with the CBD in view, easy to use a bipolar energy, for instance. You know where the CBD is when you do this. So the consensus that came up in the Shanghai meeting were that you have a superior visualization of the extrahepatic biliary tree. You have a detection of accessory rates which are higher than white light. They found the detection rates to be up to 6%, which you don't see in a regular laparoscopic series. Repeatability, no radiation, and ability to see before you have dissected is advantage over intraoperative cholangiogram. So also, Intraoperative cholangiogram requires some amount of dissection, and it could potentially cause in a minority of patients bile duct injury, catheter related, which you don't have with this. We quickly go on to role of imaging. This was a serendipitous discovery in 2008. In the East, the ICG retention test has been used to assess liver function. So in some of these patients, when they were imaged during surgery, they found that the tumor was showing fluorescence. And that's how it was initially described by IOP. And the types of fluorescence, in general, one would say that a complete kind of fluorescence in a HCC and a rim fluorescence in case of a metastasis. But HCC itself has been identified to have 3 types of fluorescence patterns. One is a complete, as you would see in the top. In a cirrhotic background, you would see that the pure white light image doesn't show where the tumor is. The NIR image shows the black and white. And then on the right side, the augmented image. And a rim fluorescence can also happen, complete, partial, or rim, based on the differentiation of the HCC. A poorly differentiated HCC would have a rim fluorescence. But rim fluorescence is typically described for metastasis, as you see here. Now, in colorectal liver metastasis, it is standard to use intraoperative ultrasound apart from your preoperative imaging to detect additional metastasis. In groups which have used ICGF, it's been found that you could find new lesions which were not seen on an intraoperative ultrasound. And currently, the combined use of ICGF and intraoperative ultrasound appear to have superior detection rates for colorectal liver metastasis or of those which are less than. The downside is that you can't detect ICG fluorescence in lesions which are more than 8 millimeters deep from the surface. The other advantage in colorectal metastasis, when you do a resection, is identifying deeper lesions on the cut surface. If you encounter, then it helps you keep your margin away. Now, what is the optimum dose and timing for liver tumors? The dose is approximately 0.2 milligrams per kg if you are doing it for a tumor identification and guidance during surgery. And it should be 2 days prior to surgery. If you give it within a day, particularly in a HCC, you could have fluorescence coming from the entire liver because dysplastic nodules can retain ICG like the tumor, and so it can interfere. So in a cirrhotic liver particularly, it should be beyond the 48, 72-hour period. How long before? It could be as much as 2 weeks before. ICG retention, that's how it was initially detected. And there are groups even now which practice up to 20, 21 days before planned surgery. The limitations, as I mentioned, are if the depth is more than 8 millimeters, then one cannot visualize. The other concern is in cirrhotic background, in HCCs, regenerative nodules, dysplastic nodules, bile duct proliferation. These are things which can give false positives in some of these patients. During liver resection, it's been recommended by this group after reviewing the available data that keeping the margin along the outside of the fluorescence in a HCC and in colorectal liver metastasis about a centimeter is what is recommended to get a R0 resection. And the dose I mentioned 2 weeks before surgery, 0.5 milligrams, if you're using it for ICG retention test and subsequently detection during surgery. But if you planned for only surgery, the tumor uptake purposes, 0.2 milligrams 2-3 days before surgery is good enough. There are benefits over conventional methylene blue staining. Now I need to come back here quickly and so 2008 was the initial description for segmental mapping, the original description. Ishizawa in 2012 came up with positive and negative staining techniques. Now we have no personal experience with this. We have seen all the images that you see are the images that we have picked up in our HCC resection, during resection, the colorectal metastasis that you saw, etc. But as far as segmental mapping, we have no experience. But most of the positive staining would be for segmental resections or subsegmental resections where you can inject ICG into a segmental portal pedicle. And negative staining is when you're proceeded with the resection the area that is to be resected. When you have occluded that portal pedicle, then you inject systemically, intravenously, and the dose would be 2.5 milligrams typically. So you give it intravenously, and the uptake happens in the normal liver that is being left behind. So it helps after the portal pedicle is clamped for you during parenchymal transection. The difference is seen on the surface. The difference is also seen as you go transecting the fluorescent side and so in the intersegmental planes. And it's used for guidance during, say, a laparoscopic microwave or a radiofrequency ablation. Let me quickly summarize the statements and the level of recommendations that were made in the Shanghai Consensus. You had one international meeting, which was a year later, published in the annals recently, and that looked at ICG in general in surgery, which means it was broader, but this is the only consensus which happened in the hepatobiliary area. So aids in dissection of critical structures in laparoscopic cholecystectomy based on available information, helpful in localizing subcapsular tumors less than 8 millimeters, reduces margin positivity in resection of deep colorectal liver metastasis, and the same is true for hepatocellular carcinoma resection. Helpful in delineating segmental boundaries in open liver resection, helpful in delineating segmental boundaries during minimally invasive resection, concurrent use of IOUS required for positive staining, useful in determining appropriate division point of bile duct in major hepatectomy. So in living donor liver resection, it's been used by groups. When you plan to do the hilar dissection, half an hour before, you give 2.5 milligrams intravenous. It shows the biliary anatomy, extrahepatic biliary anatomy. And as you dissect, it would be critical to know where you want to transect the bile duct. It could help you plan that, and that's where it's used in living donor liver transfer for the donor operation. And more, you have minimally invasive ways being adopted, and therein lies the advantage of using ICG in that subset of patients. Thank you.
Questions from the floor?
Yeah, I think the floor is open for the questions.
Yeah, please go ahead. Good afternoon, sir. Nice talk. Sir, what I felt was like you take cholecystitis, aberrant anatomy, maybe liver tumors. Like I felt that lap ultrasound or intraoperative ultrasound gives you almost the same or in fact better results than ICG. And to add to that, like ICG has a lot of logistical issues. I do not use, we have not used. This is just a question put to you. A lot of logistic issues. Wouldn't it be wise to invest more in lap ultrasound, which gives you a better return of investment?
So investment is a question I cannot answer. Depends
No,
on
what I
you
mean
and
is
your
investment
management.
of time, not the money.
Yes.
Yeah.
So I
years
get what you're
put in
saying.
for, like
So
any modality.
I would say that ICG is an established way. Ultrasound is not something everybody is trained in. What you're asking is, it's easy for me to give ICG and train anybody to look at the extrahepatic biliary tree. Anybody can see it. All the surgical trainees could see it, colleagues could see it. It could be transferred across in an image for people to give comments. You put the scope in, you can see the extrahepatic biliary tree. Now to answer the question, can you see it in all at the outset? The most data, even that randomized study had shown 2/3 of patients, but again, in the consensus which was drawn, they found that with increasing time, increasing experience, the pickup rate or interpretation is definitely better. What do I mean by that? For example, from Eastern groups, which have been doing it for several more years, they've reported 85% upwards at the outset. When you put a scope and see and interpret the data, they're able to see the extrahepatic. So as regards use of ultrasound, it's another tool, but can it be a replacement? I don't think so. This is a very straightforward thing. Continuous, it provides, it doesn't interfere. Ultrasound, you need to have another ultrasound instrument. You can't dissect with ultrasound guidance. Here you have the surgical flow is not affected. You just have the image with these three picture in picture, at least the system we use. And so that would give you a continuous flow reference point for you to keep operating. That cannot be provided by ultrasound. So I think it has a demonstrable superiority. People have talked about intraoperative ultrasound. They are complementary. You can't see the intrahepatic biliary tree with ICG, but that gives intrahepatic biliary tree. You can't see CBD stones with this, cystic duct stones yet. So CBD stones IOC has. So they should be used complementary. I'm not comparing. But for guidance during surgery, at the moment it appears that ICG has all the advantage. And as regards, it's the recurring cost is nothing much. The allergies are rare. It's an inert substance. And the cost is, it's inexpensive, the drug itself. So I don't see any reason why one should be hesitant in using ICG if they have the equipment.
Not hesitant. One modality if it is to be used.
I would
for
use
deeper liver tumors, like intraoperative ultrasound is very good.
I think the
So if you want
purpose
to
is
go along
different.
the veins for doing an appendectomy for guidance during surgery, again,
I think the
ultrasound
purpose is different. And if you're talking about liver tumors, even there it would be complementary is what I would say. And like I said, the data is there to say that IOUS doesn't pick up and ICG shows up lesions, new lesions. So this recommendation by the consensus was to use them together, which means use ICG plus IOUS. So I'm not discounting IOUS. IOUS has been standard during liver resection. And an inexpensive tool. Why should you worry about giving ICG, which guides you during surgery? Why should we compare it that way?
Go on to the next question.
How much and at exactly what time prior to the surgery should be given to identify the balance structures in major hepatectomy, like if we are doing donor hepatectomy?
I would think half an hour before you do the dissection in the hilar plate region. Let's say you open the abdomen. I think the initial assessment, as you start mobilizing, you should give it. And it's retained for 2 hours, 3 hours, 4 hours in the biliary system, continuously providing you whenever you get the scope. If you're doing open surgery, there's an open scope, but the same scope, laparoscope could be used. You only have to switch the mode. So how long before you give it at induction should be fine.
Last time when we did donor hepatectomy, we have given 2 hours prior to the surgery. But while doing the hilum, while cutting the biliary duct, we are not able to identify the entire ICG was there in the hepatic parenchyma.
So it should be definitely half an hour before you reach the transection point you should have given. And half an hour before. And let me also tell this, that ICG, the technology is evolving. The red, blue, and green are the 3 chips that are used in, let's say, laparoscopy, regular imaging. NIR is what is required because that is what is absorbed by ICG and it releases the excited waves which are at 930 nanometers. You need a dedicated NIR source, and that has come in only recently. So the one which I was showing you the images has that it's a 4-chip camera, what we use. In systems where the dedicated chip is not there, you may have inferior images. And this background noise is the term used to describe what you said. The whole thing looked green. The whole thing looks green if you do it within half an hour of injecting. You want to evaluate the biliary tree and you inject at that time, everything will be green because it's rapidly taken, excreted 15 to 30 minutes from the liver. So 30 minutes before should be the time.
What you think that might be the timing is important.
Yes, timing is important, very important.
My co-chairperson, Dr. Mahajan.
Yes, I'm here. Thank you. Thank you so much for the wonderful presentation. Well, if there are no questions, may I put one comment on that? Because we've been practicing ICZ since last 2 years in Kathmandu Medical College, and we have published our papers as well last year. So right now we are focusing more on whether we'll be able to detect peritoneal mets which are not detectable on CT scan, a role of ICZ before doing a diagnostic laparoscopy. So we were able to find few in colorectal peritoneal mets. We are doing more in pancreatic malignancies. Do you have any experience on that?
We have used ICG in other situations, but in the specific situation, we haven't looked at. You're talking about peritoneal metastasis, etc.
Yeah, yeah.
Today, as a whole, if you see, we have used it in gastric cancers for mapping out nodes. You inject it in 4
Right.
quarters day before surgery and map out the nodes. We use it in
Right.
achalasia. We published it recently, accepted for publication. Where at the end you give ICG through the Ryle's tube. The myotomy site just shows fluorescence. If there's a leak, it should be evident. So as a check for leak, you could do that on completion of myotomy. So we have used ureter. We have used routinely in colorectal malignancies when we take them up for resection, or even diverticular abscesses where we have taken up them for resection. We give ICG at the outset of the procedure, which stays for 4 to 5 hours in the ureters because urothelium has a high affinity. So we are also on the road are gaining a lot of experience. About cardiomyotomy, I know that esophageal mucosa, unlike urothelium, doesn't have affinity. So
Yeah.
it doesn't stay. So we have figured out that if you add it in, beat it in an egg, albumin, or you could use a regular albumin solution, that stays longer and coats the mucosa. So those are things we are learning along the way. A lot to be learned. Like I said, we don't have these positive, negative staining techniques. One is related to the numbers, referrals, etc. But I think those are exciting areas that we would like to be associated with.
One last question
Yes.
from my side, because gallbladder surgery is one of the commonest. You said it's a class 1, level 1 evidence using in preventing or kind of preventing the bile duct injuries. We also know that there is a gallbladder, the bile duct injury, 70% it's the wrong perception of the surgeon in while operating. So do you recommend that it be added to a routine surgery, gallbladder surgery? What's the take home message?
So the consensus panel experts based on available literature had made a recommendation. It increases the safety and should be routinely used.
Yeah.
Here I have to add, they also observed that the randomized data which is available, one of the studies which looked at 300 odd patients each arm, white light versus ICG, found better identification of the structures, better identification of additional structures, the accessory structure compared to white light, reduce the time, and could be repeated n number of times post at the conclusion also, and had lesser number of bile duct injuries, 2 versus 8 in the 2 groups. I mean, if I remember correctly the number. So they said you didn't have statistical significance because of the numbers. And this expert committee came to a conclusion you need, for showing a less than 25% reduction in bile duct injuries, 1,25,000 patients to be recruited and then randomized in such a study. Difficult to perform even in multi-center. So the difficulty seems to be in performing such a study. But available data indicates a trend towards decreased bile duct injury with the use of ICG.
Thank you for a wonderful talk. Close the session here.
Thank you.
Thank you, everyone.
I would like to thank the speaker and the chairperson for such an intriguing discussion on the topic. Next up, I would like to invite Professor P.K. Kapoor and Dr. C. Khandelwal, who is the Director of Surgical Oncology and Gastroenterology at Mahatma Hospital, Patna. He will be joining us online. And the topic of discussion is preventive cholecystectomy in Chile.
Can we have Dr. Khandelwal on the screen? Good afternoon, Dr. Khandelwal. Dr. Khandelwal? Unmute कर दिया आप? Okay, so I will introduce Dr. Eric Sabala. He is one of the most prominent persons who has done work on both clinical as well as pathological aspects, along with his pathology colleague, Dr. Ivan Roa, whose name we heard earlier, on gallbladder cancer, because just like in North India, in South America, especially in Chile, gallbladder cancer is very common. And I remember that I got in touch with him when in one of the journal clubs in the very early years at SGPGI, we discussed an article written and published by Dr. Eric Sabala in the British Journal of Surgery. And since then we have been in touch. I have been to him and he has come to SGPGI, he has come to India, and I'm sure he will come to Jaipur also one of these days. So I will, he has already
Thank you.
the video. Welcome, Dr. Khandelwal. I think
Yeah.
Dr. Eric Sabala's
Let,
video
yeah.
online, and then he will join us for a discussion.
Yeah. Let me also welcome him. We have also met quite few times and very eager to listen to his talk, which is really very pertinent to our scenario in our population, whether to do cholecystectomy for prevention of gallbladder cancer. For cholelithiasis, everyone knows, but whether to prevent for gallbladder cancer, let us listen to him. We, on behalf of Jaipur Surgical Festive, we invite him to deliver his talk.
Let's play the video, please.
Good morning. First of all, I would like to thank the invitation received from Professor Kapoor to share with you our experience in the management of gallbladder cancer. During this talk, I would like to show the program that is performed in Chile to prevent the occurrence of the disease. During the last 2 decades, Chile had the highest incidence of gallbladder cancer. Other countries affected by this disease include Bolivia, Korea, India, etc. The Ministry of Health of Chile has 85 special programs devoted to the treatment of different pathologies. These programs are carried out under some guarantee given by the government to patients. The guarantees are the guarantee of finance, the guarantee of quality, and the guarantee of opportunity. The above means that patients suffering any of the 85 pathologies must receive treatment within the period under financial protection and by qualified physicians. One of the guarantee programs is the Preventive Cholecystectomy program. The aim of this program is the reduction in the gallbladder cancer incidence. The relation between the cholecystectomy rate and the incidence of gallbladder cancer is well known. For example, Bill in this manuscript showed the above relation. It is obvious that when more cholecystectomies are performed, we exclude the organ where the tumor grows. Normally, symptomatic cholelithiasis is the indication to perform a cholecystectomy. However, from our studies, we know that gallbladder cancer also occurs in previously asymptomatic patients. Because of the above, we should include also patients with asymptomatic gallstones in the program. To define the program characteristics, some important facts have to be taken. First, we knew the age when gallbladder cancer begins to affect the Chilean population. This slide shows that at the age of 35, the incidence of gallbladder cancer shows a sharp increase. From the above data was defined that 35 years old could be the age for the beginning of the program. Also, another important data taken into account when the program was designed was the time elapsed between the different stages of the disease. We realized that within dysplasia and early gallbladder cancer, the time elapsed is approximately 10 years. That means that patients with gallbladder cancer have a large period to undergo a simple cholecystectomy for the curative treatment of the neoplasm. In 2006, and considering the data just exposed, a program to reduce gallbladder incidence by 25% was launched. In my opinion, the objective of the program was too optimistic because the excess of cholecystectomies to be done is too much for the capacity of the public health system in Chile. However, I will show you what has happened with the program. In this slide, we observe the operative diagram. For those patients with symptomatology suggesting gallstone, an ultrasonogram must be performed during a time of 30 days from the first medical consultation. On the other hand, for those patients in whom cholelithiasis was detected, the cholecystectomy must be performed within the next 3 months from the diagnosis. In case of this guarantee could not be accomplished, the patient has the right to be operated in a private center and the cost paid by the government. This slide, we observe the curve representing the mortality rate in Chile during the last 20 years. It is interesting to realize how the curve shows a decreasing incidence from 2000. This is before the implementation of the prevention program. The program launch is marked by the arrow. Until now, we do not have a clear explanation to understand the possible cause of the decreasing incidence. To evaluate the preliminary results of the program, first, we analyzed the change in the number of cholecystectomies performed before and after the beginning of the program. The curve colored in red show all the cholecystectomies done in Chile according to years. In the blue curve, patients belonging to the program are shown. That means patients between 35 and 49 years old. Both groups show an increase of approximately 35% in the number of cholecystectomies. When we wanted to analyze the specific effect of the program, we compared the mortality rate before and after the program implementation. We focused our analysis on the group of patients between 35 and 49 years old. That means the group of patients who underwent the cholecystectomy program. The change in mortality before the program implementation showed a change of minus 4.3%. This difference did not get statistical significance. On the other hand, when the same analysis was done after launching the program, the difference did get statistical significance, showing the beneficial effect of the program. For a long time, gallbladder cancer was the main cause of death among women. Nowadays, this has changed completely. The slide shows the different causes of mortality by cancer in 2018. The red circle is in the bars correspond to gallbladder cancer. The brown bar shows the incidence of gallbladder cancer in women. golden bar shows the incidence in men. Now, in men and women, the mortality by gallbladder cancer is lower than other types of tumors, such as lung, stomach, colorectal, and breast. This graph is an indirect indicator of the reduction in the incidence. Analyze the rate of gallbladder cancer around the world from Globocan. Chile still has a higher incidence. The detailed analysis shows that Bolivia exceeds Chile's rate, and the same happens when the mortality is analyzed. In the mortality analysis, Chile has the third position after Bolivia and Bangladesh. This slide shows a more recent picture of the main cause of death in women by cancer in Chile, such as it was observed in 2018. Gallbladder cancer is the seventh more common cancer. Other types of tumor, such as lung, colorectal, and stomach, show higher incidence than gallbladder cancer. Again, these results reinforce the change in the gallbladder cancer incidence. How important is the cholecystectomy culture in these results? The cholecystectomy culture is the fact of operating all cholelithiasis irrespective of symptoms. This has been the way we have dealt with gallstones during the last year. Concerning the above, there are some questions to answer. Do we need to continue with this program, such as this done today? Second, do we need to evaluate symptomatology at the moment of considering the surgery? And finally, do we need to identify a special population with a higher risk to develop gallbladder cancer in whom cholecystectomy should be performed? One of the most important keys to identifying a high-risk population is to consider the ancestry. The main native population in Chile is the Mapuches. They were the people who were living in Chile in the south when the Spanish conqueror arrived in Chile in 1541. It has been studied that every 1% of Mapuche ancestry represents a 3.7% increase in gallbladder cancer mortality risk. In this slide, we observe the Chilean map and the influence of the ancestry on the incidence of gallbladder cancer. In the blue map, we observe the Aymara concentration. Aymara is another native population that lives in Chile. A higher concentration of this native population is seen in the north of Chile. In red, the Mapuche ancestry is observed. The major concentration of this population is seen in the south. Then, when we correlate the ancestry with the incidence of gallbladder cancer in gray, it is observed that the higher incidence of the disease and the concentration of the Mapuche population affects the same areas of the country. In this slide, a typical Mapuche lady using her ceremonial process is shown. Lorenzo et al. Investigating a large Chilean population harboring both gallstones and gallstones associated with gallbladder cancer population were able to identify a special group of patients. These groups different variables shown in the slide. Among these patients, the chance of detecting gallbladder cancer will be 1 in every atypical spectrum. By applying the above, we will be able to perform the preventive program more efficiently. Finally, as conclusion, we can highlight the following. First, the primary prevention is a difficult task. Obesity could have a role not only associated with the gallstone formation, but also in a more direct way in the development of bladder cancer. Because of the above, obesity management could have an important role in the bladder cancer prevention. Secondary prevention by performing cholecystectomy more massively could have had an important role in the decreasing incidence rate of the disease. In the future, we need to concentrate our efforts on selecting people at higher risk of developing the gallbladder cancer, and in this population to perform the cholecystectomy campaign. Thank you very much.
Can we have
Thank
Dr. Khandelwal?
Yes.
Khandelwal, please.
Yes. Thank you for the talk, Dr. JaVale. Well, we would like to ask the floor any questions from the floor. But before that, I would like to know what is the policy of your government right now? What is in practice? Is it advocating cholecystectomy in each and every young female, or it is selected? So let me know what is that.
Okay, well, first of all, I want to thank Dr. Kapoor. For me, it's a pleasure and an honor to be part of this Congress. And well, the program has not changed. So there is no change. And now we are evaluating the results. Because as I told you, we have observed a decrease in the incidence, but we are not sure that the total cause of the decreasing of the incidence is because of the program. But until now, we have not changed. And also, not only for the people between 35 and 49 years old. So we advocate cholecystectomy for those patients with gallstones. But the program, the guarantee program, is for people between 35 and 49.
So has there been any interim analysis about the costs, complications, and the benefits?
Well, about the cost effective of the program, we do not have up at present an evaluation. So evaluation was done, I think, 15 years ago when the program was beginning, and at that time was supposed to be cost effective. But at this time, I think we can be much more effective focusing the program in areas with higher incidence. For example, in the north of Chile, the incidence is low. So our idea is to focus in the south, where the incidence is higher.
You know, Dr. JaVale, why did Dr. Kapoor ask that? Because those patients who are asymptomatic undergo lab chole, some of them will certainly have some complications. So that is one point that we are discussing in India. The complications, though it is very low, in a symptomatic patient is probably accepted. But those who are asymptomatic and we are not sure whether we are preventing cancer or not, and if unfortunately they develop symptom, then that is bad for the patient. That is why this question was raised by Dr. Kapoor.
Yes, you are right. That is a very important point of view. So the incidence in Chile is about 0.25%. So I think we are within the range of a biliary duct injury that we observe around the world. Fortunately, most of the cases are done by surgeons in big hospitals. So we do not perform cholecystectomies in small or county hospitals. So Chile is a small country, so we can do the surgery in big hospitals.
Last query from my side, if time permits. have you worked on prevention? You said it is difficult task. I agree, but there are many researchers in India who are working to prevent the gallbladder cancer by finding some different causes, like some insecticide, pesticides, or some organic, some toxic products, something related which produces higher. Have you some experience or knowledge of such thing in Chile?
Yes, no, I think our main risk factor is the ancestry. So that is the most powerful risk factor, the ancestry. So that's the reason we focus on the south of Chile. But we have not observed any factor like you mentioned.
Yes. Any question from floor, Dr. Kapoor, you can ask.
Actually, Dr. Luis Martinez from Uruguay also is here. So I would like to request him to make some comment if he wants, because the situation in Uruguay must be more or less the same as Chile. Yeah.
Hi, good afternoon. Thank you very much for invitation. I am delayed because I lost in the city, in the old city of Jaipur. Excuse me for the delay. Xavier, how are you?
Fine, Luis.
It's very interesting for me to talk with you at the distance. Well, so I understand well, because we have in the Uruguay 20% of the female and 15% of the female of the male have gallbladder stones, but we have not your incidence. We have a very low incidence or low incidence of gallbladder cancer. Why is your explanation about this situation? Thank you.
Well, Luis, a pleasure to talk with you. Well, the explanation is because of the ancestry. So the gallbladder cancer in Chile is related to the ancestry. So it's very clear that for 1% of the ancestry, the chance of having a gallbladder cancer increased by 3.9%. So we have studied that, and that's the reason. And the same happened in Peru and Bolivia. So all the coasts of the Pacific coast show a higher incidence of gallbladder cancer, different with the Atlantic coast of South America. So like you say, Bolivia, Uruguay, and Buenos Aires.
Okay.
Only two, only one question. But the other side, in the last 10 years, we can see in Uruguay an increasing of the gallbladder cancer. It's not too much an increasing very quickly, but more and more increasing the gallbladder cancer and increasing the pancreas cancer. On the other side, we can see that the stomach cancer is very low now in Uruguay. So I think we have a situation of change, biological change of the oncology factors, yes, of the oncology factors in the east of the South America. You have any opinion about it, the change of the oncology factor in our country, in Uruguay, Argentina, maybe the south of Brazil?
Well, I think we have to wait for the data. So I think very important. We got the data from GloboCan, and well, if you observe that, I think it's very interesting to wait for the data.
Okay.
Thank you, Sabina.
So I feel happy that I could connect Uruguay and Chile through India. Thank you, Dr. Exawala. Thank you, Dr. Khandelwal.
Thank you. Thank you very much.
Thank you very much.
Thank you.
I would like to request everyone to step outside for a cup of tea. We'll be coming back at 4:15. Please. T. We will discuss deterministic theory of genetic alterations in biliary cancer. This discussion will be chaired by Professor V.K. Kapoor. Thank you.
Good afternoon, everyone. So we are in the last session of the final day, and we have a speaker from the US, from the Memorial Sloan Kettering Cancer Center, Dr. Ghassan Abu Alfa, who's a GI medical oncologist. So he's already sent his pre-recorded video. We will play the video first, and then Dr. Ghassan will join online for any audience interaction. Yeah.
Congratulations again, and again, thank you very much for the warm invitation. It's truly a great honor and a great delight to join you today, and I hope that it will be in person next time. I'll go ahead and share my screen, and you'll see that I'll be carrying on a quite a bit of a different perspective in regard to the deterministic theory in genetic alterations in biliary cancers. These are my disclosures, and these are my contacts. Please feel free to copy what you like or take a picture of the QR code. And as many of you know, I'm more than readily available to connect and to help discuss anything which is pertinent to a educational question, research question, or of course, a clinical care question. So with this said, the agenda is going to start with addressing the clues that bring in that deterministic theory that we were discussing. What is the data? What is the issue? What model are we proposing? And of course, what are the disruptions to the model? So in regard to the clues, we all recognize that biliary cancers is a collection of different malignancies that just end up being looked at and perceived to be the same simply by anatomical presence or connectivity to each other, which are the intrahepatic cholangiocarcinoma inside the liver, extrahepatic cholangiocarcinoma outside the liver, and gallbladder cancer. We know very well that those delineations anatomically have even further details that now we appreciate more. For example, we know very well nowadays that a even pathologic assessment on histology can give us a little bit of more clarity about where the tumor is coming from. And for example, we know here that a intrahepatic cholangiocarcinoma, based on location being peripheral, will probably have a further implication with regard to, for example, IDH1 impression. Not only the pathology was able to do that, but of course, radiologically, we could consider this as well. As you can see over here, this is a quantitative radiology features using AI. And as you can see, other than the tumor burden as we know it, we are looking at different other components like glucose consumption, bone marrow metabolism, heterogeneity, the shape of the tumor, the burden, and the skeletal muscle index, plus many others. And here I have to really be recognizant of the great effort and great thanks to Dr. Larry Schwartz, who was the chair of radiology at Columbia and will be joining us beginning of the 2023 at Memorial at the chair of radiology. Beside the pathology/histology evaluations, beside the radiology evaluations, now we do understand that even within the tumor itself, some specific components of the location can make a difference. This is a classic scenario of the occupational cholangiocarcinoma, if you recall, has been published many times, looking into the 1,2-dichlorohydropropane and dichloromethane at the printing factory and outlet cholangiocarcinoma. And you can see here, this really not necessarily to dissect that one specific, but it shows you how much even the intricate details of the tumor itself can really carry on different genetic alteration evaluations that we don't know yet how to interpret them all, but ultimately will make probably quite a difference in regard to the care of the patients. At least for now, next-generation sequencing has been able to delineate for us quite a bit of malignancies. This is beautiful work from Dr. Kao, and there have been many others by many groups, among which some of you are in the audience. And as you can see here, at least as an exercise, the comparison between China and the US in regard to the cholangiocarcinomas show you very clearly that yes, to some extent, the tumors are almost the same, but there are some differences. And I'm only pinning down over here, for example, the KRAS alteration that really appears to be more prominent among the patients in China, but interestingly, the IDH1, which is more prominent among the patients in the US. Not only that, but we know very well there is a certain mutual exclusivity regarding the genetic alterations. You can see over here, and this is nice work that was done here at Stone Kettering, that after all, if a tumor is IDH1 mutated, might not necessarily have FGFR2 fusion or vice versa, even though there are exceptions, and we have seen some very rare occasions that these tumors can occur, or these genetic alterations can occur together in the same tumor. So I kind of gave you a snippet of different things, and really it's not meant to give any conclusion, but simply to tell you that we have clues that are coming from different directions, but we are not able yet to put it together. And this has actually become a challenge in regard to the data that many of you know that I'm going to go through to only illustrate one more time the challenge that we all have. This is, for example, the Biliary study that probably we led all over the world, looking into ivosidenib as an anti-ADH1 therapy versus placebo. And it showed a clear improvement in survival after we look at what's called drag-preserving statistical analyses. The reason why we did this way, because the study with the genetic alteration in support of the patient advocacy was to permit patients on placebo to cross over to the ivosidenib arm, and as such, OS will be very difficult to assess. So PFS was the primary endpoint. However, if we did a drag-preserving analyses that will pretend as if the patient never crossed over, we'll be able to deduce a certain overall survival data. And as you can see here, it was 10.3 month median survival for the ivosidenib, and at the same time, it was a 7.5 month for the placebo, which, however, worsened all the way to 5.1 months for the placebo on the PRSFT revised statistical analysis. And as such, we have 10.3 months versus 5.1 months, great positive results. Fair enough, we're happy about that. The challenge was a little bit more complex when it came to the anti-FGFR2. This is BGJ398, a great effort, give great credit to our dear colleague, Dr. Milan JaVale, who led on it, and we were all part of it. As you see, incredible responses, incredible PR and stable disease. This actually led to the evaluation of what became called infigratinib. Interestingly, though, the infigratinib was pulled out of the market because of really a certain, business decision of the sponsor, especially with the advent of so many therapies the first time, where their aspiration was to begin with. Another anti-FGFR2 therapy beside the infigratinib is pemigatinib. Again, we proudly led this all over the world, and you can see over here an incredible, including CRs with 35% response rate, and of course a pretty robust PR of 32% or so, with a continued response rate of about 35%. Not only that, but we found that actually the patients with the anti-FGFR2 specifically targeted against a fusion fared the best, with the median survival of 17.48 months, as you can see in blue. Some other alterations, 6.7 months, and for no alterations, 3.98. Again, speaking very loudly here and clearly that a anti-FGFR2 against FGFR2 fusion is the one we will benefit the most. Looking into who are the patients with FGFR2 fusions, you can see over here that interestingly, their benefit of targeting it in second-line therapy will be best. In other words, like treating as second-line treatment for the anti-FGFR2 therapies will probably fare very well for the patients, as you can see over here with the use of pemigatinib. And then the story goes on and on and on. We have different other anti-FGFR2. One of them is darzatinib. Interestingly, some probably potential asset of value against mutation and all diffusions. We have the futibatinib, which was proudly approved lately by the FDA in second-line therapy. Great work led by our dear colleague, Dr. Lipika Goyal. Congratulations on that as well. And of course, you can imagine there'll be on and on choices. Already I mentioned at least about the FGFR2, the ifigratinib, which already has pulled out, as we said, pemigatinib. We mentioned the derazantinib. We mentioned the futibatinib, and of course, there would be others that already are in the works as well. So what's the issue? The issue is like who's who. And interestingly, not only that, but if resistance would occur, what will occur? This is superb work by Dr. Lipika Goyal and colleagues that looked into patients who had anti-FGFR2 therapy, and their tumor actually progressed with time because of a change in the alteration. They were able to biopsy before and after the progression, and they were able to find like the potential gatekeeper tumor genetic alterations that will lead to this resistance to the therapy. And by the way, this is not only done in about FGFR2, nice work that was done at Sloan Kettering by my dear colleague, Dr. Harding.
Powering off.
It's a look into IDH1 and IDH2. And you can see here, for example, was ifosadenib, as you can see in red. The minute we kind of like, had some potential resistance, IDH1 dropped down, and now IDH2 went up. The question is, how does this happen? Is this a random issue that a certain genetic alteration will change from the certain genetic specific next-gen sequencing alteration of FGFR2 to another, or is it a deterministic component per se? So I'll share the model with you and see what we all think together. And I'll give you as a pretext to that the well-known development of the vasculature around tumors. As we all know, these blood vessels are kind of done rapidly. They might be even immature, and this will already become a target for anti
can think in terms of some possible collaboration. So my question is very practical, that what kind of biomaterial is required for these studies, so that my younger colleagues can try to link with you and see whether some collaborative work is possible.
Thank you very much, Dr. Kapoor, and good afternoon to everybody. This is no doubt, and the aim is not to really fascinate about science. And to be fair, I respectfully will also defer that I'm not really the scientist that really can tell you all about the chaotic theory and deterministic component. However, with this said, I think the obligation that we all have, and I love your question because exactly this is a point of showing that effort, is to really provide the data on patients with FGFR2. What was the FGFR2 genetic alteration that occurred to begin with? What kind of therapy they did get as anti-FGFR2, and what FGFR2 result came afterwards? There are many ways of doing this. Option number one, if for whatever in the ultimate world you have the biopsy before and after, that's one option. And if you have the biopsy and you already tested for genetics, that's even perfect. We don't need material then, we just need the data. Number two, if you have only blood before or blood or biopsy in the beginning and blood after, this also can be helpful. And if you have genetic sequencing on it, of course, we're happy to get the data. And lastly, if you have the biopsy to start with and blood or biopsy at the end, but you don't have any data, we're happy to work with you, same way we already did with the HCC, and we can obtain the material from you, do the genetic analysis for you, return the material to you, and then we will do in the mathematical formulation that we're working on. The work is all being done, of course, like everything else we do, collaboratively with one of our mathematicians, Professor Alan Tenenbaum, and simply we're looking at math over here. We simply need results before, results after, and then we'll be able to build the story that we can see. For example, a patient received with pemigatinib, let's say, as a first-line therapy, this time will, for example, futibatinib will be the right therapy, but more importantly, can they go back to pemigatinib at some point in time because the resistance caused one more time coming back to the same genetic alteration?
Thank you. Thank you. So I think some of my young colleagues who are here or online, if they get interested to take it further, they would definitely contact you. And I'm sure my group, my younger colleagues in clinical medicine as well as in oncopathology would probably try to. The only hurdle I have faced in past is the very elaborate and very strict legal issues in the US for import of biomaterial.
Yeah, no, thank you. This is a very important point. And we were able to cross through this beforehand. We do appropriately what's necessary. I give a lot of credit for India for really making sure do what's right for our DR patients in India or wherever they are. And of course, respectfully with the same regulations, but we were able to successfully do it in liver cancer. And of course, we can do it again in regard to biliary cancers. And I don't know if everybody see the chat, but I know I put my contacts in the beginning, but I'm putting again in my chat my email, but I'm sure your respectful committee can provide my contacts to anybody who would like to help and connect with us.
Thank you so much. Thank you so much, Dr. Gasson. Thank you for joining.
Thank you.
We'll move on to the next and the last presentation of the day by Dr. Hoptran Kao from MD Anderson. Manmohan, please.
So we'll move on to the last session of the day. We will be discussing new adjuvant therapy in HPV cancers, which will be chaired by Dr. Vineet Gupta, who is a Senior Consultant Head, Medical Oncology and Hematology at Sakra World Hospital, along with Professor V.K. Kapoor. Thank you.
Dr. Vineet is online. Can you please check? Dr. Vineet Gupta? No? Okay, I think we can play the video. I'll in the meantime check whether Dr. Vineet Gupta can. So, Dr. Kao, we'll play your video first, and then we will request you to come online. Yeah.
Good afternoon. My name is Hoptran Kao. I am an HPV surgeon, surgical oncologist. at MD Anderson in Houston, Texas. I specialize especially in the treatment of primary liver tumors, and it is my absolute pleasure to join you today. Thank you for the invitation. I'm sorry I couldn't be there in person. I certainly hope to be able to take part in this surgical festival in the future. I have no disclosures. As a surgical oncologist, there is no greater frustration than to encounter the kind of scenario that I'm about to describe to you. Here's a scan of a very nice gentleman who came to me with a large tumor in segment 6 of his liver. It was an intrahepatic cholangiocarcinoma. We take him to the operating room. We do a right hepatectomy with lymph node dissection. He did very well post-op. His pathology shows an 11-centimeter tumor with microcytolysis, but margins are negative. And the 14 lymph nodes that we recovered from the lymphadenectomy all were negative. He went on to receive adjuvant capecitabine, but unfortunately, at 6 months following surgery, his scan demonstrated disease recurrence in both the liver and in the lungs. Now, whether this represents futility can be debated, but there's no question that early recurrence is an undesirable outcome and a marker of poor prognosis. And increasingly, we need to lean in and learn from our experience with pancreatic cancer, for which a neoadjuvant therapy approach is well established by now. In fact, in pancreas cancer, borderline resectability is no longer defined solely on the basis of anatomic consideration, but instead, it's also considering tumor biology as well as patient physiology. The rationale for using neoadjuvant therapy, even for resectable tumors, can be listed here. There is a potential for tumor downsizing, which may or may not translate into a greater chance for R0 resection. There's also the ability to provide early systemic therapy for occult metastatic disease. Importantly, it helps in patient selection, because we want to find out who are the patients who truly stand to benefit the most from some of these operations that we perform, which can be very morbid and can affect the quality of life of the patient. And so by allowing for us to have this treatment window to assess the disease biology, we help in improving patient selection. But also it's important to know that there are biologic correlates that we can draw from the neoadjuvant experience that can then be ultimately used to predict and prognosticate. In the case of immunotherapy, a specific advantage of giving immunotherapy in the neoadjuvant setting comes in the form of more effective immune system priming, thanks to a richer source of neoantigens in the primary tumor and an intact local regional immune system and environment around the primary tumor when you have intact lymph node drainage system, for instance. And in neurosurgery, for instance, there is clinical evidence of greater efficacy of immunotherapy in the neoadjuvant compared to the adjuvant setting. And the interest in neoadjuvant therapy for GI cancers is growing by the day. Just this year at ESMO, there was an entire session dedicated to the topic of neoadjuvant therapy in GI cancers. And if you search on PubMed, for instance, neoadjuvant and liver tumors, you're going to see there's been a steady increase in the number of publications on this topic over the last few years. So let's take a deep dive into intrahepatic cholangiocarcinoma, for example. Professor Tim Pollack and his team recently published in JAMA Surgery in 2020 a very elegant study where they looked at predictors of very early cancer recurrence after surgery for intrahepatic cholangiocarcinoma. And very early recurrence was defined as recurrence of disease inside 6 months of surgery. And they found that large tumors, multifocal tumors, those with node-positive disease or positive margins at the time of surgery, tended to have very early recurrence. And in turn, very early recurrence was associated, not surprisingly, with a much worse survival than patients who did not have very early recurrence. This therefore begs a question for this subset of patients who have more aggressive or high-risk kind of disease. Might an alternative treatment approach be necessary to achieve improved outcomes? So we looked into this very question and reviewed our own experience at MD Anderson with neoadjuvant therapy for intrahepatic cholangiocarcinoma. Amongst this cohort of 45 patients, 60% just about had high-risk features, the features listed in the slide before, and 33% had initially unresectable disease. The vast majority, if not all patients, received gemcitabine and some kind of a platinum drug. And you can see that the median overall survival in this cohort was a remarkable 45 months. Certainly, we have to acknowledge that there's a selection bias involved here. In other words, these were patients who were able to get through that neoadjuvant therapy and get through surgery. But this benefit of a neoadjuvant therapy approach in better selection of patients certainly has been shown also when you look at the national landscape. Here we did a propensity score matched analysis of the National Cancer Database, matching patients who received neoadjuvant therapy versus upfront surgery for intrahepatic cholangiocarcinoma. We matched them across a number of factors, including those reflective of disease biology when available. And you can see that the line in red, it represents neoadjuvant therapy, and neoadjuvant therapy is associated with a survival benefit compared to the patients who got upfront surgery. And this benefit bore out when you looked at a number of sensitivity analyses that we performed to support the role, certainly, of neoadjuvant therapy. So as a surgeon, I always kind of think back about what it is that we as surgeons can do in the treatment of cancer. We are oftentimes, we must be more than just a technical, more than just a technician. We represent the point of access for patients deemed to have localized liver tumors. And all those, surgery certainly remains central to the management of these tumors. It must be pursued in the context of disease biology. It is incumbent on surgeons to investigate the factors that can predict surgical failure and to take part in designing a better treatment strategy forward. Indeed, technical resectability does not always mean surgery first is the way to go. And therefore, it is important that surgeons be fully engaged in the design, the conduct, and the success of perioperative trials. For the next few slides, I hope to share with you some of the clinical trials that we have engaged in at MD Anderson or will be opening soon in this perioperative space for primary liver tumors. The first study I want to share with you is the NeoGAP trial. This is a phase 2 study, a multi-institutional study that completed accrual late last year and reported our early finding at ASCO this year. In this, 30 patients with high risk but resectable intrahepatic cholangiocarcinoma, defined as having large tumors greater than 5 centimeters, having vascular invasion, multifocality, or cytolysis limited to one lobe of the liver, or suspected nodal disease, were then treated with 4 cycles of neoadjuvant gemcitabine, cisplatin, and Abraxane. Our primary endpoint of feasibility was met as 77% of patients were able to complete neoadjuvant therapy and go on to have surgery, and the rate of disease control was 90%. We look forward to reporting long-term outcomes of this study in years to come. Now, many of you know about the TOPAZ-1 trial, which recently established durvalumab with gemcitabine and cisplatin as the new standard of care for advanced biliary tract cancers. And the findings from this study portend well for an upcoming trial, which we've been working on for a couple of years at MD Anderson and will be accruing soon, of perioperative pembrolizumab and gemcitabine and cisplatin for high-risk intrahepatic cholangiocarcinoma. Finally, I want to talk to you about a neoadjuvant immunotherapy trial that was spearheaded and led by Dr. Ahmed Kassab at MD Anderson, a single institutional study, an open-label phase 2 trial of perioperative nivolumab alone or nivolumab with ipilimumab for resectable hepatocellular carcinoma. This study had patients Randomized into these two arms, they would get their neoadjuvant immunotherapy followed by surgery, and then up to 2 years of adjuvant nivolumab, and for the arm that also received ipilimumab, up to 4 doses of that drug. The primary endpoint was safety and feasibility, and the secondary endpoints are listed here and included overall response rate, path response, recurrence-free survival, overall survival, as well as a number of exploratory endpoints like biomarkers and immunologic markers. Let's jump into the results. You can see our primary endpoint, safety and feasibility, was met as no treatment-related toxicity led to cancellation of surgery. In fact, nearly all grade 3 or 4 treatment-related toxicity occurred during the adjuvant therapy period. When we looked at overall response rate by RECIST criteria, you'll see panel A represent nivolumab, panel B, nivolumab with ipilimumab. A couple of highlights here. 23% of patients, so 3 out of 13 in the nivo arm, had a RECIST criteria partial response defined as greater than 30% size reduction in their tumors. On the other hand, on the nivo-ipi arm, none of the patients achieved that marker of radiographic response. Based on pathologic response, 3 patients in the nivo arm achieved major pathologic response. All 3 had RECIST criteria response. 2 patients in the arm had a complete path response, and 1 had greater than 70% tumor necrosis. Interestingly, none of the 3 patients in the nivo-ipi cohort, again highlighted in the salmon color bars, achieved RECIST criteria tumor shrinkage. In fact, one of them even had enlargement of the tumor, and yet all 3 had path complete response. Now, taken all together, what this tells you is that immunotherapy, whether it was nivolumab or ipi with nivo, achieved a 30% rate of major pathologic response and 25% rate of complete pathologic response for hepatocellular carcinoma. And if you were able to achieve major pathologic response, there was no recurrence of disease at 2 years. Compare that to a 50% rate for patients who did not achieve major pathologic response. When we did correlative studies looking at kind of immune markers, you'll see that compared to baseline levels and also compared to patients who had no major pathologic response, those who did had an increase in the number of effector T cells, including CD8 plus, CD3, as well as those cells expressing PD1 and PDL1. Mass cytometry confirms this increase in tumor infiltrating immune cells and an increase in the effector to regulatory cells ratio. Again, patients who achieved major pathologic response seen in red here compared to those who did not achieve major pathologic response seen in blue. You can see that there was an increase, a marked increase in panel D of effector activated CD8 T cells compared to baseline. Conversely, panel E shows that for patients who had no major pathologic response, there was an increased cluster of CD68 myeloid cells expressing an immunosuppressive molecule called VISTA. Finally, when we performed gene expression by nanostring analysis, we found, again, a higher baseline expression. This is interesting. In the nivolumab arm, the top part of the panel, what we find is that there was at baseline for the nivolumab arm, a higher expression at baseline of CD45 cells, natural killer cells, and T cells compared to amongst patients who had major path response compared to those who did not. Treatment with nivolumab did not lead to an increased expression of those cells compared to baseline. On the other hand, panel B, the second panel down here, for patients treated with nivo-ipi, there was no baseline difference in these cells, but for patients who experienced major pathologic response, treatment with nivo and ipi led to an increased expression of these T cells and natural killer cells and CD8 cells, something that was not seen in the nivo arm. And this suggests and supports an immune priming role of CTLA-4 antibodies. So those are 3 studies that we were involved in at Anderson for primary liver tumors. And kind of goes to illustrate to you just how important it is for us to explore this space. Surgeons, no doubt, play a critical role in the treatment of primary liver tumors. But the current surgery first strategy may not be appropriate for all patients, even when they come in with seemingly resectable tumors. The role of neoadjuvant and perioperative therapy for primary liver tumors is growing, and it is important for us as surgeons to collaborate with and to take part in the successful design and conduct of clinical trials in the perioperative space for primary liver tumors. I thank you very much for your attention. I thank you so much for the honor of the invitation, and I look forward to any questions that you may have. Thank you so much.
Understand and appreciate the role of neoadjuvant treatment in locally advanced, possibly unresectable cancers, because neoadjuvant treatment may make it resectable. Our worry is that if we do it in a definitely resectable or obviously resectable tumor, and because of whatever reason, either toxicity, dropout, in India, financial reasons, the patient doesn't reach surgery, then we have lost those resectable tumors. I'm sure you would say that if they were not going to show response to neoadjuvant treatment, they were anyway bad tumors. But how do we solve this issue? That's the main concern of most of the surgical colleagues.
Yeah, well, good morning or good afternoon. Thank you again for having me. Appreciate it. I will tell you that those are very fair questions. Those are very practical questions to consider, right? I think that the argument I would make is not so much for those tumors that, let's say, have low risk features. In other words, single small tumors. They don't have a markedly elevated tumor marker like a CA19-9. They don't have nodal disease, okay? For those tumors that are straight, low risk features, I would argue that an upfront surgery approach may be very reasonable. And I think that's a very fair thing to do. The question to me is, just like the scenario I showed you at the very beginning, the very first case that I showed, which is when you have these tumors that are, in fact, higher risk tumors that are very large, that may on CT scan have microsatellitosis or may have enlarged lymph nodes or major vascular invasions. You can certainly put them through an operation. Those are technically resectable, just like that case I showed you. But the problem comes in the form of very early recurrence. And if you commit them to that operation, that is time during which they cannot get systemic therapy, right? During which, a potentially systemic disease already is being treated with local therapy. So I think that there can be judgment exercised as to which patients really stand to benefit from surgery first, and which one should be given the option of getting systemic therapy as an early treatment of what likely is early microscopic occult metastatic disease. And I think that's the main difference. I completely acknowledge that it's not always possible, but I'll draw a parallel, Dr. Kapoor, to the experience with pancreatic cancer. It used to be thought you're losing the window, right, of resectability. But if the disease progresses so rapidly that you're losing out the option of doing surgery, which, by the way, is almost never local, it's more systemic, then you've really spared that patient an operation that was not going to help in the first place. So I think that's why we need to start shifting our thinking a little bit beyond just saying, can I cut this out? It has to be, can I cut this out? And will that help the patient from a cancer standpoint?
No, I agree that a patient who progresses was anyway bad candidate for surgery. My worry was dropout because of toxicity of the needle.
That's also a very good question. And I think that's why it's important to work closely, very closely with your medical oncology colleagues. Like in the trial that we showed in terms of immunotherapy, for instance, tends to be very well tolerated. And there was very little, there was no patient who fell out because of toxicity. That said, that's absolutely true that some patients don't do very well with chemotherapy. Then you need to have very good open communication with your medical oncologist, work together and say, let's see how they do with this chemotherapy. And let's see, if something happens, we'll need to change course. It's also important to remember that some of this chemotherapy or systemic therapy that's most effective is going to be better tolerated in the neoadjuvant before the patient has been submitted to an operation rather than the adjuvant setting. So I think that's another piece that we can't forget, right? But points very well taken, absolutely.
Is Dr. Vineet Gupta online? So I think we will thank you once again for your presentation and for joining online. Thank you very much. Thank you.
Thank you, sir.
Our mind that there are non-medical delegates also. So the prize we had kept was a surgical book. We will think and we will see